I'm also a board member of the American College of Medical Toxicology and an associate professor of emergency medicine and medical toxicology at Emory University in Atlanta, Georgia, and at the American University of Beirut in Lebanon. It is my honor to welcome you to the beautiful city of Istanbul. I also want to share with you that I am one more affiliation, that I'm also the assistant medical director of the Georgia Poison Center. So not to forget, I have many affiliations, so please apologize for forgetting one. And Georgia, Tbilisi, Georgia. So welcome to the beautiful city of Istanbul. This meeting has been a lot of hard work and passion for toxicology on behalf of Minatox and as well as on behalf of the Emergency Physician Association of Turkey, that I thank sincerely for their support and their coordination and collaboration. I want to thank Dr. Bashar Jandar, Dr. Mohamed Gul, and Dr. Bashat Al for their staunch support to medical toxicology in Turkey and in the MENA region. Today you are participating in a course that is very dear to my heart. The course is titled Bridges Between Clinical Toxicology and Public Health. I selected the title very carefully because Istanbul is the sign and symbol of bridges between different cultures, between different continents. And I could not find a better title for this course today to really embody what we believe in as toxicologists. Medical toxicologists are also bridges. We are bridges with clinical medicine. We are bridges with public health. And I belong to a training school through my mentor, Dr. Ed Kilbourne at the CDC, and others as well at the ACMT and then the Georgia Poison Center, that really believe strongly that medical toxicologists are essential in the public health response system or the public health structure. So you are going to hear about all of these various aspects today in this program that we put together carefully. We are short on time a little bit. We are also going to be joined by the World Health Organization, Center for Environmental Health Action from Jordan via webinar, as well as by a colleague from New York City, New York in the afternoon. So we will have some online juggling to do, but we already tested it out this morning, and I think it's going to work out. I want to thank our sponsors, Toxins, which is represented by Ms. Lucy Schiffelbein here, Randox, as well as Response System International, and Integral Global Consulting. Please make sure you stop by their booth and say hello to them and thank them for their support. Without any further ado, I would like to move on to the next, our first presentation by Dr. Edwin Kilbourne. Dr. Edwin Kilbourne is my mentor. I met him in 2003 when I joined the fellowship at CDC Emory Georgia Poison Center. Dr. Kilbourne is the one that really instilled in my heart the importance and love for public health and injury prevention. He taught me a lot of public health principles that I use every day in my practice and in my career. I've asked him to talk about his career, his journey. Dr. Kilbourne, before retiring in 2005 from the CDC, had spent around almost 25 years at the United States Centers for Disease Control and Prevention as a Public Health Service Corps member. He is probably the pioneer of clinical toxicologists in public health. And his career is illustrious and marked by several key investigations that he led that really prevented thousands of injuries and death. He is going to share with us today his experience. He's speaking today as an adjunct professor at Emory University, Department of Emergency Medicine, although he also works currently with another company called Leidos. Dr. Kilbourne, thank you again for being here with us, and we look forward to your presentation.
Good morning. Ziad, I'm pleased to be here. I think we probably got more from you than we ever gave you. But that doesn't matter. I'm pleased to be here. I want to thank the sponsors, and I want to thank you in advance for your attention today. Dr. Kazi asked me to speak about my career, and I found that, at least as far as I'm concerned, I'm not as so terribly interesting. Can I have the first slide, please? Oh, I do it. Who do I point it at? Okay. Right. You know, I've had unusual luck in an unusual period of time when public health was changing and the world was changing in a way that brought toxicology to the foreground. And I've had opportunities not available to everyone, and I think that's part of what I've been able. That's been an enabling factor to help me do what I want to do. But let us pay attention. I cannot speak about the development of toxicology, clinical toxicology, in all of the countries of this area of the world. And so I'll confine myself mostly to how clinical toxicology developed in the United States. Let's go to the next slide, please. Oh, I have the, sorry. Oh, my luck. The location and time, the U.S. following World War II was a very vigorous economical economy. I was in the generation that's known as the baby boomers. There were a lot of children born after the war. My father was also a respected physician scientist. He worked in infectious disease and worked specifically on influenza vaccine. And I often think of him as issues come up these days with influenza and what he would have done and how interesting he would have found it. I had a couple of illnesses while a child that required specialty care, and I went into New York City from the suburbs of New Jersey frequently, and I came into contact with hospitals, and I found them to be fascinating places. I also went to my father's lab, and I think I was stimulated there. I had excellent mentorship, and I had excellent students, like Dr. Ziad Kazi. In the course of my career, I've been influenced by such people as Dr. Sir Richard Dahl, the well-known British epidemiologist who died in 2005, I'm sorry to say. Dr. Clark Heath, a famous cancer epidemiologist, Dr. Henry Falk, who discovered the link or had a major part in discovering the link between vinyl chloride and cancer. Dr. Stephen Thacker, who is well known at CDC. He died young, and various parts of the CDC are named after him. And as I said, I have had great students and people to work with me. Now, if you go through clinical medical toxicology in the United States, you find really that the first impetus for it occurred in the 1950s. And that was because the war stimulated, we were running low on latex, for instance. And so various forms of rubber were being tried. A substance called neoprene was developed instead of rubber for tires. But the chemical industry just went really forward in great leaps and bounds. By 10 to 15 years ago, the numbers of known and frequently used chemicals in industry was in the tens of thousands, close to 100,000. The number of compounds that had been synthesized, developed, or reported on was in the millions, 6 or 7 million. And the American Chemical Society has a registry by which they keep the numbers. So it becomes a very difficult field when people are being exposed to all sorts of things. And so it was with increasing complexity that pediatricians, particularly because children, well, I remember having very young children. They'll eat almost anything. And you can, and any poison center knows that, that so many of the calls are about children and what they ingest. Many of the more serious cases are related to adults because sometimes their motives are suicidal or towards self-harm. That's infrequent with the children, of course. In the 1950s, there were literally hundreds of poison control centers. It became a popular thing for every hospital or healthcare institution to have this as something that would make add luster to their prestige, add something. But there was really there was little, if any, quality control at that time. And there wasn't a process for evaluating. There was no certification. Also in the 1950s is when Dahl, who I think read medicine in the 1940s, started to get results from the British physician study. And one of the things he looked at was smoking. And it started to come out that there was an association with lung cancer. Dahl's work was was pivotal in terms of the United States response when Surgeon General Luther Terry made the announcement that lung cancer and smoking were associated. Of course, we know now that smoking tobacco is associated with many, many health conditions, but this is certainly one of them. So I believe it was for that and in his related work that he was knighted by the Queen of England. 1958, people started to be concerned with cancer, and there was some legislation which was not given great importance at the time, but it was called the Delaney Clause, and it was added to a piece of legislation regarding our Food and Drug Administration, saying that the FDA could not allow any known carcinogens to be in food. So this is a time in the 1950s of many chemicals starting to realize the problems of chemicals and what they represented for public health. So the precise words, I believe, are the Secretary of the Food and Drug Administration. That is odd because it's called the Commissioner of Food and Drugs, but perhaps that came later. Shall not approve for use in food any chemical additive found to induce cancer in humans or after tests found to induce cancer in animals. The problem with that is that as chemistry progressed, it's hard to say, it became harder and harder to say that there was nothing, not a single molecule of a carcinogen in food. If you think about it, foods are very, very diverse group of chemical substances. And so to swear about that, you have to be a very, very good chemist. You can't actually swear that I have not put in anything that is chemically a problem. So as chemistry became better in response to the synthesis of new chemicals, we really didn't know, and it was hard to follow the Delaney Law. In United States jurisprudence, there is something called a de minimis exposure. De minimis means that it's such a small thing that we're not going to pay it any attention. And ultimately, that was a concept on which low-dose exposures were regulated, such that if you have a risk for some additive ingredient in food that is less than 1 in a million in a lifetime by estimates, or perhaps 1 in 100,000, that you might, that could be called de minimis, meaning it's not big enough to worry about. And that is a legal concept, that is not a health concept, but we developed it into a whole new area of public health and medicine, in toxicology. So let's move along. We'll return to Delaney. Clinically, in the 1960s, poison centers and clinicians continued to struggle to treat an ever-growing spectrum of causes of intoxication. The chemical industry was off and running and was extremely successful. Pollution became a problem because there weren't definitions of pollutants, and there weren't clear-cut rules about who could dispose of what and where they could dispose it. The US government tried to assist, at least the clinical side of the equation, by providing sets of reference cards on particular toxicants. And these made their ways around. I talked with my colleague, Dr. Barry Rumack, who is old enough to have practiced during that time, and who told me that the cards were usually one set per hospital, that frequently the cards, they were meant to be easily replaced when they were lost, and they actually migrated to patients' charts, away from the set. People would mark them up and so forth. So public health had developed further by having fewer poison centers recognized as, they became recognized as a critical public health resource. But the problem of funding started to emerge, and it continues to this day in the United States. Dr. Rumack, I believe he made a great deal of money, but he managed to get consumer product data, including proprietary formulas, and to put them in a database, which became widely used as computers became available also in the 1960s, were available to medical toxicologists. Sorry, I was going to say next slide. Yes. The 70s, the same trends continued. Certification of clinical toxicologists became an issue, and I think the early, I guess what we call now the first board in the United States started to function, and Paul Wax and Chuck McKay are here. Is that approximately the right date? In the 60s, or was it the 70s? 60s, okay, good. In public health, our air in big cities had become so polluted that President Richard Nixon, who's a Republican, who's not, not typically the party that is seen as safeguarding the environment, actually created the EPA by an executive order, which was later confirmed by the Occupational Safety and Health Act, the OSH Act. Poison control consolidated even more into fewer but much better centers. And the quality control of poison centers became a concern and started to be addressed. US public health agencies began to study with this began to have to deal with this Delaney concept. But it was a difficult area. How much are you going to absorb? Well, in FDA, if you have medicine or food, USDA safeguards food, EPA, the environment, how much, if it's in the soil, how much dirt gets in people's mouths? There were really no data at that time to really help move that study along. That's since been addressed, but slowly. And CDC got into the act, especially with regard to Love Canal. The Love Canal incident changed the country. It led to legislation that created the so-called Superfund. In other words, a way to clean up some of these dumps where people had just left all sorts of chemicals without regard or any thought for future contamination, the likelihood of very toxic chemicals getting into groundwater, whether those chemicals were toxic or what. So in the 70s and beyond, risk assessment became an important area, mostly done with animal data, which of course raised the question of how similar humans are to animals. For instance, even in mammals, we don't all have the same organs. There's a distinct area of the mouse, I believe, called the forestomach. If the forestomach, which we don't have as humans, generates a tumor after exposure to a certain chemical, does that count? Does that make sense? How much is de minimis? And how do you estimate that from animal data? How do you even treat the animals? Animals with, such as mice, with I think a 1.5 year lifespans, rats with 2.5-year lifespans. How do they compare with a 70-year lifespan of a human being? The area of animal extrapolation, full of theory and not much data, became a very important concern. So that remains an issue and an area for study. Poison center quality remains an issue, but the American Association of Poison Control Centers has developed criteria to review poison control centers to see if they're adequately staffed and can provide information that's adequate to the public and to physicians or other healthcare professionals that come in. So that's an issue of which we should be proud, and we are proud because of the concerted effort of toxicologists. There are not very many of us that are clinical and see patients, but we're scattered throughout the country. But we come together and we make these kinds of decisions, and it's an important aspect of the way we function. Public health surveillance of intoxications began in a really meaningful way in more in the late 1990s, the early 2000s, and continuing to this day. The Superfund legislation took a lot of money, and right now that is ratcheting down. On the other hand, the most severely contaminated sites have been addressed. They're not necessarily clean, but there are rules for disposing of hazardous waste now, and they're under the Resource Conservation and Recovery Act, as we call it, RCRA. It's not a word, it's just a bunch of letters. But those are the initials of that legislation. So let me conclude. Where we're going, both as clinicians and in terms of public health, is in a pathway that is coming together. When I got my certification in medical toxicology, I wondered if it was even appropriate, because I thought of medical toxicologists as seeing emergency patients. They're, the patient comes in, they're unconscious, the skin is wet, the skin is dry, the pupils are big, the pupils are small. What is the toxidrome? How do you think through this case? And that's not something I had been doing. I had been looking at outbreaks, and we'll talk more about outbreaks later in the week. And so I'm not going to address it a lot today, Ziad, I'm sorry. But also I see that my 20 minutes is up. So perhaps I should stop talking. But clearly what we do in public health affects what the clinicians do, and vice versa. I found that when I was in government, to work with Dr. Paul Wax, who I see over there, and others in the American College of Medical Toxicology was tremendously beneficial. And I think and I hope that when I served on the board, that tests U.S. physicians for competence in toxicology. I did push, and Paul will remember this as well, for knowledge of public health and the importance of public health such that it's become embedded as part of our culture now, our professional culture. Anyway, I thank you for your attention. I look forward to seeing you later in the week. I'm pleased to be the lead-off speaker. My gosh.
That's a tough job.
It's an honor. Okay.
Thank you, Dr. Gilmore.
And I'd be pleased. I don't know most of you, but I'd be pleased to meet you as we go through the week, and thank you very much.
Thank you, Dr. Gilmore. As well as fellowship trained in clinical toxicology. He's a regular supporter and staunch supporter of Minatox, and is going to talk to us a little bit today about the poison centers, the U.S. model for poison centers and public health.
Good morning, everyone. It is an honor once again to be with you and participating in this great conference. Dr. Kazi has been very instrumental in getting me involved in these conferences, and today I'm going to be speaking about the involvement of poison centers in public health. As you heard from Dr. Kilborn, it started with physicians who were very much involved in identifying public health concerns, and then it was the role of poison centers to execute on some of these. Now, I've been blessed that I've been part of an organization that has been very much integrated into public health. And so as soon as I get my slides rolling, will it show up on this screen? No. Okay. So I've been very fortunate that the program that I work for has been very much involved in public health. And so just a little bit about me. You heard Dr. Kazi talk a little bit about me, but I am trained in pharmacy at the University of California. I went ahead and did extra training in toxicology, and I have been working in the same poison center since the late 80s. So with 32 years of experience, I've been able to see our program develop. Now, just to let you know, I don't have any conflicts, but if you're unaware of where Atlanta, Georgia is, this is where I am based, is in Atlanta, Georgia, and my state is one that is My state is one that is, it has over 10.5 million people. We were a brainchild of a pediatrician. You heard Dr. Kilborn talk about pediatrics being the primary patient pool, and it was very much that that a pediatrician wanted to figure out a way to get information to his residents, because these were the most common poison cases that we were getting. The key for us was in the mid-'80s, where our health department, public health, said poisonings are a public health concern. It was one of the very few poison centers early on that had an established relationship with public health. And so with public health recognizing that this is a concern, the health department not only designated us, but they also started giving us money. You heard Dr. Kilborn talk about money as being an issue, and when you're talking about hundreds of poison centers that started when this whole program began, now we are down to just a very small few poison centers, and I'll show you those numbers in just a bit. So in my particular poison center, you know, we've grown tremendously since I've started. And so just a little bit about us. We're one of now only 55 across the United States. At a time when the early 70s saw poison centers proliferate, just in my state alone, there were over 200 people that call themselves poison centers in the state of Georgia. But the state public health recognized we need to centralize these programs and designate only one center to cover our entire state. The staff that we have consists of nurses, pharmacists, and physicians. And when you talk about the kind of call volume that we have, nationally across our country, over 2.5 million poison exposures have been reported and collected. And in Georgia alone, we are recognized as the second busiest poison center in all of the United States. So up to 350 human exposures are called into my center alone. A good majority of those, nearly 9 out of every 10 calls, comes from the average person, not a healthcare professional. And certainly the ones that are, the cases that are most difficult are the ones that we get from healthcare professionals. The data has changed fairly dramatically over the last 30 years in terms of the call pool that we get. You heard about pediatrics being the primary pool. In 1988, when I got here, about 65% of our calls were about pediatrics. Now, that has decreased significantly to 50%. Can someone tell me why the pediatric exposure volume has gone down? I'll give you the answer in 2 words. Dr. Google. The reason why volume has decreased is the proliferation of the internet. I mean, you could treat everything from broken bones to poisonings now. So people are less apt to call us. Therefore, you see the decline in the numbers of cases that we get. As I tell my population in Georgia when I'm lecturing, I try to promote the poison center services because I ask them, would you rather trust an algorithm or would you rather talk to a healthcare professional? What do you think is going to be most beneficial to you? So yeah, and Alexa and Siri, you know, they could, you know, they're not as good as the people who are, you know, familiar with the most up-to-date data, using the most up-to-date resources, whether it's toxins or micromedics. Trying to convince them that a human is much better is difficult. And even when you tell them it's a free service, still someone wants to pick up their mobile and ask Siri if, you know, silica gel is a problem. So it's something that our generation now has to deal with because we've become so enamored with quick answers and bullet points. Oftentimes, the conversations about poisoning just don't happen, and that's why we're seeing such a decline in the number of cases that we're getting about pediatrics. They are still happening. Don't get me wrong. Pediatric poisonings are still happening, but people love their Google. So what are we getting called about? Well, this should be familiar to you because across most of the U.S. poison centers, their data is going to look fairly the same, but analgesics obviously are at the top of our list, all the way down to foreign bodies and pesticides in terms of the calls that we get here in our office. Now, the striking fact that makes us such an incredible public resource is our ability to handle these cases and keep a majority of these cases at home. This is where our money is, in preventing the unnecessary visits to doctor's offices and to emergency rooms. So when you think about the cost savings, yes, public health is investing in us, but their return on their investment is tremendous. And that's why when our state realized that in terms of the cost sharing of Medicaid and Medicare, giving us a little bit of money will result in tremendous cost savings. And the insight and think about this is the early 80s where public health said this is an important program to have. What's really disappointing and disheartening is that in the 80s, we were one of the very few poison centers, if there were even any, that were integrated with public health. If you fast forward to 2020, the numbers are not very much better. What the primary reason why some of the people in public health don't integrate with their poison centers? Everybody claims poverty. Everybody claims poverty. And of course, as you look at everything from the CDC budget being cut to other poison centers' budgets being cut, our state has remained steadfast in saying poisonings are a public health concern. This is an important project for us. We're going to continue to fund. That doesn't mean I'm waking up every day and happy with my funding. In fact, before I came to Turkey, I was alerted that I was going to be cut about 15% of my budget. And I am pleased to tell you that while I was visiting a palace yesterday, I got a text message that said for this year, our money was restored. That's right. People who write the laws recognize that, you know what, being penny wise and pound foolish, cutting our budget would result in far more millions of dollars. They wanted to cut us hundreds of thousands of dollars, but yet the cost to them would have been millions of dollars. And finally we got, after a couple of communications with state public lawmakers, they realized this was a very foolish decision to cut our money. But not everyone is successful as us. And so we've been lucky that we've been able to convince state public health that we need to be funded at the levels we're being funded. So when you look at the collaboration, as I said, I've been part of the program for over 30 years. We've been integrated with public health since before I got here. When we first started with public health, nobody else in the country was doing this, and we were managing animal bites and rabies. We were the depot for getting cases about foodborne illness. We were being asked to provide information in major public events, and I'll be talking about some of those in just a second. And then also, they wanted us to be able to provide a 24-hour hotline for people in our state that had other public health concerns, and you'll see some of those in just a second. So they recognize that poisoning is a public health concern, whether it was environmental, whether it was occupational, whether it was in drinking water. They recognize that if they provide the public with a resource to call for information, Number one, their jobs would be made easier, so their phone lines wouldn't be filled. And then they chose us because we're a 24-hour resource with medical professionals. So we established programs here that I'm demonstrating here, and I'm going to go into these more in depth because, for example, a poison center and its ability to handle cases regarding hurricanes, does that even make sense? You think maybe it's just medical, maybe it's just, you know, an antihistamine overdose or a cardiovascular. Why is our poison center involved in H1N1? Why is our poison center involved in the latest coronavirus? These are all public health issues, not poisoning issues, yet they're coming to my center and saying, we need help, and can you provide it? So let's talk about some of these here. For example, rabies. Back in the 80s, they asked us to work with them to provide care about animal bites. And one of the things that I tell people when I'm lecturing, here's the beauty of rabies. If you get bitten by a rabid animal and you start having symptoms, I tell my audience, there's only about 100% chance you're going to die. Only about 100. But the need for medicine, the need for rabies prophylaxis, the need for the antidote is importantly held, and the decision-making should be held by people who are more knowledgeable. Instead of just giving everybody the antidote, even though it's 100% fatal, you need to be able to have a program that identifies those patients at high risk. You need to be able to do it in a manner very quick, and you need to be able to do it on a 24-hour basis. We were that organization. And in the early 80s, unlike the other colleagues in poison centers, nobody had a program. If they did, there was probably less than 3 or 4 of us that had an active program that managed animal bites. Looking at the cost savings, just in making the recommendations or not for rabies antidote, resulted in a cost savings of over, $5-7 million. And just for funding us for a few million, you save $7. Hey, who wouldn't want to invest $1 million, and every year you get $7 million? Get in line with me, because if you have that money, we could make this kind of cost savings, right? What's another program that the state said, can you help us with? Well, there's a program that's a federal program that individual states are able to take part in, and that is the strategy of locating certain depots of antidote in strategic areas in the state in the event there's a mass exposure to organophosphate poisoning. So the federal government gives the state quantities of organophosphate combating agents, and the poison center is the gateway to be able to utilize these resources. We know the secret of where all these antidotes are stashed throughout our state, and when a mass occurrence happens, whether it's a truck that overturns or whether there was a spill at a factory and it involves nerve agents, we have the ability to identify where the closest resources are. We have the ability to then release this antidote for use. One of the other things that we do is for our state, we provide our state the number of 1866 Pub Health, and you see the number spelled out there, but we have separate call center staff who answer certain public health questions, ranging from notifiable diseases, bioterrorism events, and other public health emergencies. And these are people that are utilizing the call center capabilities, and we're able to do this on a 24-hour basis. Now, who are the folks that call us on this special hotline that's contained inside the poison center? You see everyone from healthcare providers, pharmacies. We get calls from the quarantine office at our airport, veterinarians, a number of agencies but the primary call base is going to be people who come from just the general public. Now, the thing about our hotline, our separate hotline, is this is a way for people to talk to us about everything from diseases, dead birds, mold, if there are feces in swimming pools. Where do people turn to when they need information? Who are they going to call? The state said, can you handle everything, like these, like restaurant complaints, mosquito complaints, hotel, food complaints? All those calls come into the Poison Center. So again, it's resources the state says, hey, we can provide it to our residents of Georgia. We could do it on a 24-hour basis. Now, the unique thing about these calls is we document these calls, and these calls immediately get uploaded into the state public health database. So there's no duplication of effort. A public health call comes in, we enter it into our system, our electronic medical records, and every 10 minutes, these cases automatically get uploaded to public health so that they see cases in real time. Now, those hotlines that I talked about, we know the clinical side of this. Acetaminophen overdoses, aspirin overdoses, calcium channel blocker overdoses. Those of us who are toxicologists know these are the routine things. But remember, we're talking about public health today. We're talking about the bridges of public health and poison centers. These are not traditional things that poison centers do. As I mentioned, we are dealing with cases that involve pandemics, endemics, hurricanes, disease monitoring, mass messaging. What are some of the examples? Well, I mentioned in 2005, the state said, can you help us with hurricane victims? Not from a toxicology standpoint, but from a resource management standpoint. People from Louisiana were forced to go to our state, but they had no idea about housing information, medical information, food, people who needed glasses, everything like that. The state said, we need your assistance, and we think you could do it. Why? Because we had the infrastructure. We had a call center. We had an electronic medical record. We had a way to answer calls on a 24-hour basis. And so we partnered with Georgia Department of Public Health to provide these resources to the people who were coming to our state. This is not a poison center function, but the state says, we need your help. You are a public health arm. You are an arm for public health and public information. Can you do this? So we hired extra people. Within 2 days, I was able to train staff, and we were able to use our infrastructure and be able to deliver this program. What other things have we done on a mass scale? Well, we've been fortunate that we've had major events in our state. Those events include the Super Bowls, those of you who are football fans, 1994, 2000, 2019, and of course, the big event that we had to prepare for because of public health was the Olympics. In 1996, the Olympics came to Atlanta, but it was in 1992 that we were awarded the Olympics. And from 1992 to 1996, we were working nonstop to be able to provide certain public health information to the people who came to the state. Now, primarily, we were looking at bioterrorism events, and so we all got fairly familiar with anthrax and nerve gas, and so we were ready to provide that information, and I'm going to share with you the mechanism that we were looking to use to do that. So, when you look at pandemics and such, in 2009, the state asked us, Dr. Lopez, can you provide a call center for people who have questions about H1N1? Again, this is not a poisoning, but they wanted to use our infrastructure of healthcare professionals who could work in a call center around the clock. And so they gave us a little bit of money that they would never be able to use to spend to develop a program, but they knew they could use our infrastructure and be able to do and deliver these programs immediately. We started not only with H1N1, but we've done work in Ebola and Zika. Again, a poison center and infectious disease. You don't think these are partners, but we are in bed all the time. And lately, our latest project is working with the state on the novel coronavirus. Again, what is our role? We have been asked to take monitoring capabilities, meaning monitoring temperatures, monitoring symptoms, not a poisoning, but a valuable public health resource. So when the patients arrive at Atlanta Airport, they are told to call a certain number. They don't know they're calling the poison center. They know they're calling public health. And so again, we feel, honored to be able to help in these particular events. The one that happened that was a public health emergency happened just a couple years ago. We were in the news across the United States. You might have heard it, in your country, but with the opioid crisis that we're experiencing, there was an incident that occurred while I was on call where at 10 o'clock at night, a doctor calls me and calls our center about how can we alert the public about an event that's happening in my area, and over the course of the last 24 hours, we are recognizing that there's something unusual going on. Can you help spread the word that we possibly have an epidemic in our state? Because in the last 24 hours, 5 patients have presented very similarly where they have needed high-dose naloxone because of severe respiratory issues, all after getting drugs on the street, all having taken only 1 pill. We later find out that this exposure involved purchasing off of, in a drug house. A small amount resulted in major problems, and our cases were being fed electronically into our system, and hospital data later confirmed in a syndromic surveillance study that there was something in fact going on. But who was the first agency to recognize it? It was the Poison Center. Now this is a case where we're talking about poisoning now with a public health event. And so we were able to document a number of these cases. Our state public health director, our head person in public health said, hospitals in Georgia, starting now, anybody who meets patient criteria must be referred to the Poison Center. They must be able to report these incidents to the state Poison Center so that we could track these patients. So over 2 weeks, we identified almost 30 cases, and a number of these folks, you could see here the statistics on these individuals, and you could see that they all presented fairly similarly. When all was said and done, we understood all these patients were looking to buy Percocet, and when they ended up taking these Percocet, they almost died. In fact, 5 individuals died of the 27. We later identified this as cyclopropyl fentanyl, not Percocet, and it also had another novel opioid, and we were able to immediately work with public health and our partners, our Department of Public Health, GBI, and other law enforcement. It's all because of how that call ended up coming to the Poison Center. Now, another program that we use that allows us to talk to people and multiples of people is using this problem called SUFER, and it stands for Surge Public Health Emergency Response System. What is that? In short, what it is a phone system that overlays on top of our existing phone system to allow us to simultaneously receive calls of from nearly 600 people at the same time. Now, we don't have 600 agents in our office, but you're able to develop messages that the public could hear regarding an event. So we used our existing infrastructure, we put messaging into the system, and it was a text-to-voice program where you put in the most common frequently asked questions and answers, and the public goes in and they make a call to the number, they enter their code of their county, they select a message, and if they're satisfied with the message, we've done part of our job. If they're not satisfied with the message, then they're able to find someone who is a live agent who can speak. So, in summary, it is an incredible relationship that we have with public health. As I mentioned at the very beginning, many of our other partners throughout the United States don't have this relationship. They don't have the luxury of being able to work with other public health agencies. And when you think about our collaborations, they've recognized that at least our Poison Center is an efficient way and a cost-effective way to deliver public information. We are always surprised to hear why other poison centers don't have the same relationship. But slowly but surely, I think public health is recognizing the importance of having a poison center, helping them with these kind of situations. And for us, I've been lucky to be part of a program that for over 30 years has been partnered with public health to not only provide poison information and treatment information, but also to provide valuable information for the public health in a variety of areas. It doesn't matter if it's bioterrorism, it doesn't matter if they're worried about mold or a dead bird, or of course now some of the pandemics we're seeing. We've been involved in H1N1, Ebola, Zika. We got called about, now we're doing so many things with the novel coronavirus. These are non-traditional things that we are doing, and we've been very fortunate that public health continues to support us. And yes, I will continue to fight for money that they take away from me. I will continue to tell them that if you cut me a little, we're gonna cut some of the programs to you a lot. And when they realize the people who push pencils, the lawmakers who write the laws, it's easy on paper to say, well, cut Dr. Kilburn's program by 10%. We have to achieve a bottom line. We realize that people do listen to us. We realize that lawmakers, know that the Poison Center helps us. And I've been very fortunate that I work for a program that integrates with public health very intimately. Thank you very much.
Dr. Lopez, thank you. Any questions? The center is unique because it also contributes a very important toxicology resource for the world, an information resource called toxins. And oh, you are okay. Sounds good. So Gaylord is still on stage, and then we are going to look at the poisoning emergency from the scene to the poison center and beyond. And what they want to do here is they want to share with you various stages of poison center involvement with paramedics, with the hospital, etc., and how they are able to assist along the way.
Okay, so I'm going to open quickly on, again, poisoning is a public health issue. Both Lucy and I will be talking about what happens from the scene to eventually when you get seen. Because those of us who are in a poison center model where we have our poison specialists working primarily to provide information as opposed to physicians who do it from start to finish, we're going to share with you a few cases where our poison specialists are the ones who are managing these very critically ill patients. And so, as a reminder, my state is populated with 10.5 million people. The Poison Center is staffed with this kind of organization. We have poison specialists. We have 19 full-time people. We have computer people. We have trainers. We have residents. We have fellows. We are probably the most best staff group of toxicologists in all of the United States, with our resources at Georgia along with our resources with the CDC. The staff that primarily handles the emergencies are nurses, pharmacists, or physicians. So those are the people who work in our call center. And these are folks handling the calls on a daily basis. Now, I'm going to go over 4 cases really quickly, cases that we get on a day, very commonly, and it starts with these routine cases that our folks handle. So let's take case number 1, where we have a pharmacist who's calling the Poison Center for information. So the pharmacist is calling us about a 4-year-old patient who gets 4 tablets of iron pills. Now, what the mother is asking not the Poison Center, but the mother is asking her pharmacist for advice. Now, what I would have preferred the pharmacist to do is tell the mom to call the Poison Center, but instead he calls us. Okay, so that's not uncommon, but the pharmacist doesn't know what to do because they're not trained. So they call us, and we take history, and so we put the pharmacist on hold, and what do? What is our next step? Well, I've been at these conferences, and we've talked about the development of guidelines so that your staff can do the majority of work for you. So we have a guideline on our internal internet that allows us to look for cases that have specific protocols, specific actions you take. And when you go to our protocol book, you'll find that we do have a guideline on how to handle iron ingestions. So our poison specialist says, hey, let me read the protocol, let me see what has to be done. And when you read the protocol, you'll realize that for pediatric patients, we have a guideline of how much they could take without having to go into the hospital. So when you figure out that you could do calculations and realize that your patient did not get enough iron, you do your simple calculation. This is a case where we performed a calculation. We recognize it as being not a problem, being subtoxic. We decided to do an additional call 4 hours after they got a hold of us, and we realized that the patient only had minor effects, maybe some nausea and some vomiting, and then we decided to keep the patient at home, and we closed the case. Very cost-effective way, and think about how much an emergency room visit would cost if this patient went directly to the hospital. Think about how much cost it would be if they just went to their pediatrician. And think about the time that it would take to do all this. The Poison Center, a public health partner, said we can do this, we could keep them at home, and these are one of the 85% of cases we keep at home. What about case number 2? A dad tells us that his 3-year-old son just had awoken from a nap. He took a nap for 5 hours, and when the child wakes up, he tells his father that he ingested a penny. And so, again, a Poison Center is in place. The father recognizing that there is a resource for me to call instead of immediately going into the emergency room. He calls Poison Center. Now, for those physicians in the room, some of you are probably saying, oh, it's probably nothing, just leave it at home. Well, in order for us to make a decision, we turn to our guidelines again. Do I have a guideline on foreign bodies? And we take history, we look at our computer system, and wouldn't you know it, we have a guideline on foreign bodies and choking hazards. So our poison specialists goes into the guidelines, and they read what is our medical backup wanting us to do in the event of foreign bodies. So again, this is not a case being handled by the medical toxicologist. This is a case being handled by the poison specialist who has direction from the medical toxicologist because we have a guideline written and approved by our medical toxicologist. Now, because our protocol advises that that patient needs to be seen, we want to make sure that the penny is beyond the esophagus. So how do we do that? You can't do that at home. You must take x-ray. So we were able to send to the hospital, they performed a abdominal x-ray, and they did isolate and find that the penny was in fact beyond the esophagus into the intestines, and the patient was now safely able to be discharged. Again, by following our guidelines, we were able to manage this case appropriately, tell the hospital in this case what has to be done. In fact, one of the key elements that we do is if we recognize a patient has to go in, we will call the hospital ahead of time and tell them a 3-year-old patient's coming in, this is what you have to do, this is what you have to monitor, so there'll be no waste of time. So again, it's by use of guidelines. The third case I want to talk about, mom, I told you about this earlier, decides to consult Dr. Google. So she's Googling what happens when you ingest Visine. Everyone's familiar with Visine, the eye drops, if you have red eyes, right? So now the internet tells her this is a major problem. This is an issue. The mom's not sure what has to be done, but she tells us that the ingestion is not witnessed, and the kid is a little drowsy, but it may be nap time. So now the mom says, I read Dr. Google. It sounds like it's a problem, but let me talk to a real person. So she calls us, and after we take a history, we want to look up if we have a guideline. And wouldn't you know it? We have another guideline. We have a guideline for imidazoline compounds and vasoconstrictors. And when you look at our guideline, you'll notice that we have a specific protocol that if you have this ingestion, these symptoms, you must be evaluated. Again, these are written by the medical staff, Dr. Kazi, Dr. Geller, Dr. Morgan. These are the physicians who write these guidelines so that the staff has directions on what to do. It's not cases that you have to deal with on a minute-by-minute basis. Many poison centers have these guidelines, and they are basically instructions on what to do in the event of a particular type of exposure. As per our guidelines, we noted that the child had to be referred into the hospital. We went ahead again and called the hospital to say that little Johnny is coming in. This is the poison center. This is what can occur in this particular overdose. These are my steps that I want you to take, and these are the things you need to look for. The child gets to the hospital fairly quickly, within 20 minutes, and the child is noted to be altered, is noted to be somewhat CNS depressed. We follow up with an additional calls to the hospital. After the child is admitted, we follow up. Our protocol calls for continued follow-up of these patients, and we do 2 more, and we realize that the child is fine after 24 hours. Boom, boom, boom, they go home. And because the hospital is waiting for our specific recommendations, they will follow our directions. In this case, the outcome was good. Now, the last case that I have is the following. We have a 20-year-old patient, a female, who calls us and says, can 1/2 bottle of insulin, if I inject 1/2 bottle, I hope I will be able to die. That's what she was asking. And she's asking because she wants to make sure she dies from the insulin. Why? Because she's tired of always being admitted to the psych ward. She now is tired of her life. And so this is an unusual call for us where someone says, did I do enough to kill myself? So you might be thinking, well, how do you handle a call like this? You could go to your resources. That's what we did. You could go to the databases. That's what we did. But I want to share with you what steps we took. So we asked the patient to go into the hospital immediately. And for many cases, they simply don't follow our recommendations. Now, when we called the hospital, we advised them early what they have to do to treat this patient. Now, one of the things that we, as part of our protocol, for anybody who we referred to go into the hospital, we always called the home back within 1 hour after they call us to make sure they followed our recommendation. So, number one, we called the hospital and we told them patient X is coming. Within an hour, the hospital didn't call us back. We realized patient may not have gone to the hospital. So we called the home and there was no answer. But how are we guided with a case like this? Because it's a situation that's life-threatening, guess what? We have a guideline. We have a protocol. What are the cases when you need to call a medical toxicologist? When is it that it's important for the poison specialist to seek extra help in managing a case that may be difficult? We have a protocol for it. So, we have a protocol here. Within 45 minutes of a call, I told you that part of our procedure is we tell you to go in. Part of our procedure is if you don't arrive at the hospital, we're going to call you back to see if you left, if you're following our directions. Over the next 2 days, our office calls the hospital to give them further instructions. On admission, 2 hours after the initial call, the hospital calls us, the patient in fact arrived. Voila, this is good news. The patient arrives, they have a blood glucose of 22, so they immediately, initiate therapy, D50, D10, IV glucose, and then they're calling the poison center for more advice on what to do. They're waiting for us to tell them if there are other complications with so much of this product being exposed. Our job was to help with hand-holding of managing this patient. Over 2 days, we called 5 additional times to make sure everything was good. And our last follow-up on day 3, the patient was deemed medically stable and now transferred to psychiatry, which she doesn't want in the first place. So it just represents for you, at least for us, the steps that we have to take in order to manage these cases. And my colleague will present a much more complicated case that will dive into managing poisonings and the amount of work that goes into handling a very serious case. So I'll turn over the podium to my colleague, and then after the presentation, we would be open to answering any questions.
Dr. Hamoudi, question? You go ahead. Click on that.
First one, can we take a copy of this guideline management to my center in order to update our knowledge about?
So the question is, we have guidelines, we have protocols.
Can you send us a copy?
So I will answer it in the best way I can. The guidelines are written by our doctors who evaluate literature. Now, a lot of physicians in the room today, when they read an article, they may not see the same things I see. So these guidelines were written by people who know the literature, and they decide on their own actions they would take. Because our poison specialist, myself, we work under the umbrella of the medical toxicologist.
Yeah,
right?
yeah, I know.
So now, to answer your question as best I can share with you our protocols. Now, you could follow them if you like.
Yeah, yeah,
If
yeah.
you trust us, you could follow them. But I would be open to
Yeah.
sharing some of these protocols.
Yeah, if it is available in a software, it would be easy as to get an access, but not an internet access, because the internet services in my country is not so good.
Yeah, so
if you
for
have
us,
a software, this is the first
look,
question.
these are all contained within our own internal internet, right? So we have easy access. We could talk after the presentation about specifically how you might want to evaluate our data, look at our data, and maybe use it in your setting. We could talk afterwards.
Okay.
Okay?
Thanks. The second question about the financial funding of these numbers of calls, because no one in my country might fund or pay for these calls. How would you manage it?
So funding is a very tricky problem. Some of us get state funding, some of us get federal funding, some of us get no state funding. Since the early 80s, Georgia has recognized this is a public health concern. So we had insightful leaders in public health. That's what it takes. I have a fellow who just graduated from my program. She went to a state with no public health money, no public health relationship. Her job is to establish a relationship with the leaders in public health, and I'm understanding she's making some progress, even though she's only been on the job for 2 months. So you have to make progress talking to the people in public health. It doesn't happen just by magic. And we could talk more about some of our strategies.
Okay, thanks a lot.
Thank you, Hamoudi. For the sake of time, we're going to move on. That's great. That's okay. Thank you.
Thank you. So I'm going to follow on. I've got a bit of a complex case that I'm going to present. But first of all, there we go. Okay. So first of all, I just want to say I've got no direct conflicts, but I would like to disclose that I am also the manager of Toxins, Poisons Information, who are sponsoring this conference. So I just want to be clear about that. So, as you know, I'm from the New Zealand Poison Centre, and there's a wee photograph of the green building where our poison centre is housed. And for those of you that haven't been to New Zealand, you should come visit us. So I'd just like to say that Dr. Kazi's title for this stream, Bridges Between Clinical Toxicology and Public Health, I think is absolutely perfect. How are bridges built? Bridges are built using struts. One strut on its own cannot support a bridge. So a strut essentially provides outward-facing support. So if you look at that, we are essentially all struts on that bridge. So I just want to talk a bit about when a poisoning occurs, who gets involved? And why is it important to all be on the same page? And how do you ensure the best care and outcome for the patient? So you look here, poisoning is a bit of a puzzle sometimes, and there are multiple people involved. And that can be everything from the caller or the patient themselves, the caller's family, spies who take the initial call, medical toxicologist who becomes involved to consult, paramedics, the ED doctors, the ICU consultants, and then finally mental health or public health. So looking at a typical scenario, we have a person who calls the poison centre. So that's one call. They talk to the spy. That spy then advises them to call an ambulance. The caller then makes a second call, talks to ambulance. Ambulance calls back the poison centre to get advice. So how many calls are we up to so far? 3? The ambulance then transports the patient to the emergency department. At the emergency department, the staff then call the poison centre back for further information. Then the emergency department will hand over to ICU. So we have multiple conversations going on here about the one case. Are we all speaking the same language? Are we all doing the same course of treatment? It's very important that we are. ICU then potentially calls back the poison centre to talk to the medical toxicologist for further guidance. And then finally, if mental health are involved or public health, potentially they're also calling the poison centre. So if you look at all of those calls or conversations, they all add up to support that one case. So how do we record this? We were talking before about funding, and we know that funding is very difficult. If you underreport calls, you're not doing your job, so potentially you could lose funding because you're not seen as taking enough phone calls and providing enough support. If you overreport a case, you could end up with sending public health into a tailspin because they think the situation is actually a lot worse. There's more poisonings happening than there are. So it's really important that we record calls and record them accurately. So just looking quickly at calls versus events versus exposures, they're actually all very different things. And as you can see there in the middle, I failed art class at school because I can't draw people. So typically, about 80% of our calls will be one phone call involving one patient and one substance. Generally, they're pretty straightforward. So it's typically mum calling the poison centre about their child who has ingested paracetamol. Very easy, no further involvement, one exposure. You can have one call involving multiple patients and one substance. So again, mum phones up, both her children got into the paracetamol. So again, one call, multiple patients, but still just one substance. You can have multiple calls involving one patient and one substance. So we talk to mum goes to the hospital, then the hospital phones us. Still only one event, but it's two phone calls. You can have multiple calls involving one patient and multiple substances, and multiple calls with multiple patients and multiple substances. So for example, some sort of public health emergency, a chemical spill, there's going to be a lot of phone calls backwards and forwards to the poison centre about a large number of patients and potentially, several chemicals involved. Again, how do you record that accurately? So just going back through, so one call, one patient, one substance will be put down as one exposure. One call, three patients, one substance would be three exposures, but still just one phone call. Two calls, one patient, one substance, two phone calls, but only one exposure. See, it gets confusing? Two calls, one patient, six substances will be two calls, but six exposures. And then, for example, if we had four calls involving two patients and two substances, that would be recorded as four calls, but four exposures. So just looking at this case that I just want to walk you through and the calls and the conversations that were involved. Got a 37-year-old male attempted suicide by ingesting silazepam and aspirin. Quantities of both drugs were unknown, and the male is a type 2 diabetic. So the first conversation, day one of the exposure. His distressed partner calls the poison centre. She calls in a distressed state, tell us about the suicide attempt that happened last evening. She thought her partner would be okay, but he's just had a seizure which lasted 30 minutes. What's the advice? So we look up our protocols for silazepam and for aspirin. And in this case, for an acute on chronic dose of silazepam, medical observation is recommended for ingestions of 5 times the patient's usual single dose. Well, we don't know how much he took, so that's an uncertainty. Symptomatic cases are all referred. We know he's symptomatic because he had a seizure, so that ticks the box. And exposures with intent of self-harm, well, we know it was a suicide attempt, so that was another reason for sending him in. Second conversation in this case. The stressed woman has to ring the ambulance because of his symptoms, and he's just had a seizure. Our advice is to talk to ambulance direct. That way, if he deteriorates while he's on the call, they can guide her through CPR, etc. Conversation number 3 in this case. Ambulance then call back the poison centre. So that they've talked to the woman, they're now transporting the patient. They want to know what to look out for en route. So again, we look at some advice and give some basic monitoring advice, looking at things like blood pressure, heart rate, level of consciousness, and perhaps putting a line in to get some fluids in. Conversation number 4. Ambulance has now arrived at the hospital, handing over to the emergency department staff. So they're going to talk through what they've found, their observations, and the advice that the poison centre gave them. Conversation number 5. Emergency department then ring back the poison centre for treatment advice. So the information provided to the poison centre by the ED physician is the patient has just arrived, so all they've done is vitals and blood gas at this point, and they've not started any therapies. They can't really do it, well, they can do a salicylate test, but it's sent out, so the results aren't going to be back on time. Vitals are all over the show, and the patient has a history of poorly controlled type 2 diabetes. And glucose is currently at 53, and we know he's had a seizure. pH 7.23, lactate 12.2, sodium 129, and he's had a chest x-ray which shows possible pulmonary edema. So that's the information fed back to the poison centre. So based on that information, we do an assessment and we'll give some advice back. So our advice was ICU admission. Given that they weren't going to be able to do meaningful salicylate levels, in cases like that, if we can't get a result back on time, we always look at worst case scenario and treat for worst case scenario. It was advised to start hemodialysis, and there was some caution advised if the patient needed to be intubated. And again, the last thing we always say is call back the poison centre for that advice. The poison centre is kind of a central cog in the wheel and the keeper of the information. So we've had conversations with that many people, we know what's been said to each person. If these conversations were happening outside the poison centre, we can't coordinate the care plan. Conversation number 6. We now have the ED staff handing over to ICU. So again, they're going through all their observations and their treatment recommendations. So I'm not going to go through all those, but that's the numbers that the patient presented with by the time they got to ICU. So they're pretty poorly. So now ICU staff have had a further conversation with the man's partner, and it was revealed that diltiazem, not cilazapril, was involved in the ingestion. So suddenly we had to rethink what was going on here. It's now a different drug to what we thought was happening. So we're now up to day 2 of this man's care, and we're up to conversation number 7. So the ICU staff call back the poison centre and disclose that they're now dealing with a diltiazem overdose. So again, looking at diltiazem and our treatment guidelines, the first thing you'll see is consultation with medical toxicologist through a poison centre is advised, because this toxicity can be life-threatening. So it's right there, first thing we say, call the poison centre for a discussion. So an update from the ICU at this point, GCS 15, pH now 7.26, lactate 9.7, no other updates compared to the previous call. Advice from the poison centre, it was to start or continue hemodialysis, monitor for onset of bradycardia, hypertension for diltiazem toxicity, and again, keep the poison centre involved and tell us what the progress is. A few days later, so the ICU have been supporting this patient for several days now. We're now up to day 6 of his care, and we're now up to conversation number 8 involving the poison centre. So high-dose insulin has been stopped, but patient's still receiving adrenaline. Patient is deteriorating pretty badly, and they've developed slow atrial fibrillation. At this point, their neurological exam had worsened. One of the things that was not clear was the symptoms of CNS depression were not in line with what we thought he had taken. Let's just skip through this. So at this stage, there was concern for brain death. The patient was too unstable to move to MRI. Every time they tried to move him, his vital signs dropped. So discussing the history that there were known drugs that should cause significant CNS depressive effects that would mimic brain death, we advised to check medication history again, just in case there was anything that had been overlooked or missed. Turns out that there was some colchicine tablets missing, but again, that didn't fit the profile of what we were seeing. But it highlights the importance of getting a really clear history and knowing what else could be going on here. At this stage, a family meeting was planned and any further care and support was withdrawn, and unfortunately the patient did pass away. So we've got one case, 8 conversations, and 7 very, very long days. It gets complicated. So how is this recorded for public health? Most poison centres have a due diligence to report to their funders or to public health to advise them of events that are happening for funding reasons, but also for surveillance. So it's important to get this accurate. So this was one event involving one patient with 2 substances, and even though there was 8 conversations, there were 5 phone calls. So you see the difference between phone calls and events. If you under-report or over-report, it can skew the numbers a bit. So basically, in order to achieve the best possible outcome for a patient, information needs to be consistent and flow freely. We all need to be on the same page to make sure that bridge does not collapse. And so from the initial call, from the scene, right through to hospital discharge and follow-up, the treatment needs to be consistent and have the same treatment plan.
Thank you for this nice description of your everyday work, which is a model to consider and follow in different parts of the MENA region. I would open this up for a couple of questions before we can go to the break. From the audience, if you need to speak, we have a microphone. Any questions? Everyone's ready for the break, I guess. Okay, so let's take it again, and let's go to the break and come back at 10:30. Please be on time because we have a webinar from Dr. Mazen Melkawi from WHO, EMRO, Center for Environmental Health Action from Amman, talking about the WHO efforts regarding poisonings in the region. Thank you. All right, psychology. It is my honor to present to you our next speaker from Amman, Jordan. Our next speaker from Amman, Jordan is Mr. Mazen Melkawi. Mr. Mazen Melkawi is the regional advisor for the WHO Center for Environmental Health Action. He is going to discuss with us a little bit about the regional framework on public health preparedness and response to chemical events for the purpose of the international health regulation implementation. He will share those remarks with us over 20 minutes. After that, we have rapid updates about various poison centers in the region from representatives from 5 poison centers. Each of those presentations will be a 10-minute presentation. And hopefully we'll finish on time for lunch, lunch around noon. With no further delay, Mr. Melkawi, please go ahead and you can start your presentation. You can go through slideshow if you like, slideshow mode on your PowerPoint.
Good morning.
We can hear you good.
Okay. I'm glad to speak to you this morning, and I regret that I lost the opportunity of participating face-to-face to chat and discuss, issues of mutual collaboration with colleagues.
Mr. Melkawi, do you want to go on slideshow? You can go on slideshow mode. All right, very good. We can hear you well.
Oh, great. In this morning session, I will be speaking a brief introduction on the international health regulation. I'll shed some light on chemical events and the joint external evaluations that we are doing jointly with the countries to determine their capacities of responding to chemical events. We did some analysis for the joint external evaluation mission, and last year actually we developed a plan of action, to help countries to respond to chemical events in the year 2018 and 22. International health regulations is an agreement between most of the countries of the world, 196 countries, including all WHO member states, to work together for global health security, actually, including events like biological and chemical and radiation hazards. The new thing about IHR, it does not just focus on infectious and non-infectious diseases.
This meeting is being recorded.
It focuses actually on the what we call the all hazard rather than specifying specific type of hazard. Uh, Through the IHR, countries agreed to build their capacity to detect, assess, and report public health events. And during the couple of slides, I'll show how this is very much linked, to the subject of your meeting. Within the IHR framework, or the multi-hazard dimension, there are 19 capacities or 19 things that are being discussed. And if you notice in red, the chemical event is one of the issues that I will focus on. One basic thing, you know it better than me, that the global understanding of the complexity of the health impact of chemicals is not as easy as we can imagine. The number of chemicals is on the rise. The latest estimate of WHO that 2.7% of the global deaths, about 1.6 million people, are dying because of exposure to chemicals. The chemical releases arising from technological incidents, natural disasters, conflicts, and terrorism, the man-made, are common. And during the 10 years from 2000 to 2009, about 3,200 chemical disasters, killing about 100,000 people and 1.5 million affected. But it is there, it is on the rise. A chemical event in one country can lead to health consequences in another. This is the main issue that we are concerned. There are a lot of examples where a chemical spill happens at a water river, and affects several countries. It is essential to talk that the IHR implementation is not just the responsibility of the Ministry of Health alone. And when we come to toxicology and poison centers, it's very clear that it's not necessarily the Ministry of Health alone. But the collaboration, that's a very good example, about an incident that happened in a factory on a water supply where several countries were affected. If we look at the number of unintentional chemical poisonings in the region, which is unfortunately a bit old estimate, in the region, about 8,400 people lost their lives actually because of toxicity. And we all know that registration of toxicity is not that bad. I would say the real number is much higher. In 2014, the countries of the region did what we call the self-assessment actually, and they identified the gaps in different aspects of IHR. In a sort of, I don't expect you to read, this, but these are the capacities that are linked to chemical events and preparedness. And if you see, the picture is, from a self-assessment, is good. It seems that green capacities are there, more or less. A lot of green is in the screen, which means that the capacity is fair. But unfortunately, when we did the assessment jointly with the countries, the picture was a bit different. And in the joint external evaluation, actually, we are measuring two main indicators. The first indicator is mechanisms are established and functioning for detecting and responding to chemical events, and we give usually a score from 1 to 5. And the other one is that is there an enabling environment in place for the management of chemical events. Again, the scale is from 1 to 5. Yes? I'll continue. Capacity 1 means there is no capacity. Capacity 5 means that the capacity is there and is sustainable. And there is a detailed way of estimating that. This is the result of the evaluation of 18 countries of the region. As you notice, it's almost the blue and red, which is yes and no, or the capacity is there. Roughly speaking, 54% of the capacity is there, which means that unfortunately still we are not ready to deal with chemical accidents or chemical events. And one of the main issues that we are losing is non-existence of poison centers and the poor clinical management, let me say, at hospitals. This is in a nutshell, the evaluation of of the different aspects of chemical safety. As you notice, the picture is completely different from what we see in the self-assessment. A lot of red, which means that the capacity is not there, and one of the lacking capacities is really the poison centers. And actually, in most of the countries, either see this is if I know if the pointer is clear. In most of the countries of the region, either the poison center is not existing or is not functioning to the level that it is serving 24/7 the whole country. In the first indicator, we see clear gaps, and we know the chemical event and poisoning surveillance system is weak or not existing. Chemical laboratories for testing and sampling is weak or not existing. Functional poison center is weak or not existing. I think this is closely related to what you will be discussing in the coming 4 or 5 days. And accordingly, we built actually a plan of action for the countries of the region, in order to bridge these gaps. I'll just browse through those main activities. First is to design and introduce a model event-based surveillance system for detecting and reporting on chemical events, strengthening existing evidence-based surveillance systems for detecting and reporting chemical events, provide technical support to help all countries in having at least one functioning poison center, strengthening the laboratory capacity of countries of the region for sampling and analyzing chemical public health concern, technical support to help countries in maintaining reliable access to information, and strengthening the capacity of the health sector for assessing, communicating health risk on chemicals. I don't want to go in all the details. This is a very rough talk about what we are planning in the coming 3 or 4 years to help countries and region in responding to chemical issues. And back to you.
Thank you, Mr. Mazen. I think your points are very important and actually really validate why we are here today. And it's actually an opportunity for us in the MENA region as toxicologists and public health professionals and emergency physicians. It's an opportunity for us to build on the attention that is given to us by WHO and call to action to enhance our chemical toxicology, or medical toxicology, clinical toxicology, poison center, even laboratory capacity in the region. So I thank you for joining us. I wish you were here with us. Mr. Melkawi is going to be here with us with the network of their network that they formed in the EMRO region. However, the novel coronavirus led to them being occupied with this epidemic, and we had to do this online today. Hopefully, you will join us next year, Mr. Melkawi, with your group.
Inshallah.
Now we are going to keep going. Mr. Melkawi, if you'd like to watch the slides, we are going to keep the WebEx going. And actually, I don't know if we'll be able to do that. Actually, we're not going to be able to do that because of the technology. We will share with you those slides for the Poison Center updates. I can email them to you afterwards so you can look at them. But we are going to go through now several countries' updates about their poison centers. And we are going to start with Qatar, with Dr. Lina Amin. Dr. Lina Amin is a clinical toxicologist who is the director of the SIDRA. Did I make a mistake? Well, pharmacist and clinical toxicologist. Yes, clinical pharmacist and clinical toxicologist, director of the SIDRA Poison Center in Qatar. And she's going to give us an update about the Qatar Poison Center.
Good morning, everyone. Good morning, everyone. My name is Lina Amin. I'm the manager of the Qatar Poison Center in Doha, Qatar. And I'm a clinical pharmacist by training. And actually, I'll tell you a little bit about myself. I got my doctorate of pharmacy at Mercer University in Atlanta, Georgia. And after that, I moved to Chicago, Illinois to do my pharmacy practice residency at the University of Illinois at Chicago, and then did some emergency medicine training and actually worked as the emergency department clinical pharmacist at the University of Wisconsin in Madison, Wisconsin, before I ended up moving to Qatar and helping start the Poison Center there. So I'll tell you a little bit of history about Poison Center and toxicology in Qatar. So I know some of our colleagues from Qatar are here and can attest to this, but Qatar is a booming nation. It is rapidly developing. Some of you may be aware that Qatar 2022, the World Cup will be hosted in the state of Qatar. And with that, the infrastructure and development in the country is going at an astonishing rate. And that's not just for the infrastructure and the amenities that are available in the country, but also for the healthcare sector. And a few years ago, the WHO actually visited Qatar to assess the availability or the state of toxicology services, and found that there was really a lack of, obviously, a poison center and no standardized tox services available. A series of events then led to the development of the Qatar Poison Center, which has been running now for a year and a half. We opened October 1st, 2018, and it's the first and only poison center in the country. Some of you may, I don't know if you can see very clearly on the map, some of you may recognize it. It's actually the WHO directory of poison centers around the world. I wish I had thought of taking a screenshot of the before they recognized us as a poison center. So I could show you that, like, Qatar didn't have a red dot. All the red dots on the maps are actually poison centers that exist around the world. But before we opened the poison center, Qatar did not have any poison center established and didn't have any recognized resources available. But with the opening of the Qatar Poison Center, we were able to get that red dot on there for us. And to me, that's a small, big win in a way. Okay, so with our services at the Qatar Poison Center, if you were to visit us, which I encourage everyone to visit Qatar and come see us, we're practically identical in structure, organizationally, and in function to a standard North American model of poison centers. I know the Georgia Poison Center has some additional public health activities that we don't, but in general, our functions are very, very similar. We're staffed by US-trained and board-certified medical toxicologists and clinical pharmacists who are also specialists in poison information, or what we refer to as SPIs. And we run the call center that serves the entire country, but we also, where we dispense poisoning management advice, but we also have additional activities like research, education, training, and lots of public outreach. So Dr. Ziad mentioned that we're Sidra Poison Center. We're actually the Qatar Poison Center, but we're located at Sidra Medicine. Sidra Medicine is a state-of-the-art tertiary care center for women and children in Qatar. It opened, the outpatient clinics, I think, opened 2015, and then the hospital opened in 2016. It's an amazingly, incredibly beautiful building. It's probably the most beautiful hospital that I've ever worked at, and probably will work at. I have some pictures on there that you can see. But Sidra was, or is, part of Qatar Foundation. Qatar Foundation is a nonprofit organization in Qatar that was actually founded by Her Highness Sheikha Moza bint Nasser, who's the mother of the current emir. And it's comprised of over 50 academic research and healthcare facilities that serve the country. All right, so what do we do at the Qatar Poison Center? Well, obviously, our bread and butter, what we do every day, is to manage poisonings. And we do that through our nationwide poison helpline, through our call center. We also promote the development of toxicology in Qatar through education and training. We're involved in research, and we're heavily involved in public education, promotion, and awareness about poison prevention and management. And I'll discuss each one of those further. So for poisoning management, as I mentioned, our bread and butter, our day-to-day activity is providing care through our call center, which really serves everyone in Qatar. We get calls from public, we get calls from healthcare facilities all over the country. Surprisingly, we've actually had some international calls as well from over 10 countries over the past year. It's always a pleasant surprise to hear someone talk from, or request your advice and help from somewhere outside of Qatar. So it's nice to know that our reach and our help is able to extend beyond our borders. And our clinical management of poisoning complies or is standard with guidelines, policies, and procedures that follow regular standard of care that's in the US. Who works in the Poison Center? So our Poison Center, our call center is staffed by specialists in poison information, or SPIs. they're all PharmD, so they all have Doctorate of Pharmacy degrees with specific background in critical care and/or emergency medicine, and they've received some specialized additional training as specialists in poison information. They are the ones who receive the calls from the public. They're the ones who receive the calls from physicians, nurses, pharmacists, and various healthcare facilities all over Qatar. And they triage and manage those cases, they document them, and sometimes they involve our medical toxicologists in certain cases depending on our guidelines. And they're all, actually everyone in our poison center is bilingual, speaks Arabic and English, except for our medical director who only speaks English. Our call center is also fully electronic. We have online resources. We also document all our cases in a database that we maintain. Some of you are familiar with it from the US. And we have a very advanced telephony system that supports our large-scale functions. As far as education and training, as I mentioned, this is something that is part of the vision of the Qatar Poison Center, is to develop toxicology in the state of Qatar. We actually have started a medical fellowship in toxicology that's soon to be ACGMEI accredited. We actually have our first fellow from Kuwait who started in July 2019, Dr. Abdul Latif. He is. We also offer lots of poison center rotations in toxicology. We've had medical students from Weill Cornell and also from Qatar University. I also precept pharmacy students in both the Bachelor's of Pharmacy and the Doctorate of Pharmacy programs from Qatar University, and I do some teaching at the university as well. We also offer the Specialist in Poison Information training that's specially tailored and customized to what a spy would need to do or how they would need to function in a poison center in the Middle East. So it takes into account the challenges that they would face, takes into account language issues, and is really a fully comprehensive, very detailed, very intensive program. And we've also hosted several BHLS and HLS courses and others throughout the year. Just as this is for our medical fellowship program, just wanted to let everyone know that we are actively accepting applications. And if you have any further questions, you can speak to me or to our medical director. So in addition to our education training, I'm really proud to say that in almost less than 1 year since we've opened, we have completed 10 research studies. We've had 7 abstracts published and presented posters and or oral presentations at 13 local and regional conferences. Actually, one of our spies right now is presenting some of our studies at a primary healthcare conference in Qatar. Actually, I think her presentation was or is tomorrow. And we're also heavily involved in public education awareness. Public health awareness is not an area that's highly developed in Qatar, especially poison prevention. And so we have, over the past year, we have been involved and active in a lot of public events, public holiday events, health fairs, and pretty much every opportunity where we could have access to a large gathering, gathering of public, we've made sure to attend. And it's always gratifying to have people come up to you and say that they've called you, that they've spoken to you, that you've helped them in some way. We've also introduced National Poison Prevention Week to Qatar. This is something that did not exist before, and we've copied the idea from the US. And we did host an art contest for students from schools all over the state. Last year, we had over 600 applicants or art entries. So it's always really nice to kind of have the public get involved and become aware of poison prevention and just what you can do to serve them. Obviously, other than that, we've participated in media appearances, and we have social media accounts that we use to raise awareness further about the Poison Center. So if you're not following us, you can follow us at Poison QA. And with that, end my talk.
Thank you, Dr. Dina.
Any questions?
I follow you on Twitter.
Thank you.
Thank you. Can we leave the questions till the end, Mazda, because I have to keep going. And then Dr. Badir Hattali, Director of the Oman Poison Center. Dr. Hattali completed her fellowship at Emory University in medical toxicology. She's also the emergency physician consultant at the Royal Hospital. She's also working as well at Hamad Medical Center in Qatar. So she has multiple hats. And she is a board member and treasurer of Minatox. So she has all the money.
That's not completely true, by the way. Good morning, everyone. Thank you so much for being here and helping us with Minatox 2020. We are delighted to have all of you. And we would like to thank EBAT for hosting us this year. I've been giving an update about what is the process and how we are doing in Oman for the last probably like 2 or 3 years. So this is just a follow-up of what we are doing so far. So we are in Oman, we are like a population of around 4 million. Half of us are Omanis and half of us are expat. And you can see that, you know, there is a challenges when it comes to the kind of the exposure that we are facing, because it's like a different, we get like from different countries all over the world. If you look at the outpatient morbidity in the Ministry of Health, and this is for the last update 2017, you can see when it comes to the injuries and poisoning, we are just like way down compared to communicable and non-communicable diseases. And so it was really hard and difficult to convince the ministry how important is this specialty and how do we need to advance care in this field. Now, the majority of the cases that we are seeing are in pediatric population, and most of them are unintentional exposure. Though we see some of the occupational and environmental exposure, which is quite significant in the country. When it comes to all outpatient morbidity, there are around, this is basically based on an ICD-10 coding, so we are not 100% accurate, but we see around 90,000 cases related to tox exposure per year. And when it comes to the inpatient morbidity, there are around 900 cases. Now, the vision to start the poison center in Oman was started in 2015. And that's basically after I finished my residency and my fellowship and joined the Ministry of Health. We struggled to have a section, like let's say poison control section in the Ministry of Health, but eventually we were able to establish that and we published it by 2018. So now we have what is called a poison control section, which is part of the occupational and environmental health in the Ministry of Health. We are currently 4 medical toxicologists that have been trained in US, including me, Dr. Nadia Al-Hajri, Dr. Suad Al-Abri, and Dr. Walid Al-Sukaiti. That being said, all of us do a hospital-based service, medical toxicology service. So most of our job is basically related to seeing patients in the hospital and giving advice rather than a proper poison control center. The whole process is meant in collaboration with as I said, Ministry of Health, the contact center in the Ministry of Health, and the Oman Medical Specialty of Board. And the reason why the medical specialty was involved in this, because we were trying to push further this subspecialty and get the attention of the Ministry of Health. So the current situation where we reach, as I said, we will be able to establish a section in the ministry which was not there before. We are running multiple workshops and educational activities for the hospitals related to the Ministry of Health, and we did not reach to the public yet. We were able to do some sort of guidelines and policies, and we were able to distribute them in different institutes in the Ministry of Health in collaboration with the Minatox. Dr. Ziad Kazi was a lead in that. We also sent leaflets and educational materials about different aspects of tox-induced exposure in the country. Let's say, for example, snake envenomation, scorpions, different plants, different household products as well. Within the guidelines, we list some of the antidotes that is available in the country and where they are located, so that was easy for them to know exactly whom to approach. but we did not have a dedicated line. So most of the antidotes are not actually allocated in one place, but we have a pool of data that each hospital has this kind of antidotes, and so we were able to approach them if we needed. That being said, we are lacking like few expensive antidotes that is not available in the country. We also created somehow minimum, or let's say a minute triage dosing list for the primary health care facilities, which is the main, most of our cases, they go to the health centers, and then from there will be referred to the hospital. So we said if we provided this kind of list for the most common medications in the country, maybe we are decreasing the load on the hospitals by doing that. And we also created some charts to help them with the management of the most common exposure in the country. Now, when it comes to the laboratory capacity, we have a small lab within the section that runs basically heavy metals. We don't do more than that. And the reason why we are having heavy metals on board, because we see lots of cases related to mercury and lead exposure, specifically because of the preparations, like the local or the traditional medicine that's being used, quite common in the country. The last step that we approach is we asking the contact center in the Ministry of Health to take our calls. And we are starting to train the nurses in the center, basically to receive and triage the cases for us. So let's say, for example, a patient who is coming in the primary health care, we have a facility which runs from 7 a.m. till 10 p.m. at night. So we are covering that section basically with a direct line that can give an advice whether they need to go home or they can be referred to the health center. And we have the medical toxicologist will be 24/7 on call for that facility to give us. In terms of the surveillance and database software, we had a manual notification forms that's basically entered through and fed through the EB data, and then that goes directly to the surveillance department in the Ministry of Health. And recently we will be able to change it to the electronic notification. And so we get direct number of cases from all the institutes that belongs to the Ministry of Health. Now, we were able to create electronic data entry system in the contact center, which is basically similar to the notification form that we distributed. And this is basically will give demographic feature, the kind of exposure, and the follow-up for the patient as well in an electronic form, which is locally prepared and distributed. So hopefully that will work. We are still in the first year of using that one. Now, the challenges that we are facing, I guess it's the main thing is that we still did not convince the ministry how important is to advance this care, and one of the challenges is the financial support. Unfortunately, because of the crisis that the country is going through, we could not advance this in a rapid way. The human resources have been asking for more and more toxicologists, more of poison information specialists that can provide the care for us, the equipment, facilities, and technical support, of course, to increase the laboratory capacity. And there is a step forward in terms of the Central Public Health Lab, where all of this will be integrated together. We have issues with toxicovigilance. We don't have that yet in the system. We have only a simple surveillance system, and that should be. And then we started with the collaboration with different countries in order to help advancing the care, and hopefully we can reach somewhere in that. So that's basically an update about what is going on in Oman.
Thank you, Badriya. Some updates about the Kingdom of Saudi Arabia's poison centers. By the way, for Turkey, there's a session on Turkey. We are going to collapse it with the afternoon session on Turkey. So Dr. Ainur Shaheen is going to do the Turkey update in her afternoon lecture. And we did that because we had to add the WHO speaker last minute.
Good morning, everyone.
Dr. Al-Maliki, sorry, Dr. Al-Maliki is currently a medical toxicologist in Riyadh at King Saud Medical City. He's actually probably the first medical toxicologist in the MENA region whose salary and job description includes medical toxicology, bedside care, and consultation at the hospital. And he actually completed internal medicine training, and we will not hold that against you, Dr. Al-Maliki, and then a fellowship in toxicology at Emory University.
Good morning, everyone. I would like to give you a brief background about the poison center in Saudi Arabia and the toxicology services. I'm internist and working at King Saud Medical City in Riyadh as consultant internal medicine and medical toxicologist. So I has nothing to, no conflict of interest to declare. So basically, what I'm gonna cover in my presentation is I will give you like a history about the poison center development in Saudi Arabia and what they do. Plus, I will share with you some numbers from the previous years, and at the end, I will give you an overview about toxicology consultation services in the kingdom. So, as you can see here, this is the mortality rate secondary to unintentional poisoning in the MENA region. As you can see here, rates are very high in both African and countries in the Middle East, like 3.8 and 3.5, as compared to other countries in the world. Despite having this high rate of mortality secondary to unintentional poisoning, there is a huge gap in poison centers in the MENA region. If you can see here, this is from WHO. This is the map of the poison centers all over the world. Like if you can see, there's a gap in poison centers in MENA regions as compared to other countries in the world. So again, here just to show you like few poison centers in MENA regions. What about poison centers in Saudi Arabia? Poison center in Saudi Arabia, like under umbrella of the Ministry of Health, and there's like a General Directorate for Poison Control Centers. Basically, the first poison center in the country has been established like 40 years back. It was in Riyadh. Year after year, some other centers has been opened in other areas in the country. So as you can see, this is the map of Saudi Arabia. Saudi Arabia is like one of the largest countries in the Middle East. The population is around 30 million. So there is 13 poison centers distributed all over the country. We have the first poison center that has been opened in Riyadh. Also, we have poison centers in other regions, like we have in Dammam, we have in Jeddah, in Mecca region, in the south, in the north. So basically, the total number is 13. So poison centers in the kingdom is like the function is not similar to the US model. They have different rules and functions. Basically, they have different functions. They have consultation services for drug and poison information. Also, they are handling some lab stuff. So they are doing forensic toxicology lab, also TDM, plus also they are doing like screening for drug of abuse for both like workers or even from healthcare facilities. They are doing some occupational and environmental toxicology, like screening for substance of abuse, biological monitoring of pesticide, plus trace metal analysis. Is poisoning issue in the Kingdom of Saudi Arabia? I will share with you like some data from 2017. This was like cases that has been reported to the Poison Control Center in the Kingdom. Total number of cases was 12,566. Still, this does not represent the whole number of cases. These are the reported cases. We have large number of cases not reported. Majority of cases were in kids under 6 years of age, and 12% of them has been admitted to the hospitals. 2/3 of the cases came from the public, while 1/3 of the cases came from healthcare facilities. So just if you will see here, 85% of cases occurred in children less than 6 years of age. In terms of substances that has been encountered, different substances like vitamins, corrosives, chemicals, hair dye, antacids, corrosives and chemical constitute the majority of cases. In terms of most commonly encountered medication, so vitamins constitute 13% of the cases, while exposure to paracetamol constitute around 8% of cases. So recently, over the last few years, what we did, we established a new hotline to receive consultation for poisoning and issues related to poisoning from healthcare facilities. So just for hospitals, if they have like someone in the emergency department and he need consultation regarding a patient with drug overdose, they will call the hotline 1937. So then if the caller is from healthcare facilities, calls will be handled by a medical toxicologist. But if the call is coming from the public, it will be handled by a general practitioner and sometimes clinical pharmacist. So basically, the medical toxicologist at the time being, we are only covering calls from healthcare facilities. So what we do in the medical toxicology consultation services, we are doing different tasks. We are handling consultation for poisoning and poisoning related issues. We are doing training staff, delivering courses in the field of medical toxicology and some public health awareness. So basically, if a medical care facility, they have a patient who was exposed to a chemical substance or intentionally ingested any medication, what they will do, they will call 1937, and again, the call will be directed immediately to a medical toxicologist in call. We are covering 24/7. We have 12 medical toxicologists on the service, covering all hospitals from all governmental and even private sector in the kingdom. So we give immediate advice about how to manage this patient disposition and follow-up. For some cases, if they need bedside consultations, we provide bedside consultations for some like critically ill patients, or in case we need to do that, plus follow-up. This is basically what we do for the consultation service. We are doing training during this service. We have trained fellows. Majority of our fellows are pediatric emergency fellows. So they rotate with us like for 4 weeks. And they are the first one, or the first on call for the services. Then they will discuss the case with the on-call medical toxicologist. Also, we trained residents from different backgrounds, majority from emergency medicine, but we have residents from rotating in ICU, pediatrics, and internal medicine. Also, we trained some clinical pharmacists. This is in terms of training. In terms of courses, we are trying to increase awareness about the importance of toxicology services in the kingdom. So we are conducting training courses in medical toxicology all over the kingdom. We covered 6 areas per year. The courses are directed toward emergency physicians, GP, and even nurses and pharmacists. Basically, the course is like 2 days to cover main aspects of how you can approach poison patients and management of these patients. Also, what is the impact of this service? Is it important, like, to have toxicology service? Yes, there was a huge impact in the kingdom. So, impact in patient care. So it has been found that a lot of unnecessary investigations has been stopped, unnecessary admissions to the hospitals, unnecessary antidotes, even unnecessary visits to emergency department. So it has impact on patient care and mortality rate. The cost, again, a lot of unnecessary like investigations, drugs, etc. Has been saved. Resource utilization. Previously, before we have this service, like each hospital is working alone. Like each hospital will stock its own antidotes, and some of these antidotes are very expensive. Now, after we have this service, we can share the resource between different hospitals. Like if we have someone who will need fomepizole and it's not available, immediately we can allocate resource from other facilities in the same area. So it will help to help them to save money. So unnecessary like antidote stocking has been decreased. Public health. After the service, like we have been involved in a lot of outbreaks. Like for example, last year, because we received like 4 or 5 cases about methanol in different hospitals in the same area. Without having this service, you will not discover these scattered cases. But because we receive over like 24 hours, we received like 5 cases of methanol in different hospitals, and this has been raised to authorities, the Ministry of Health, and it has been found that the common source was like contaminated juice in one of the restaurants. Needs assessment, toxicology, medical toxicology services helped the Ministry of Health to know what is needs for medical toxicology. Now they know how many cases we have per year. They know, like for example, how many cases of ethanol or methanol would we have per year, so that they can plan, for example, where to have antidotes, which area is in high need for this antidote or that. Before having this medical toxicology service, these figures were not there. What we are planning to do in the future, we started to have training courses for specialists in poison information. Last month, we trained 15 new spies. The majority of them, like if you can see here in this, the females are clinical pharmacists, the males are nurses. So we are planning to recruit these spies and to be like a first responder for to receive calls regarding toxicology from both healthcare facilities and public. They will do like triaging for the cases for us. We are preparing specific guidelines for them to know which case to be managed at home, which case, when to refer the case to medical toxicologist, which cases to be referred to healthcare facilities. Still, we do not have a lot of awareness in public health about poisoning, chemical safety, etc. So we are planning to have more awareness programs in the future. Also, we are hope that we will have a fellowship in medical toxicology in the future.
Thank you. Thank you, Dr. Melki. Our next speaker is...
Good evening, everybody. In this opportunity, I would like to thank you, Dr. Ziad, for his logistic and scientific support. In fact, I will talk about a brief introduction about poisoning control, Baghdad Poisoning Control Center. Yeah. Baghdad Poisoning Control Center located on the ground floor of Al Ghazi Hariri Hospital for surgical specialties within the Medical City Complex. It is established in 1998. It is nearby the General Emergency Departments of Baghdad Medical City, about 2 meters. About the infrastructure of our Poison Control Center, in addition to the administrative departments, we have an information department for which usually the patient presented for either consultation or information of agent. Of course, a special case report form were done, and after that, after interpretation of the whole presentation and clinical picture, we usually send for the command toxicological unit or screening in the other department, which is called laboratory departments. And then these data were kept in a special statistic unit for research for retrospective studies. Why Poison Control Center is important? As I said before, it provides a database about the drug intoxication and chemical exposure that involve our local society, and has the ability to diagnose and to suggest the guideline management for each type. Second, training services for emergency departments. We are a part of the training courses of those in emergency medicine, pharmacists as a clinical toxicologist or non-medical toxicologist, and biochemists. In fact, many research have been achieved with the aid of these animal statistics, retrospective studies like lead poisoning, organophosphorus, and so on. And the information about any agent, it is always available, and about the antidotes, indication, uses, side effects. Also, through in participation in mass gathering people exposure and CBRN teams. In fact, how does it work? Either directly, the patient presented by his relative, with his relative, for example, chronic lead poisoning, thallium, or indirectly by phone call or written request. In this case, we ask for the complete data about the clinical picture and complaint and their investigations. Also, we ask our blood and urine sample, gas clavage, or a container of the suspected drug to be poisoned. This is a summary of the mean number of patients presented with positive clinical finding and confirmed by laboratory diagnosis. For example, of insecticide people exposed to, whether it is organophosphorus or organochlorinated compound or pyrethrin, about 60. This is the mean level, and usually presented from the emergency departments. Paracetamol poisoning, I mean paracetamol poisoning, not overdose. I mean it is more than 150 milligram per kilogram body weight. And of course, the guideline management for all of these patients usually supported by the Poison Control Center. In addition to our work, there is a special request from other, for example, GIT centers. It is about 100 and 250 in order to exclude Wilson's disease because the availability of these devices for levels of estimation. There are certain historical events during the last 20 years. The Poison Control Center plays a major role in diagnosis of something that have a major effect on the community, on the health, on the environment. For example, this is one of them. In 2,000 years, there are more than 2,000 cases of lead poisoning reported to our poison center. This was recognized at that time because of first, they were using a tetraethyl lead in order to increase the octane number of petrol and oil refinery system. The second reason, that lead oxide leads for batteries locally made in a closed ventilated room. During the period of embargo in low socio-economic states, most of people recycle the old batteries. And usually you should change the lead oxide plate for these batteries, which was illegal and does not meet the requirements of Ministry of Environment. I mean, it is not licensed. Of course, many of them are presented even of fit encephalopathy. We have treated so many of them with combined therapy, BAL and calcium disodium ethylate. Another important historical event, this is during the wartime, kidnapping and theft by using benzodiazepine, lorazepam, clonazepam, midazolam, or directly spray directly over the face, or these substances usually injected to the Pepsi or any juice can. The taxi driver are the most likely victims. Another historical event which happened, criminal, most likely, from 2008 up to 2015, about 82 cases reported. It is included, also Al Jawiya Sport Club, it is included in these statistics. The first one, this is the most likely patient presenting usually crippled and alopecia. This is the most likely with subacute or chronic poisoning. Sometimes they presented with alopecia alone, or rarely it is presented with a bluish discoloration or desquamation of the skin. Another historical event, mustard agent by ISIS. In fact, Taza village involved, which was belonged to Kirkuk city, the formal number was 60, and the public number is thousands. Also, many of our soldiers exposed in Abar region, and there are so many times they were exposed to in Mosul city, many times, 10 times. This is the most likely, Abulle is the most likely typical appearance of a blister agent. Chlorine gas exposure for more than 10 times. This is an example. Al-Taji area, more than 100 people exposed. Al-Sadr area, more than 300 people exposed. We treated them, we gave them the major guideline for the treatment of chlorine gas. Yeah, this is the mass gathering people exposure during a religious celebration. In fact, millions of Al-Shia usually walk to the Imam. In this religious activity, we have to support them by referring a special team to walk the medical team at that time in case of poisoning. These are the usual antidotes available nowadays in my center. In fact, the antidote is problematic for all of them. We don't have, for example, FAB for digoxin and other, some of them are deficient. Of course, there are atropine or naloxone are available in the other departments, like anesthesia and so on. These are the devices that usually used by my lab. The first one is atomic absorption. We have 3 devices. Routine work, we measure copper or lead, but for some research, of course, we can measure some other materials like cadmium and so on. Spectrophotometry device and telechromatography, these are both a procedure for drug screening test and HPLC. A new device were added nowadays for therapeutic drug monitoring and drug of abuse, still in the process. We hope in the future we can estimate the serum level estimation of some drugs. Our vision for the future, the antidotes should be available all over the time. Updating our devices, for example, GC-MAS and ICP, inductively coupled plasma emission, and isolated equipment and fully equipped with high-skilled medical personnel. A new academic study in clinical toxicology that offers a master or board-certified region participation in scientific conference in this field. Thank you.
Thank you, Dr. Hamoudi. Last but not least, Dr. Tarwa is going to give a brief presentation, followed by lunch.
So the slides will be there, right?
Yeah, we can see the slides.
Good morning, everyone. Good morning, everyone. So basically, in Lebanon, we do not have a poison center. We have a toxicology service. And this service was established in 2015, and really all the efforts go to Dr. Ziad Azzeh. and Dr. Evelyn Hatte, our chairperson of the Department of Emergency Medicine. And I recently joined in 2018, and we are co-directing this service, myself and Dr. Qazi. It's an MOU between Emory University and AUB. It's basically a telephonic consultation service that's offered to the healthcare providers, the patients also who present mostly to the emergency department. And lately we've done agreements with other hospitals, so now they have our call system, they can all call us, but not really from the public. And it's a 24/7, there's a call system. The first on call are the international toxicology fellows at Emory University. And it is directly supervised with different attendings. Myself, Dr. Qazi, and we have Dr. Brent Morgan from Emory University. And we have collaborations with the Emergency Medicine Department, the hospital pharmacy, the lab, and environmental core lab for additional testing. The Emory faculty team, Dr. Brent Morgan, Dr. Pomerlew, he's now in Australia, and Dr. Melissa Gittinger. Our toxicology officer, Ms. Zainab Naimni, who maintains the data in RedCap and follow up on the patient 24 to 48 hours after discharge from the emergency or from the hospital if they got admitted. And we recently published our data at Clinical Toxicology. We basically reported, it was a descriptive analysis, and we reported on our challenges. And recently we're working on another paper to report on how this tele-service works, maybe other areas in the Middle East or the areas where there's no clinical toxicology service could benefit from this. Mostly the age group that we had most of the ingestions were from 20 to 50 years old. And interestingly, the pediatric exposures, 24% occurred in children less than 5 years. And these typically are unintentional ingestions, we know that. And if we have a poison center, they could easily be triaged without really presenting to the emergency department. And here comes the benefit of having a poison center. And we're looking at this subset specifically now, myself and Ziad, to see how many of those could have been just triaged at home without even presenting to the ED. In the US, 12% of the children who had the toxicological exposure were managed at a hospital, and the majority really could be triaged through a poison center. We had a predominance of female in general, and specifically those who had suicide ingestions were mostly females, and we're looking at this subset separately now and just analyzing them to see what really were the risk factors for this. In the age group that were less than 12, we had female and male nearly equal, but in the adolescent and the adult, females just had the majority of exposures. Mostly we had unintentional, and interestingly that the intentional was around 51.6%. Usually unintentional are more than the intentional exposures, but in our setting, but we have some limitations. This is just one toxicology service at a big tertiary center. Household chemicals were mostly unintentional in children, and this is mostly because of improper storage. We do not have really any child resistant. We do not have a poison center that spread awareness regarding the safety and safe storage methods at home. And the top 5 pharmaceutical exposures that we had were mostly sedative, analgesics, antidepressant, cardiovascular medications. This is similar to the AAPCC US data, except that we had more of sedatives and antipsychotics. Among the non-pharmaceutical, we had cleaning household exposures, pesticides, bites, and stimulants who were among the top 5 categories. Some interesting data is that we know all this opioid crisis in the US and other areas. In our country, we had more of benzodiazepines and sedative exposures. And this is part of it because people perceive benzos and sedatives as safe compared to opioids. And we're looking at this separately now in an ongoing research study, myself and Ziad. So this was the most category that we had. And acetaminophen, like other data in other areas in the Middle East and in the US, was the most reported pharmaceutical. We do not have IV and acetylcysteine. We use use the PO. We've been doing well with the PO and acetylcysteine so far. We didn't have really any issues, and it's really excellent. The benzodiazepines, as I mentioned, really is a common problem in our country. People are really more just scared to use opioids. And even we have another thing is that other than the perception of the patients, we have regulations regarding dispensing of opioids. We only have tramadol that requires a prescription. We do not have like Percocet or other really medication that could be dispensed. And just at the hospital, you have the morphine. So this regulation helped in limiting the opioid misuse and overuse. Special situations, we have Diongzit. I don't know if you're familiar in some areas in the Middle East with this medication. It's banned in the US. It's a combination actually of a very terrible combination where you have an antipsychotic and a tricyclic antidepressant, melitaricetam, and it is very commonly used. I mean, literally people would go to like death ceremonies, you will have Diongzit. It's something like, if you're stressed, they will take a pill of Diongzit. This is very commonly used. And also we're looking at this separately. And it was reported in our 13 cases of our exposure. We had also interesting cases that led to death because of a tumescent liposuction that occurred at clinic, mostly with lidocaine. We had 2 cases. And an intragastric Botox that led to bad neurological outcome. Also, this was used. And also we had other non-pharmaceutical environmental exposures due to Datura stramonium, where patient presented with an anticholinergic toxicity, and this was also common. Another special situations where we had elemental mercury. It's still used in some areas, not that common, but it's still used. And pesticides, we also had lots of pesticides, and lately we just took care of a severe pesticide exposure. And cardiovascular drugs also is very common, and this was among our top 5 pharmaceutical exposures. We have limitations of antidote. We do not have the digibind for digoxin, though digoxin is very commonly used. I use it in my emergency department because we do not have the IV diltiazem. So it's commonly used, and surprisingly, we do not have the antidote for this. But we didn't have really much cases. We had 2 cases, and one of them, because of the use of a Jamaican stone, more of an Ayurvedic medicine, where the patient presented with a ditch toxicity presentation. That was managed with supportive care and eventually did well, luckily. For the snake antivenom, we do have it, but we do not have a local production for that. We imported from Syria. That it mentioned on the leaflet that it covered our 3 poisonous snakes. Currently, for a short time, we had a shortage because of the situation, and we were importing from different areas, but now we have it back in stock. We do not have, at our university, because it's more in the urban, we really do not see much of the snake envenomations. As far as for the medical outcome, we had no effect or minor effect. Few had the moderate to major, and we had 3 deaths in our data. We took care almost of more than 500, but at the time, 477 patients were analyzed in this data set. And the deaths were mostly due to lidocaine and tricyclic antidepressants. 18% left AMA, and this is something common. I mean, we have some limitations. Also, insurance companies do not cover for poison exposure, and usually the families want to discharge the patients, but usually there is a family member. But we were managed to follow up through our officer on 46.6% of those patients were followed up, and they did not have any major events. We have future plans. We're now trying to collaborate with other hospitals to increase the use of this telephonic service, and to collaborate with the Faculty of Health Sciences, with the MOPH, and hopefully we will have in the future to train toxicology fellows once we increase our team. Thank you so much.
Thank you, Dr. Wat. Thank you. The US model. Dr. Lina Amin, you want to go up here so you can use the microphone. So the question is, why did the Qatar Poison Center decide to use the US model? And the question is from Dr. Mazda Shirazi, who is in the US model as well. So.
I run one, so I know.
Partly because we recognize that the U.S. standard of poison center is the most established and most developed, with lots of supportive data that show the influence and the reach of those poison centers in their communities and in their states. Partly also because I trained at the Georgia Poison Center. Our medical director is U.S. trained. We all have, most of us have U.S. training. But yeah, I would say because of just recognizing the U.S. Poison Center model as being, after observing the other poison centers around the world, just being maybe the most organized or the most systematic in their approach, with just better support and better funding and being able to reach their communities better.
Any other questions? After lunch, we are going to tackle education and practice of clinical toxicology in the MENA region with a panel and some presentations. We are going to look at a specific example of a medical toxicologist supporting an outbreak of lung injury from vaping products in Illinois, in Chicago. We are going to also talk about chemical security and chemical inventories, and then finish up with a look at forensic toxicologists. What do they do and how do they interact with clinical toxicology? And a brief session on lead poisoning. So that's what we have for the afternoon. Sorry we took into your lunch break. Enjoy. And please come back 10 minutes after the scheduled time. So instead of 1:30, come back at 1:40 so I don't owe you any time. Thank you. The afternoon session, after your long lunch break, it's my pleasure to introduce Dr. Trevon Thompson, who's a colleague, a dear friend from Chicago, Illinois. Dr. Trevon Thompson is an emergency physician and a medical toxicologist. He trained in toxicology at the Toxicon program in Chicago and is currently the director of the Division of Medical Toxicology at the University of Illinois at Chicago. Dr. Trevon Thompson has had a unique opportunity and experience in dealing with outbreaks and collaborating with his health department. So we wanted him to share with us his experience in that area. Dr. Thompson, thank you.
Thank you. Alrighty, good afternoon. I have the challenge of being the first speaker after lunch. I hope you can stay awake. I am Trevon Thompson. I'm a medical toxicologist and emergency physician at the University of Illinois in Chicago, and I want to talk to you about a few things here this afternoon. Most importantly, maybe I have no conflicts of interest to disclose. Probably important when talking about poisons, so I'm not trying to facilitate or encourage poisoning. I want to start just a little bit by giving a little bit of background before I go too far into my talk, and that is to talk about medical toxicology in the United States. I think you heard a little bit about this morning when Dr. Lopez was talking. You're going to hear some more about this from Dr. Wax and some others, I think, this afternoon. But I think it's important that we understand kind of some foundational background from where I come from and talking about some of how these outbreak investigations have occurred. So quite obviously, I think, we may know now that medical toxicology is a subspecialty. In the United States, it is primarily a subspecialty of emergency medicine, though there are other pathways into medical toxicology, internal medicine, pediatrics, preventive medicine, et cetera. But it is an organized subspecialty that requires fellowship training. It's a 2-year fellowship training program. There's a certification exam, and then there's maintenance of certification. This is all important, I think, in understanding that medical toxicology is well developed, as was talked about earlier this morning, in the United States. And we have a built-in collaboration with our Poison Control Center network and the National Poison Data System. So through our poison centers, which you heard a lot about this morning, we are able to collect both regional data. So in Illinois, for example, the Illinois Poison Center, we're collecting on a daily basis our regional data regarding poisoning and reports of poisoning to our poison center system. But also all of our poison centers in the United States feed into the National Poison Data System so that we can actually track data on a national level as well. Now that's important as we think about the concept of the medical toxicologist as a collaborator. And I think we are uniquely situated to be a collaborator in many regards. One may also seem obvious, but I think it's worth mentioning. we, at least the way I function in my service at the University of Illinois at Chicago, we are a consultation service. So an internal medicine team or an emergency department or sometimes even surgeons or neurosurgeons may consult us, asking for our recommendations on how to care for someone they're concerned about a poisoning, is poisoned, et cetera. So we're naturally working with many others as it relates to the management of a case. But it goes beyond that. If we think for a moment about those of you in the room today and some of the others that you may have heard from, we collaborate with pharmacists, with nurses, with other healthcare professionals on a regular basis. My division, for example, of medical toxicology consists of 2 pharmacists who have extra training in clinical toxicology. The SPIs, the specialists in poison information who may answer the phone at the poison center, might be a nurse, a pharmacist, or a physician. So we're always collaborating just as a natural function of what we do on a day-to-day basis. With that, I want to highlight a couple of outbreaks that I was involved with and have been involved with. And these are just a few of several, but these are ones that have been published that will really highlight some examples of how the medical toxicologist can function as a collaborator with public health in dealing with poison outbreaks. So this case here, this was a fentanyl outbreak that occurred, not the current one that's going on in the United States, but the one that occurred in 2005. This centered in the Midwest, primarily in Chicago. And there's an interesting story here. So I was a first-year fellow when this happened. This was an evening. I was actually leaving from my office, my fellow office, to walk to my car when I got a page from our emergency department saying, hey, we've got several cases of heroin overdose that are acting a little bit funny. The first thing is that we've got 6 that have come in a shift, and some of them have required more naloxone than regular. So at least in the United States, many times the medical toxicologist is not being consulted for a heroin overdose. That's sort of a routine type thing that you may take care of in the emergency department. So already alarms may be going off a little bit that an emergency physician is consulting us for a heroin overdose, because that would seem ordinarily to be bread and butter emergency medicine. But these cases were unique. Several of the cases were people who were using what they thought were their usual doses of heroin and then immediately dropped, were becoming apneic or unresponsive. Many did require more naloxone than usual to reverse. And then when I started talking to folks after they were awake, some interesting features were going on. In this case, we had 6 in our emergency department at that time. They all said they got their heroin from a new drug dealer, which is always a little bit suspicious. But this drug dealer was giving away the heroin, which is also even more suspicious. No drug dealer is giving away their drugs. But this was a new dealer who was trying to drum up business and had a deal where you could get your first dose literally for free. It turns out, so we alerted the Illinois Department of Public Health to these cases. A larger investigation ensued, and it turns out that there was an importation of fentanyl into Chicago. This was imported from Mexico. This quote-unquote heroin turned out not to be heroin at all. It was all fentanyl, which is why these patients were dropping so quickly. And it turns out we, in about a 1.5 year period of time, had about a little over 300 deaths in just the Chicagoland area. We had 2 at our own hospital. So this was my first introduction to an outbreak as a fellow, but really I didn't know if this was bread and butter yet or something kind of out of the ordinary. So we'll fast forward just a little bit towards the end of my fellowship time. And so this was the report of a case of pufferfish poisoning that we had in Chicago, initially at least. So this was interesting in that through the Poison Center, we got word of a case where a lady, she was of Korean descent, but living in America, went to a Korean groceries market, bought fish labeled as monkfish in English, but labeled as pufferfish in Korean, brought the fish home, prepared a dish for herself, for her husband, and for her daughter. She drank or ate about 3 cups of the soup. Her husband ate about 1 cup, and her daughter just took 1 teaspoon of it. She knew it was pufferfish that she was buying, and just as a quick reminder, pufferfish contain tetrodotoxin, which is a poison that can lead to paralysis and kind of sensory deficits as well. So she eats the soup. She becomes almost immediately symptomatic, has some GI upset, and then develops severe paresis of her lower legs. She developed numbness and tingling in her arms. She had gross truncal ataxia. Goes to the emergency department. The emergency physician, thinking this might be pufferfish poisoning, calls the Poison Center. We're looking at this case thinking, yes, it does certainly sound like pufferfish poisoning, But another alarm went off in that in the United States, pufferfish is very heavily restricted. It can only come in through one route in the United States, can only be sold in certain establishments, particularly restaurants. The regular consumer should not be able to go to the store to buy pufferfish. So our alarms went off with just this one case. We alerted the Illinois Department of Public Health. We actually sent some of our own team to the family's home to retrieve the soup. That was ultimately sent off to the FDA and to some other bodies for testing for specifically tetrodotoxin and genetic testing of the fish to prove that it was pufferfish. A larger investigation ensued that led to the determination there was an illegal underground black market importation of pufferfish in the United States through California. And it was deliberate. So again, this fish product was labeled monkfish in English, but labeled as pufferfish in other languages. It was designed to skirt the regulatory guidelines for importing the fish in the United States. Also, turns out that there were 2 other cases of pufferfish poisoning, one in California that actually occurred a few months before ours, but it was never reported. Then there was a subsequent case in New Jersey, all related to the same illegal importation scheme. So again, highlighting a little bit of where medical toxicology can help with collaborations with public health, and I'm going to come back to this in a moment. The last outbreak that I want to talk about is more modern. So this was about March of 2018. In Illinois, our service was consulted on 2 index cases, it turns out. This was a father and son who presented to an emergency department with bleeding, primarily hematuria, and really no exposure for why they should both have hematuria simultaneously and other bleeding. Turns out they looked a lot like rotificum poisoning. Their INR was almost undetectable. It was so high. Didn't really make sense, though, because they had no known exposure. They were both factory workers, and they thought that perhaps there was some dust in the factory they were exposed to. That was the only exposure they could identify. But there was nothing that really explained why this father and son all of a sudden developed a profound coagulopathy. So those 2 cases came into our service through the Poison Center, and we immediately actually alerted the Illinois Department of Public Health in this case as well, mainly because we couldn't understand what was going on. The circumstances did not make sense. So a few days go by. Several more cases of patients randomly sort of showing up in emergency departments in Illinois with profound coagulopathies occur. Through history taking in these subsequent cases, we learned that there seemed to be some sort of association between this coagulopathy and people abusing synthetic cannabinoids. And then we were able to go back to the 2 index cases, ask them direct questions. Were you using synthetic cannabinoids? And they answered yes. That actually began the investigation to determine that there was, in fact, a big outbreak of synthetic cannabinoids contaminated with or adulterated with long-acting anticoagulants, primarily rotificum. So I highlight these 3 cases, not to highlight because I was involved with them. These just happen to be 3 cases I was involved in. A lot of my colleagues in medical toxicology have been involved in similar outbreaks. I think if you were to go around the room, you'd find that many, you see some heads nodding here, have been involved in outbreak investigations or alerting public health officials about a potential outbreak. This seems to be a common occurrence within medical toxicology. And so in thinking about medical toxicology and also our Poison Center network, we are often the first to know about a toxicologic outbreak. Our eyes and ears are to the ground, so to speak. We're sort of like first responders in a sense, in that we have a sense of what's going on, whether in your local areas as it relates to either drugs of abuse or pharmacologic agents or what have you. So we tend to have our nose to the ground and can sense when something just isn't quite right, even before perhaps there's a large number of people involved. So what has my experience taught me with dealing with these outbreaks and some others that I've been a part of? And I'll talk a little bit about EVALI, or e-cigarette and vaping associated pulmonary injury, on Friday, so stay tuned for that if you want to come back on Friday morning. We're going to talk a little bit more about that. But I want to highlight a couple of concepts that I think are really important in understanding where the medical toxicologist plays their role in public health outbreaks and collaboration. So I think this is probably obvious. We're all here sitting here at Minatox. Medical toxicology is an amazing field of specialization. I think that goes without saying. In addition to the breadth and depth of cases that we may take care of, we are really in a unique position to, one, prevent many poisonings, but then also manage poisonings, because many poisonings are treatable when you know the right treatment to provide. So we can be a big benefit to not only individuals, that individual patient that we may be caring for, but populations at large. And I think that's an amazing thing that I'm glad to be a part of as a medical toxicologist. This is an important part here. We are truly a clinical specialty, sort of the old-fashioned investigators of medicine. What we do is really take the historical features of a poisoning, the complete, not just the history of present illness, but the complete circumstances surrounding a poisoning, relate that to the clinical presentation that we have based on our clinical exam, and then add to that whatever laboratory data that we may use to then come up with what an answer may be for a case. And a good example might be acetaminophen. You can have an acetaminophen concentration, but without the full picture of what's the clinical circumstances, that level by itself is hard to interpret. Pick a level, it doesn't matter which. That level could be different, have a different meaning if it's 4 hours after a single acute ingestion of acetaminophen versus 20 hours after a single acute ingestion versus 4 days after. What if it's a repeated supratherapeutic ingestion instead of a single acute ingestion? Or what if the patient presents with an undetectable acetaminophen level, having told you they took acetaminophen, but your liver enzymes are completely abnormal? Again, we take all that clinical information and kind of put it together like detective work to come up with an answer. There's not a single test, an on-off switch that we can use to make a determination. And it's that little feature, that detective nature of who we are, that's really important in how we can function from a public health perspective, in that oftentimes we may just sense that something is just a little bit off. For example, those alleged heroin cases that I mentioned that we were consulted on, they just didn't seem right. They didn't look like a heroin overdose. That was an alert. This pufferfish case, yes, it was just a single pufferfish case, but that should not have happened. We were able to sound an alarm. And with these synthetic cannabinoids, we didn't know it was synthetic cannabinoids at first. But again, why would these two individuals present with such a presentation that looked like brodifacoum or another long-acting anticoagulant? Something just didn't seem right, and that was the trigger to alert the public health officials. Again, we're a natural collaborator with public health in ways that I've just identified. And if you're paying attention to some of these cases, you realize we didn't have to wait for outbreak numbers or a huge number of cases before realizing that something was amiss. I think that's a key point in understanding what we do as medical toxicologists. We don't need to wait for there to be 100 cases or 1,000 cases to realize something is going on. We can oftentimes be that one single case that just, again, is not quite right, that can lead us down the pathway to collaboration. So, what roles can we play as medical toxicologists in collaborating with medical toxicology, or in public health, excuse me? Well, I think there's just a few things that really encapsulate what we can do to solidify this role. The first we've alluded to already, and that is surveillance. With having our kind of eyes and ears to the ground, we can be the first ones to alert public health officials that something is going on. I think that's highlighted earlier when we were talking about poison centers in general. I think we've seen a couple of examples here. That surveillance piece is key. We are subject matter experts, and this is really important. When it came to, for example, the synthetic cannabinoid anticoagulant outbreak, our toxicology service were the ones who developed the treatment algorithm that we use throughout the state of Illinois, and even some other poison centers asked us for our treatment algorithms in determining theirs. It was that subject matter expertise that was important. We could be useful in helping determine what a case definition may be for a particular outbreak. We can help with resource utilization. There may be times when antidote may be costly or not widely available. We can help determine what the resource allocation may be in these sorts of situations. So being a subject matter expert is really important in these public health realms, realizing that our public health colleagues may be experts in public health, but they may not know a specific poison to the degree that we might know them. We can help inform law enforcement and investigative measures. So this is a little bit tricky in that we want to keep a divide between clinical care of the patient and sort of the med-legal system as it relates to, or the legal system as it relates to police and crimes and that sort of thing. Many of our patients may be doing something that may be considered illicit. For example, buying heroin off the street is an illegal activity in the United States. So whereas a patient may not tell the police where they got their drugs from or or some of the circumstances regarding their poisoning. They may tell us as healthcare professionals, and it's then important for us to feed that information back appropriately to public health officials in a way that keeps our patients in a safe space, understanding they can trust us with information without directly necessarily becoming involved in a law enforcement issue themselves directly. So while there's a tricky balance that has to be played there, it is important for us to know that certain pieces of information we may want to feed back to our public health officials in helping to realize what's going on here. And for example, the case of the fentanyl cases that we took care of, the dealer was on the west side of Chicago. We got that information from the patients directly, what corner they actually bought their drugs on. They were not willing to tell the police that directly, but they were willing to tell us as healthcare professionals. And lastly, we can help inform legal responses. I think this is important. Lawmakers are, I don't know how laws may work or how politicians, more importantly, may work in some of the other countries represented here, but oftentimes in the United States, politics is based more on image than what's actually the right thing to do. But there are times when we as healthcare professionals can help inform the law or the legal response. For example, and I'll talk a little bit about this on Friday with the e-cigarette pulmonary injury issue that's been going on recently in the United States. Many jurisdictions in response to an outbreak of pulmonary injury from electronic cigarette use thought to just ban e-cigarettes outright, or ban some of the flavorings that may be involved in e-cigarettes, or change the age requirements used to, or before you can buy these products. Thankfully in Illinois, before making any sort of rash response, our governor decided to form a committee to hash out some of the details behind what a legal response might look like. I was fortunate enough to be part of that and was able to offer some medical toxicology thoughts on what some of the outcomes might be for particular actions. Ultimately, we did not go with a ban in the state of Illinois and focus more on education, but I think informing legal responses can be part of the responsibility that we may have in helping with a public health outbreak, so that laws that may be passed don't have unintended consequences and ultimately lead to harm, or driving more patients to underground use of something that would be easier for us to take care of if we're above ground. So with that, we'll keep things nice and simple and keep us on schedule here. Medical toxicology and public health are natural collaborators, and I hope I made that case before you today, that the true nature of what we do as medical toxicologists directly lines up with us and keeping us as collaborators with our public health officials in many regards, not the least of which comes with informing legal responses and helping to be subject matter experts, to being that bridge between perhaps the patients and law enforcement, and being just that, again, natural collaborator to help surveil what's going on in the landscape of poisoning and outbreaks. So with that, I'm happy to take any questions. We should have plenty of time for questions, and I think we're close to on schedule now.
We have time.
Yeah.
Any questions for Dr. Trevon Thompson? Anybody has experience in outbreaks, being involved in an outbreak in your country? If you'd like to share it. Dr. Ihab, your microphone please, Dr. Ihab. Dr. Ihab Aki from Doha.
We have not like the outbreak. We actually, what happened that first case was seen by me, patient coming with severe bradycardia, hypertensive, after ingestion of some honey, which was made homemade honey. The other case came after 1 week, or after maybe a few days, and this was 4 cases actually. And we discovered that one guy brought honey from Nepal, and he distributed for friends, and all of them came in the hospital.
Well, that's a great example of an outbreak of, is this from Turkey?
No, the honey from Nepal.
Nepal. Because I think there's also we're going to have a lecture about mad honey poisoning in Turkey by Dr. Gunduz.
And we are raising the issue now for the public health, and it was a big issue actually. They start to investigate from where.
Yeah.
And
that's a great example. Thank you for sharing. Dr. Balla.
I have a question for you. In the first case where we pufferfish poisoning. So you detected 3 cases, and what were the agencies, law enforcing agencies you got in touch with? Did you go back to that Korean supermarket and see how many other of those mislabeled products were sold? Did you go and kind of track them, any one of them?
Yeah, so those are great questions. So we started with the Illinois Department of Public Health, was the first agency we notified, and then they made the further notifications to the FDA, the CDC, and some other areas. Interestingly, so I and my co-fellow actually went to that market. So both of us actually shopped at the same market that this outbreak occurred. We went looking for the fish, but there was none left. And it turns out the Chicago Department of Public Health ultimately also went to that market. And it turns out they had sold all of their product before we showed up. So it was actually all gone. They were able, they meaning Chicago Department of Public Health and some others, were able to retrieve some other specimens from the community that also highlighted exactly what I mentioned, that it was labeled monkfish in English, but pufferfish in Korean. And if you're interested, if you Google a picture of monkfish, it looks nothing like pufferfish at all. So it was clearly deliberate mislabeling. But we actually tried to be our own, as a medical toxicology fellow, I tried to be my own little investigator since I did know of the market where the fish was purchased, but there was none left. Yeah.
Dr. Balla?
And except for the wife and the youngest child, everyone was involved. We could never come to, it was the food which was mixed with OP, because 4 or 5 members showed up with classic OP poisoning, organophosphate poisoning. And when we went back, then we kind of investigated that the lady who prepared the food, the wife, and the youngest child, they consumed the food which was prepared as lunch. And rest everyone had the fresh food prepared as dinner. So whether it was deliberate or whether it was accidental, we could never figure out. But what we figured out was that they were storing the grain in a container which was earlier used to have, to store organophosphate. So that, and it is heat resistant. So that's how it got into the food, and that's how they kind of ended up having this problem.
I think you'll find in outbreak investigations, you have to really understand the local culture. You have to understand a little bit about the physical properties of the chemicals, the chemical properties, you know, what do they, their persistence in the environment, their heat, stability, all of that. You have to be a real investigator. We're going to highlight some of these things in our outbreak investigation workshop on Friday morning. If you're interested in attending, please let me know, because it's more like a limited space. We have some open space capacity if you're really interested in that. It's a 4-hour program, and you have to go through the entire program to get through it. So.
And I think you highlight a point that it's important to know and have an understanding of your local customs and practices. For example, with the pufferfish case, had we not known that pufferfish importation is highly restricted in the United States, we could have just chalked that up to some sort of fish poisoning and never investigated it. And it turns out that's what happened in those first California case. It wasn't thought of as anything in particular. But when you kind of have your, again, that nose to the ground and understanding what is the common custom practice, et cetera, in your region, when you sense something amiss, again, you can be that first alert that, hey, this just isn't quite right.
Okay, Dr. Gunja from Australia.
Hi, thanks, Trayvon. Very nice talk. I think I just want to highlight, we've all been part of many cases, I'm sure. I just want to highlight 3 which kind of complement what you've just been talking about. One was about 10 years ago, we had cases which were in the US and Australia, and they'd been going on for several months, but was finally detected when these children were swallowing little beads and then became unconscious. And it finally came out that one of the children actually vomited and also passed through the stool hundreds of these tiny beads, and we found out that the manufacturer in Hong Kong had switched, because it was cheaper, 1,5-pentane diol, which was used to stick those little beads together to make a toy, to 1,4-butane diol. And they thought, oh, that's the same thing, it'll work, it's cheaper. But we all know what 1,4-butane diol does in the body when metabolized to GHB. Another case we had, and your Korean case made me think of it, we had these Chinese patients that had all bought a certain product from a Chinese supermarket in Western Sydney and turned up with methemoglobinemia. They came into several hospitals, all within about a month of each other, and it happened because we have the poison center as well as emergency physicians end up being like a beacon that people call. And what happens in one location, it stays a secret. Nobody knows about it until it happens in multiple locations. And what had happened was this particular manufacturer had switched sodium borate to sodium nitrite to cure meat and so forth, and ended up with multiple cases of methemoglobinemia. And the last one that we've had just in the last few years was similar to the US and other places where there's been lots of heavy metals in Ayurvedic medicines from the Indian subcontinent taken by lots of people. And what I've learned, what we've learned from these several cases and others, is that the various agencies themselves were historically not talking to each other very well. So food is only interested in food. They don't care about lead, for example. Even if you ate the lead, they don't care about the lead. The environmental people are only interested in if you breathe something or touch something. They don't care if you ate something. And public health seems to also their funding issues are also tied to what is naturally what's most, where they're going to get the biggest bang for their buck. So often I find the poison center, like what you've just mentioned, ends up being like this tie-in organization that can talk to all these different people and provide that subject matter expertise.
That's an excellent point. Thank you, Dr. Gunja. All right, for the sake of time, thank you, Dr. Thompson. Move on to the next presentation with Dr. Andy Nelson from Sandia National Laboratory. Inventories promote security. So I asked him to talk a little bit about chemical inventories at a national level, why they are important, and how they improve security. Dr. Nelson.
Thank you. Assalamu alaikum. Good afternoon. So today I'm going to talk about a very seemingly simple topic, inventory management. It's going to access a slightly different part of your brain than the medical toxicology talks. But this inventory management is actually a very complex problem. So first I'm going to start with a story. In 2005, there was a new university formed in the United States in California, University of California, Merced. And they started a new chemistry program. And they had a new graduate student, Jason West. And this student actually had a history of creating methamphetamines. He'd been making methamphetamines for many years. He was an addict himself. He was also selling to friends. Well, he joined the university, and now he had access to large quantities of chemicals he could use to make methamphetamines. And he stole about 9 kilograms worth, or enough chemicals to make 9 kilograms worth of methamphetamines, which would be several $1,000s worth of equipment, several $1,000s worth of materials. And this went on for a couple years until he got really greedy and stole a vacuum pump. And that's when his research advisor noticed that he had been stealing things. And when the police investigated, they interviewed his advisor. His name's Matthew Meyer, and he has this quote: "Researchers generally assume that graduate students will recognize and appreciate the importance of the opportunities and responsibilities they are entrusted with to carry out research in cutting-edge laboratories. I am, of course, deeply disappointed that the trust I placed in one of my graduate students appears to have been broken." So what this highlights is that the only safety and security mechanism in place at this university at the time was trust. There are plenty of opportunities beforehand to catch this student, prevent him from having access to these materials. So why am I here today? So by training, I'm actually an environmental toxicologist and cellular toxicologist. So I PhD trained, 10 years of laboratory experience. So the main difference between my training in toxicology and most of yours is that if you have a problem, if you're sick, don't come to me because I'll just make things worse. And secondly, I never have to wear a tie to work. But in more sincerity, we're focused in risk assessment. And the environmental toxicology world has developed many different approaches to risk assessment, which actually leads nicely into the field of chemical security and chemical safety. So most recently, I've been working on some initiatives, actually along with Dr. Kazi. I'm leading a special edition in the Journal of Chemical Education to look at safety and security education practices in the United States. And we're finding some quite alarming results that very, very few universities, only about 30% of universities provide any form of security training. Fortunately, there's quite a bit of safety training. And actually, Dr. Kazi has a publication in this edition that just came out a few weeks ago that looks at some very interesting results for first responders and the safety and security practices of first responders. So I represent Sandia National Laboratories. We're one of the largest national laboratories in the world with about 14,000 employees. Our main site is in Albuquerque, New Mexico, which is we're in central New Mexico. We started actually as a nuclear weapons laboratory as part of the Manhattan Project in the 1930s and 40s. And since then, we've grown into a much larger organization, diverse organization that's committed to promoting global peace through various non-proliferation approaches, to include nuclear, chemical, biological, and radiological interventions. Albuquerque actually looks very similar to parts of Turkey. We have a balloon fiesta similar to parts of Turkey, so it feels very comfortable coming to Turkey for my first time. We work all over the world, so if you have interest in anything I say today and you'd like to collaborate, we're always happy to collaborate and share our experiences. We come mostly from a laboratory or a chemical industry perspective, but I think in the spirit of MENA Talks, sharing across different disciplines is extremely important, and that's how we learn and grow in each of our disciplines. So mostly what we teach is this concept of safety and security and different approaches to improve safety and security. So I think we're all familiar with the concept of safety where we're protecting people from chemicals, unintentional exposures, be it in the environment, in the laboratory, through our workplace. Whereas security is a little bit different. It's essentially the opposite, where we're trying to protect chemicals from people, so from bad guys that want to do harm with these chemicals. So effectively, we're trying to prevent the misuse, theft, and diversion of hazardous chemicals. And we do this through a variety of means in a systems-based approach. This includes physical security, transportation security, inventory management, personnel management, and information security. So these are what we call the 5 pillars of security. These apply throughout the systems-based approach for managing security.
Do you mind highlighting that a little bit more?
The systems-based?
These pillars.
Yeah, so physical security, the idea of physical security is pretty obvious. Physical things that you can touch. So gates, guards. In the biological world, biosafety cabinets could fall into this realm as well. Transportation security, this is how we securely move a biological sample, a radiological sample, or a chemical material from its source to the laboratory to the clinic, and then ultimately to disposal. And I'll show you a life cycle picture that will highlight that. Inventory management is really the tracking of materials throughout the entire life cycle. How much do we have? Where is it located? And how can we protect it? Personnel management, this is the idea of how much do we trust the people we work with? So if we look back to the California Merced example, they didn't really have a formal personnel management system in place. They could have done criminal background checks and found out. And I'm sure this happens in a lot of medical settings. There are criminal background checks of employees, but again, this differs around the world. Another thing with personnel management is access control. Who is given the opportunity to enter certain restricted spaces and not? And then information security. This is the idea of what information do we share with people of different access? How well do we protect our information? For instance, if you're sharing patient information, do you encrypt that as you email it to someone else? In the United States, we have HIPAA, the privacy protection for patients. That would fall well within the information security realm. So along with this security approach, we really just ask 5 questions. What do we have, be it chemicals, biological agents, pharmaceutical agents, radiological materials? What can it be used for? What kind of weapon could be created from it? What kind of abuse could be attributed to it? How badly does someone want it? So this is there a bad guy out there that wants to take it? Do you have an employee potentially that wants to take it for abuse, misuse? Why us? Why would someone want to take it from our facility specifically? And then lastly, how can we reduce our vulnerabilities? How can we protect ourselves? So coming back to this life cycle, what do we have? Particularly in the chemical life cycle, it differs from biology, where any chemical that comes to your hospital or clinic was transported from somewhere else. It was produced somewhere, transported. Then you have to store it and presumably or hopefully put it in your inventory. At some point you use it. In your case, you're delivering this to a patient. And then ultimately you have to dispose of what's not used. In other chemical industries, they're much more complex. There's recycling, there's reuse of chemicals. From the clinical perspective, you're mostly looking at these top 2 areas, the storage and inventory and the chemical use. So question for you, what kind of dangerous chemicals do you find, or dangerous compounds do you find in the hospital setting? Well, I'd imagine you don't find too much nuclear or high-yield explosive materials, but certainly you'll find chemical materials.
Nitroglycerin.
Sure, okay, so sure, nitroglycerin. Chemicals, you'll find fentanyl. Fentanyl is actually considered a chemical weapon by the Organization for the Prohibition of Chemical Weapons. Biological, certainly you have patients coming in all the time that might be infected with various biological agents, be it Ebola, hopefully not in the Middle East, but MERS, SARS, different biological agents. And then radiological, this is certainly an area that many hospitals have to deal with, particularly with blood irradiators, cesium-137, and also in some cases there's generation of nuclear imaging materials, such as gallium-68, FDG, these sort of things. So, question for you all, what is this chemical called? Yeah. Very good, thiomersal. Any idea what it's used for? Preservative of? Awesome, very good. So this compound actually showed up in an inventory for a research laboratory I was working with. And I'd never seen it before, but it makes perfect sense you would know what it is since it's a vaccine antibiotic. It stabilizes vaccines. One of the names for it is thiomersal. But the challenge with this name is that depending on where you are in the world or who you're talking to, the name can vary greatly. So these are just some of the names attributed to this compound. Same compound. All of these names refer to the exact same compound. We have similar issues with acetaminophen, paracetamol, right? Depending on where you are in the world, it has a different name. So for that reason, in the chemical risk assessment world, we tend to use the CAS number as the main identifier for the chemical. Because regardless of where you are in the world, the CAS number always remains the same. So the CAS number, CAS stands for Chemical Abstract Service Registration Number. So this is actually made by the American Chemical Society, or at least an off-branch of the American Chemical Society, and they have very tight controls on what CAS number is attributed to which compound. Now the reason we like to use this for our purposes is that from the CAS number, you can easily track it throughout your inventory and different people coming in won't mislabel the compound. So it's always the same. And then also, it's very helpful in risk assessment because you can easily look up the hazards by searching the CAS number in a variety of databases, such as the ToxinZ website. You could search that. You could also search PubChem from the NIH, National Institute of Health in the United States. There's a variety of resources. You can also see whether it's a chemical of concern for abuse, such as like Captagon. We know it can be abused in certain situations, and similarly for chemical weapon precursors. If you can search the CAS number, you can find out this information. So we're going to skip over how badly does someone want it and go to why us. Well, in security world, we like to think in systems, and particularly when we're applying mitigation measures, we like to have a systems-based approach. And we specifically put in different, what we call barriers or controls. And there are three different types of these. There's physical, so these are things you can see. Operational, these are the practices that we operate by. And then organizational, so these are our company policies, our clinic policies. So a good example of this is speed control. You've all seen speed bumps. There's about 300 of them getting out of the airport at the Istanbul airport. So those help slow his car down. There are also organizational barriers in place, such as speed limits, and then operational police cars, or the police going out and actually enforcing the laws. So I don't know if any of you have been to Albuquerque before, but we have among the world's worst drivers. People are constantly speeding and running red lights. And part of it, we have physical speed barriers. We definitely have speed limits, so laws, but we don't have enough police. So without the police, it's hard to really maintain this system together. Now, looking at this more in the context of laboratories, clinics, and science applications, with using inventory as an example, inventory itself, especially an inventory system itself, doesn't directly protect a chemical or a pharmaceutical. You have to put it into the system. So you have to have a physical control. So this would be the locking cabinet where you would store your compounds. You also have to have a policy to enforce that you will actually do inventory. So your clinic would have to say, inventory will be done. And then you have to have an operational aspect of, this is how we actually do the inventory. So the operational is, we would take that CAS number, put it into our inventory software, and then ultimately do inventory checks of chemicals that are in our actual locking cabinets. So Sandia National Laboratories has developed some software packages that can be helpful. These were primarily developed for chemists, chemical laboratories, but I think they could be easily adapted to clinical settings if you don't have current inventory software. These are freely available from the website listed here, csp-state.net. It has a user's guide available in English, French, and Arabic. And here's a kind of a screenshot of what it looks like. Once you put chemicals in by CAS number and barcode, you can then attribute various health hazards associated with it, quantities, expiration dates, and also it automatically populates whether this chemical is known to exist on an international control list, such as the Chemical Weapons Convention.
Did you say this is in Arabic also?
The manual is in Arabic, English, Arabic, and French. Completely free. We have this implemented in a variety of laboratories around the world, to include Southeast Asia, countries in Southeast Asia, South Asia, the Middle East, and North Africa. We are currently in the process of developing a new software that will be a network-based, so you could adjust it to your own needs. My understanding is that this will be used by the Ministry of Higher Education in Iraq as their formal inventory system. So our goal is to provide software packages and solutions to everyone that fits their needs. So if this is of interest to you, please reach out to me later and we can see if we can make something that's more specific to the clinical setting. So then lastly, it's important to remember that every barrier can fail, even really good barriers. So if you design say, a BSL-4 laboratory that is extremely physically well controlled. Those physical barriers only do so well if you have an employee that's going in that gets infected and then spreads it outside of the laboratory. So the same is true in chemical inventories. If you have a chemical inventory that works really well, sure, there are always holes associated with that. There's always a way to beat the system. So because of that, we suggest multiple overlapping barriers, such as physical storage, inventory, personnel management systems, and so on. So with that, thank you for your time, and take any questions.
Great, thank you. Any questions or comments about our role in this area of chemical security? The study that we did was looking at paramedics and the emergency medical services. What is their role in detecting chemical security problems? Because paramedics and emergency physicians as well are sometimes able to access the scene early, where evidence is still there, signs of a criminal activity is still visible. So paramedics and emergency medical services have a role in that. And same as well, I think, in the emergency department. If you have a patient that comes in with a chemical exposure, practice asking the question, what are you doing with that chemical? Why do you have that chemical? Especially if the chemical is suspicious. And wonder why you are stockpiling this chemical in your house. And we see that with the amphetamine labs. They come in with burns or explosions after, they'll say something exploded in my house, and then you find out it was an actual illicit drug laboratory at the house.
Yeah, and to that end, chemists, biologists in your country can be very great resources if something doesn't make sense to reach out to them and ask, could this chemical actually cause a burn like this? Since most chemists have experience with acid burns, we can always help in that regard.
Personal experience.
Personal experience, yeah. Hence the reason we don't wear nice clothes very often. So.
Thank you. All right, thank you, Dr. Nelson. And then I want to hear from Dr. Aynur Shaheen about what is being developed in Turkey. There are some important steps that have been taken in the last couple of years. And at the end, I want to invite some colleagues from the region to think through these problems and challenges, how we can adapt them and resolve them at our own level. So that with no further ado, Dr. Paul Wax is our next speaker. Dr. Paul Wax is a professor of emergency medicine at the University of Texas Southwestern. He's also the past president and the current executive director of the American College of Medical Toxicology. He has a tremendous wealth of experience in education, issues in toxicology, practice issues in toxicology, and it's really a unique pleasure to have you at MINATOX after so many years of supporting us. It's our first time that you are actually here in person. So, Dr. Wax, thank you again for being here.
Well, thank you very much, Ziad, and it's really a great pleasure to be here. And my first time to Turkey, my first MINATOX meeting, and I'm just really privileged to be here. You'll hear from me several times over the next few days. Ziad
he has 6 lectures.
6 lectures. Ziad has put me to work to earn my keep, but it's really my great delight to be able to have this opportunity and this platform. And so what I'm going to talk about now is medical toxicology practice and training with a U.S. perspective and some insights about the future, perhaps. And the objectives of this talk is to understand some of the training pathways in medical toxicology in the U.S., to learn about some of the educational opportunities for lifelong learning, to review key take-home messages from the ACMT practice survey, and to learn about areas of medical toxicology practice growth. As Ziad mentioned, I'm the executive director of the American College of Medical Toxicology. I've held that position since 2008 and was previously on the board of directors in a volunteer capacity since 1998. So I'm well versed in at least the history of the college and toxicology in the U.S. And we'll be talking a little bit more about ACMT tomorrow in a different session. But several of you in the group are members of the college, and we have international membership, and we're open arms to receiving more members. And I'm glad to talk to anyone about ACMT membership over the course of this conference. This is our board of directors. Ziad Kazi has been a board member now for the last 7 years, and has really provided a tremendous asset to the board and his perspective, particularly bringing in an international perspective as well. Because even though we're the American College, we are a global association. We have members from all over the world, and that makes it more robust to encounter folks who practice in different ways from around the country. And Dr. Chuck McKay, our past president, is here as well, and we'll be hearing from Chuck over the next few days as well. So I'd like to talk a little bit at the outset about training in the United States. Now, I should also provide a little bit of historical context. You've heard earlier today with Dr. Kilborn and others about some of the early history of medical toxicology, and the American Academy of Clinical Toxicology back in the 1970s established a certification exam in medical toxicology. At that point, there were no really formal fellowship training programs, but there were interested physicians who wanted to get some sort of certification. And so this was actually a subcommittee of the American Academy of Clinical Toxicology. They put together a rigorous examination, and at the annual meeting, they offered the exam to those who were interested in taking it. Over that time and through the 1980s, a variety of preceptorships developed where one spent some time with a board-certified toxicologist. One needed to gain that sort of experience in order to sit for the exam, and the first fellowships were established at that point as well. But it remained rather informal, although if one sat for the exam, it was quite the rigorous exam, and the pass rate was I think about 60% or so. It was a very difficult examination. It was in 1993 that the American Board of Medical Specialties conferred specialty status on medical toxicology. I'll be talking about that in a couple of minutes. And it was only in 2000 that the ACGME oversaw the development of fellowship training programs in medical toxicology. So right now, as you'll see, I think on the next slide, there's 28 training programs in medical toxicology across the country. Many of them are at poison control centers, although not all of them. These programs are 2 years in duration. There's rigorous requirements to get these programs approved, and this is for subspecialty fellowship training. And so the prerequisites to go into medical toxicology includes a primary residency in something. Now, depending on the fellowship, some of the fellowships, because of certain internal requirements, require the physicians to be trained in emergency medicine, while other fellowships have broadened it, and the initial primary residency is not mandated in a particular specialty. So it could be emergency medicine or pediatrics or occupational medicine or internal medicine. We even have a scattering of some psychiatrists and neurologists that have also done fellowship training in medical toxicology. This is a slide that looks at the number of toxicology programs and the number of fellows in training over the years. It's been relatively flat with a little bit of an increase in recent years. It's certainly a tiny specialty as specialties go. I think in emergency medicine there's close to 2,000 residents at any given time, and I looked back and looked at the percentage of emergency medicine folks that went into medical toxicology. I came up with a number of about 1.5%, so between 1%, 1 out of 100, or maybe 3 out of 200 go into medical toxicology. So it's a small number, but it's an important growth put. Now, there are different sorts of training opportunities, and on the ACMT website, we do have a list of these programs. There's both the fellowship programs, which I briefly described, as well as some clerkships, for instance. So medical students who are interested in medical toxicology, there's about 40 programs across the U.S. that offer usually 4-week-long rotations in medical toxicology. And then there are these 28 two-year fellowship programs. Some of the fellowship programs welcome international applicants, while others, because of usually internal funding necessities, limit it to domestic citizens. Now, the way fellows are selected is that they go into this match program. This match was just initiated for medical toxicology just a few years ago, and one applies. Many candidates apply to multiple programs, and for those programs who review the applications, and then they decide to interview the candidates, and then they put together their rank list from 1 to whatever, 5 or 10, based on the number of applicants they've interviewed and like to rank, and the applicants do the same thing, and this goes into a computerized algorithm, and the selections are then determined by the choice of both the candidate as well as the program. This is used in many of the other specialties, emergency medicine, internal medicine, surgery, and only recently has been used in medical toxicology. This is some of the results from the match in the last several years. As you can see, in 2020, there were 26 programs that were in the match, and 60% of those programs filled the slots that were available. In terms of the numbers of positions, of the 51 positions, 76% filled. So while these numbers are not at the 100% or the 95% or higher that you might get in some specialties, it's not bad. And several years ago, I did a study looking at other comparable specialties that don't fill their match, and there's a number of them, particularly some of the subspecialties in pediatrics, for instance, and there are a number of different factors that lead to these positions not getting filled. But I think in general we've done okay, and certainly we'd like to fill as many of these positions as possible, so we can add additional medical toxicologists to the workforce. If you compare medical toxicology with some other emergency medicine specialties at the bottom part, clinical ultrasound and EMS, which are relatively newly recognized specialties as emergency medicine specialties in the U.S., medical toxicology has been around a lot longer, but as you can see, there's many more now ultrasound fellowships and EMS fellowships. So I think medical toxicology has a place and has a loyal following, but the numbers are relatively small. For both clinical ultrasound and EMS, the fellowship duration is only 1 year, while in medical toxicology it's 2 years. And we recently discussed whether we could short track the medical toxicology training experience, but the overwhelming number of medical toxicology fellowship directors insisted that it remain at 2 years, just because of the tremendous knowledge transfer that's required during the training program. This is looking specifically at the 2020 match in terms of the number of matched applicants. As you can see, there's a couple of international physicians who matched, and then there are several people that did not match as well. Now, once one goes into the medical toxicology fellowship, it's again 2 years full-time, and then to become board certified in medical toxicology, there's a rigorous exam at the end of that 2-year cycle. This exam is put together by what's known as the Medical Toxicology Subboard, which has representatives from the 3 specialties that endorse the medical toxicology examination, emergency medicine, pediatrics, and preventive medicine. If a candidate is from some other field like internal medicine, they're also eligible to take the exam if they've completed their fellowship. And it's the American Board of Emergency Medicine that administers this examination. So way back when, before 1992, it was the American Board of Medical Toxicology, which was a branch of the American Academy of Clinical Toxicology that oversaw that exam. But that's now all been transferred out to the under the American Board of Medical Specialties, and in this case, the sub-board is just described. Now, the exam is based on the core content of medical toxicology, and I had the opportunity when I sat on the sub-board to be the lead on this paper, which put together the topics that fall under the rubric of medical toxicology. This was updated in 2012, although it remained fairly similar. And it's a long list of topics. It's not an exhaustive list, but gives the candidate an idea of what they're responsible to know to sit for the medical toxicology board examination. And the exam is put together using a blueprint, which essentially gives you the percentages of exam items based on area within medical toxicology. And I won't go through the list here, but you get a sense of that it is a diversified examination with items pulled from a number of different components of medical toxicology. These core content includes a listing of many of the types of drugs and chemicals and other sorts of components of what goes into medical toxicology, but it's not all inclusive. For instance, it mentions antibiotics, for instance, but it doesn't mention which ones. So the applicant is responsible to know really all the antibiotics. It's hard to have exhaustive lists on every last topic, and this is some more example of drugs that affect the nervous system. Again, they're groups of classes of drugs, but not necessarily specific drugs. Now, in terms of the number of folks that have become board certified in medical toxicology, once again, it's a tiny field, but you can see the number at the very bottom, 686. So those are the total number of people that have ever been board certified in medical toxicology in the U.S. And most of them came through the current subboard examination, which was initiated in 1994. So 611 of them were certified under the subboard. Now, as far as I know, this sort of rigor in terms of credentialing someone in medical toxicology is unique to the United States. I realize there are those in many other countries that have toxicology training. Some of them are within programs in clinical pharmacology or within internal medicine, but the maturation of training programs, I think, lags behind what's occurred in the U.S. In addition, the exam for the U.S., as just described, is limited to those who have trained at ACGME accredited fellowships in the United States. So there's certain limitations, and the exam in the U.S. is not open to those who have not fulfilled those prerequisites of training in the U.S. But I will add one other thing, and it's something to talk about and perhaps network on over the course of the next few days. ACMT has also developed a separate examination, which we call the in-service exam. The in-service exam is an exam we used for the fellows who were in training as a metric during their training in terms of how much they're learning. It's a rigorous exam. It's developed by ACMT. It's not developed by ABEM or the ABMS group. And we currently just use it internally for our current U.S. fellows. But putting together an exam is a very time and resource intensive process. There's a lot of rigor that under necessity is required to put the exam together. But Ziad and I on multiple occasions have discussed perhaps rolling out such an exam in another setting for those who might potentially be interested. A lot of factors would go into that decision making, but it's something that I'll just throw back out onto the table. Now, in terms of the primary board status of medical toxicology diplomats, as you can see, majority of them are from emergency medicine, as just described. There are some from pediatrics and from occupational medicine and internal medicine as well. This looks at back in the early days of what specialty they came from in the U.S. And back then it was about 56% emergency medicine and many more pediatricians and those from internal medicine. This has shifted over time, and now it's predominantly emergency medicine. I think this has its attributes and its drawbacks. Medical toxicology is not just emergency toxicology or acute care toxicology. I strongly believe of the heterogeneity of the field, and the fact is that in toxicology we deal with the xenobiotic exposures to human health, whether it be at large dose or small dose, whether it be in the acute setting or more the chronic or even the environmental setting. So it's really important to have physicians who are comfortable in all those settings, and this is not something that's unique to an emergency medicine physician by any means. So those who come from an internal medicine background or pediatrics or occupational medicine or even anesthesia, I think are very valuable in what they can contribute to the field, and we need to get more non-EM folks into medical toxicology. And again, this is looking at the total number of diplomats whose only board is in emergency medicine. As you can see, it's been in the mid to low 90s in the last several cycles, which I think is not necessarily the best trend, as just iterated, and it's important to get other folks into this field as well. So in terms of education beyond fellowship training and taking the board examination, ACMT, for instance, offers a number of educational opportunities. We just recently, just a couple of years ago, developed this Total Tox course, which is a review course not set just for the board exam. We also have a board exam review course, but this is more for the emergency physician or others that are interested in toxicology. The next course is in Minneapolis in August in 2020, but we thought there was a niche for this sort of course. There really wasn't anyone else providing such a comprehensive review course. And it's a 3-day course given by great faculty, including several of the American toxicologists that are here at this meeting. In addition, ACMT has our annual conference. The next conference coming up in March, just in a few weeks, and in 2021 it will be in Portland, Oregon, and 2022 will be in San Antonio, Texas. This is a conference that's really evolved over the years, and now we have approximately 350 to 400 people that attend from around the country and internationally as well. And we have a lot of research presentations, plenary sessions, and it's a great place to network. This conference has really grown tremendously over the years. But not only do we provide conferences as a way to provide professional enrichment, but we also have a whole series of webinars, and particularly in the last 10 years, it's been so much easier to provide information via webinar, and it really has no geographical limitations either, for that matter, other than some time zone challenges perhaps. And ACMT, we put on approximately a webinar every single week. These webinars are open for any of our members. You have to be a member to attend, but there's lots of webinars. Like I said, we have a webinar case conference, a journal club, a grand rounds, an addiction medicine journal club as well. So we have a lot of opportunities educationally. Finally, we also have a mentorship program. This is meant for any of the ACMT members, whether they're junior or mid-career, and with the idea that education continues beyond training programs per se, and there are new skills that some may have not been indoctrinated in during their fellowship that they want to brush up on or develop more skills to help further their professional career. And we just reinstituted this mentorship program just over the last year. So with that said and done about education, I just wanted to move into practice. And this is some data from a survey that ACMT did several years back, looking at how people practice and some of their thoughts about the practice and what they kind of needed for further professional development. As you can see, in the U.S. at least, the majority of physicians do practice in an academic setting, although certainly this doesn't account for all medical toxicologists. One of the things medical toxicology provides is a nice academic niche, for instance, for both teaching and research purposes, so it kind of lends itself to that. Most specialties, say internal medicine or pediatrics, the majority of physicians are practicing in the community. They're not academically affiliated, but in medical toxicology, it's generally the reverse. In terms of time engaged in medical toxicology practice, the majority of the U.S. medical toxicologists, or those who filled out the survey at least, only practice medical toxicology part-time. It's my sense that that many of our medical toxicologists in the U.S., not all of them, but many of them, if they had their preferences, would like to practice medical toxicology full-time. But there are certain barriers that we can discuss over the next few slides. Many of them, like their emergency medicine practice as well, and want to pursue practicing both emergency medicine and medical toxicology. But there are certain challenges. Speaking personally, when I did my emergency medicine residency. I thought I was going to be an ER doc, and that would be the extent of my practice. And as I took my medical toxicology fellowship, that really pivoted my career aspirations. And after that, I certainly wanted to do as much medical toxicology as I could, although I still, even at this date, still work in the emergency department as well. To work on expanding medical toxicology practice opportunities. I think this has been really a wonderful symposia that Ziad and his colleagues put together today with the convergence of both the clinical and the public health. And I think I'll briefly mention some of my public health interests in the next few slides, as well as a short talk I'll be giving tomorrow. But I'm a very big believer in gravitating toward both components, and part of the mission of ACMT is furthering the practice of medical toxicology, both clinically and also in the public health sphere. So this slide looks at some of the barriers to expand medical toxicology practice. Some of it is just the volume. If you think about your typical clinical practice, one of the reasons emergency medicine has turned out so well for most hospitals is they have this natural catchment of many patients seeking emergency care. So they put up a shingle at the emergency department, and plenty of people come, and you can make a fairly viable existence out of that sort of practice. It tends to be, in many places, the volume tends to be quite high, but you have the demand, which will help offset the costs. With medical toxicology, we're kind of so niche that it's sometimes hard to see enough patients to practice solely as a medical toxicologist. We don't have a particular procedure like many of the other specialties, and many of our patients are very complex, and they take very long to see, and you can't see many patients an hour like you could either as an emergency physician or doing some routine work in internal medicine or pediatrics. So there's some inherent challenges, I think, to building the practice, but there are also opportunities as well, and you have to kind of sell yourself and your knowledge. And earlier it was mentioned about the subject matter expertise, and you really have to fall back on that and try to market what you can potentially provide. In terms of income derived from medical toxicology practice, this pie chart gives you some example of that. And as you can see, the majority of medical toxicologists don't derive the majority of their income from the practice of medical toxicology. I think many would like to see the paradigm shift. And I think with some folks it is gradually shifting, but it's been a challenge and a struggle, and remains left to us and our creativity to figure this out and try to make for a smoother transition in the future. The ACMT also has a practice committee. We have a lot of practice resources on our website for members, and we've built this up over the years and try to provide more and more guidance for folks who want to learn about the practice of medical toxicology. We also have a bunch of position statements. I believe that advocacy is really one of the core missions of a professional society, and some years back there was some reticence about getting into the advocacy field, but I think one needs to represent themselves to promote their specialty and their members, and to stake out positions. And so we have a variety of position statements and guidelines, and some of these really kind of help you get recognized as well. So for instance, and we'll talk in a second about addiction medicine, but with the opioid epidemic and the necessity of really confronting this head on, and the use of buprenorphine, which can start in the emergency department, we wrote a position statement last year. And even though we were the primary authors of it, we got the support from the American College of Emergency Physicians, from AAEM, and ASAM, which is the Addiction Medical Society. And we went to them after we primarily wrote the statement and got their endorsement. So I think it goes to show the potential leverage one has if they take the lead, even with the much larger societies. This is another statement we put together on interpretation of cannabis metabolites, and there really wasn't much guidance out there. A lot of folks were obviously doing these sorts of testing, and we put together an expert panel to come up with the statement. And we have a number of other position statements on our website, and are always in the look for developing further position statements as well. Now, a couple accomplishments in the last several years was that in the U.S. now we do have a billing code for medical toxicology. Up until several years ago. For those who saw patients at the bedside and wanted to bill for those services, there wasn't a specific medical toxicology billing code. So it took quite a bit of an effort and perseverance from some of our members to get this through the CMS, but now there's a billing code for medical toxicology. We've also developed some quality measures in medical toxicology. This was another big effort, a lot of work behind this, and it's still an evolving process, but these were the initial metrics that we developed. Most specialties do have their own metrics, their performance measures, and which they're held accountable for increasingly, particularly from the payers. And medical toxicology didn't have anything, and people practiced every which way. There wasn't much consistency. So this is a start, and it's ongoing, and some of that needs to be continued to be addressed, I think, and taken seriously. I mentioned briefly before addiction medicine, and with the opioid epidemic, it's really provided an opportunity for medical toxicology to advance beyond its traditional boundaries. I look at other specialties that have really embraced new technologies, whether it's in surgery or even emergency medicine with ultrasound and other advances, and going beyond what they were initially configured. And medical toxicology had remained somewhat static in many ways, but with the opioid epidemic, despite the fact that there is a separate specialty of addiction medicine in the U.S., many of our members have taken this on and developed some additional skills. Some of them have become board certified also in addiction medicine as well, but there's certainly a societal demand for this sort of clinical service. As a result, and part of this process, ACMT has recently been awarded a $500,000 grant to do education in this area, and we put together a program called Sustain ED, which is substance use screening and treatment approach in the emergency department, with the caveat that we in emergency medicine and other fields don't do as good a job as we can in terms of identifying patients with substance use disorder. And so this is funded by the U.S. government. This is through SAMHSA. A number of specialties did get some grant money to put together some training, and we're just rolling out this training as we speak. Actually, it's going live this week, and we hope to expand this to other folks as well once we get this launched, but predominantly right now it's tailored toward emergency medicine residents and medical toxicology fellows. Lastly, I'd like to just mention our toxic program, and I think I'll mention this maybe tomorrow as well. So back in 2009, a colleague of mine, Jeffrey Brent from Denver, and myself, we put together the Toxicology Investigators Consortium as a way to utilize what we do at the bedside to improve surveillance, epidemiology, and research into poisoning. And seeing that more and more folks were seeing patients at the bedside, we thought if we develop a database for this, it may be very worthwhile to use this as a tool, as a research tool that stands apart from, for instance, the National Poisoning Database System, which is poison center data. And they all have their pros and cons. The toxic database is certainly much, much smaller, but we have about 80,000 cases in this database at this time. And when we initially launched it, we were hoping to get some international collaborators, and over the years we've had a few from Australia and Thailand and from Canada. There's something that probably needs to be revisited again. It's all web-based, and it's easy to use. One just has to put the time into putting the cases into the registry. But I thought, and I still believe, that this could be really a rich opportunity in terms of the sort of data we gather. What makes this stand apart from poison center data is that all the cases in the database are based on the physician's interaction with the patient at the bedside under the guise of a toxicology consultation. So if it's just an ER visit without a separate toxicology consultation, it really doesn't qualify. But if a toxicologist has been called to consult, those are the sorts of cases that we've put into the database. And we're starting to get some traction and some funding from CDC, FDA, and others. And I think goes to the robustness of what the medical toxicology community can contribute, that we're finally beginning to get some recognition. again, this is easy to adapt internationally. It's all web-based. All you need is a computer, but one needs the commitment to participate as well, because to put in the cases is time commitment. On the other hand, once the cases get in, you have a rich database to do research on. And if anyone's interested in talking more about this, I really would welcome that over the next few days. And we've published a number of papers on this. And last year, I think we published about 10 papers based on this database. So at that point, that's a kind of a brief purview of education and practice in the medical toxicology based on the U.S. model. And thank you very much for this opportunity, and welcome and open it up to questions at this time. Thank you.
Thank you, Dr. Wax. Wow, you know, I've been really fortunate to be mentored by Dr. Wax and Dr. McKay through ACMT, and I really try to emulate some of the ACMT passion and activities through Minotalks. And I think Minotalks is the little brother or little sister of ACMT. So again, thank you for your support. Dr. Bashatal from Emergency Physicians Association of Turkey. And don't worry about the time, so we can...
Thank you very much. You are welcome to Turkey, Dr. Parvez. It was a very nice presentation. You answered all of my questions about clinical toxicology. Even though the emergency training has started in 1994 in Turkey, but we still have not medical toxicology program. But we started it in a PhD program, not fellowship. My question is that, does everybody, every specialist, can get the medical toxicology in US in fellowship? The second question, if so, is it possible to get this fellowship program in their own clinic, or is it given in emergency department? And you finish your first aid, and the patient is need to be hospitalized. Which clinic do you send this patient for hospitalization, for further investigation? Thank you very much. You are welcome again.
Thank you. Again, it's really a wonderful opportunity to come to Turkey. The medical toxicology training programs, the majority of them are associated with emergency medicine programs, but not all of them. And they don't need to be associated with emergency medicine programs. There's a program actually in Phoenix, which is really apart from emergency medicine, really has nothing to do at all with emergency medicine. They have their own toxicology inpatient service, and so it's not part of the emergency medicine program at all. And even the ones that are housed within departments of emergency medicine, the medical toxicology group is often a sub-department or a section of emergency medicine. And depending on the program, some of the fellows in training may not even work in the emergency department. They may just see the patients clinically. Usually the clinical component of the training program for many of them consists of serving as consultants to the Poison Control Center, although that is not even a requirement itself, but is usually having some sort of bedside service, some sort of clinical service. The majority are as a consultant, although some of them have their own inpatient service. So as a consultant service, you're consulted by, it could be by the emergency department or the intensive care unit or some other service around the country, around the hospital, and you come in and provide a consultation, just like an infectious disease specialist would provide a consultation, or a rheumatologist. It functions in a similar way.
That's a key point, though, to highlight that, the training must include a clinical component at the bedside. That's what's important to remind.
And there's certain requirements. So as I mentioned, each of the fellowships have to go through a very rigorous application process to be approved as a fellowship. And in the fellowship application, they have to ascertain that their fellows will see a certain number of patients at the bedside or perform a certain number of toxicology consultations. In terms of the clinic, most of the, in fact, I guess all of the training programs have some sort of clinic where they will see often non-emergency toxicological cases, occupational cases or environmental cases, or depending on the situation, they may follow up some of their inpatients like snake bites and whatnot in the clinic. And that clinic may be, sometimes they use the space in the emergency department for the clinic, or they may have access to other outpatient clinics.
Thank you, Dr. Wax. This is Yeşim Tunçok from 9 Eylül University, Medical Pharmacology Department. And when you are talking about the emergency medicine and the medical toxicology, many beautiful memories came up to my mind because 29 years ago, I was medical toxicology, clinical toxicology visiting fellow in United States for a year, and in Cincinnati, Ohio, University of Cincinnati, with Leslie and with Curtis, and I think they are your friends also.
Yes, yep.
And after went back to Turkey, we set up a poison control center in Izmir, in 9 Eylül University, and we set up, I think Aynur will talk about that, but after your talk, I would like to tell my memories to you. And after that, we developed a poison center, and we set up a clinical toxicology division in the pharmacology department. And I would like to ask if you have any medical pharmacologist in U.S. fellowship program. We are in Turkey, medical pharmacology departments have medical physician residents. That's why in Turkey we try to do medical toxicology training in our division, also in collaboration with emergency medicine department, not ourselves. Because I think in the multidisciplinary approach, every medical toxicology certification program can be established in Turkey also. Thank you.
Yeah, thank you for your question. And Leslie and Curtis are dear friends of mine. So, so in the U.S., what you refer to, I think, as medical pharmacology would be considered clinical pharmacology. And there are some programs in the U.S. Currently, although we investigated this years ago, we don't have a tight connection with the clinical pharm community. My sense of it is it's even a smaller community than medical toxicology. It's struggled to grow, often because of the compensation issues that we've discussed. Although certainly there's overlap in content. I do think that many of the medical toxicology programs try to teach basics of clin pharm, but the majority of programs don't necessarily have a clinical pharmacologist associated with them, although those that are closely aligned with the poison control centers will have clinical pharmacists, for instance, so we're a little bit different than clinical pharmacologists.
Dr. Balla from Chandigarh.
Yep, very interesting talk. We are going through this phase, which you went ages ago. We still have interested internal medicine people, some pediatricians who would take up clinical toxicology. And now, since last 5-7 years, we've started emergency medicine as a specialty. My question to you is, if we are trying to set up a clinical toxicology fellowship program in India, what should we be aiming at? Because what happens is, with the emergency medicine growing in the country, we would have only them as the front man in the emergency taking care of acutely poisoned patients. But they won't be there for the occupational and environmental hazards if there are some disasters which are happening. So the second problem which we face is that if we include pediatrician into an adult clinical toxicology program, they can't sustain themselves. And the problem which clinical pharmacology people, if they come, because they haven't seen a patient in years, they haven't seen an adult patient in years. So if we bring them into a clinical toxicology bedside program, I think it is going to be very difficult. It's not difficult to train a person who knows a little bit, but it might be difficult if we put them up front in the care of acutely poisoned patients. So I just want
Well, I mean, you are a role model of someone who's successfully evolved your career and embraced medical toxicology. It's, you know, it's, as you allude to, it's very challenging. And I think, again, it doesn't have to be done in the emergency medicine department. Now, so why should someone do a medical toxicology fellowship? Why should they get a certificate to begin with? And that's really an existential question that I've thought much about. Because my wife, for instance, is a gastroenterologist. She did internal medicine. She did her GI fellowship, and she learned skills and procedures where she practices gastroenterology full time. Like many medical specialties, the subspecialty training allows you to then practice and earn a living doing the subspecialty full time. Except for a few. That hasn't been the case in medical toxicology. I put up some data about what might be some of those reasons why and some of the challenges. So given that, why should one do the medical toxicology? And it's certainly not to make more money. It's to develop intellectually a particular niche talent, I think. It's potentially to allow you to do other things beyond working in the emergency department, but you have to be very proactive. You have to go at it. It's not going to be delivered to you on a silver platter by any means. It does have the potential of opening up some doors. That's why, as I mentioned, for every 100 people that train in emergency medicine, maybe one of them goes into medical toxicology. That's a very, very tiny number. My perspective over the last number of years is as you start to develop partnerships with others, you start to waken them to the idea of medical toxicology as a bona fide specialty and what we can offer. I've spent many times over the last, particularly the last several years, trying to interact with folks who were interested in, say, in addiction medicine or whatnot. We'd never even heard of medical toxicology. I mean, we're kind of we remain kind of an invisible field. But we're never going to change that paradigm without working on that and getting people enthusiastic about the field. Many of the folks that go into medical toxicology go in there because they get the bug somehow and they develop this passion. But it doesn't make for any easier professional path afterward by necessity.
Thank you.
Yeah.
We'll take the last two questions. Well, quick questions because we still have to go through one more presentation before the break. So, Jalal. Dr. Jalal is in Doha, Qatar.
Yeah, thank you very much for this really interesting topic. And I can see from the audience they are so interested in solving this problem in MENA region especially. If I talk about myself, that we started something called Emergency Medicine Fellowship and Toxicology in Qatar, which has ended up after 3 years only. Then we were looking for, improving our toxicology training to look for other subspecialty or other countries to enforce our training. So maybe this is correct for other countries, which is that difficult to get a proper training in an easy way and with a good cost and with better experts. So my question, because after building up of MENA Tox, and we reached to this level, where there is a lot of toxicologists in the all MENA regions, and with recognition from ACMT and other association, why we don't start something called International Fellowship or Training in Medical Toxicology that is run in the country itself, whereas there is a patient, there is some toxicologist, and it is recognized by ACMT and supervised by ACMT. So there is a requirement, there is a bedside teaching, and there is a curriculum to be followed with direct supervision by ACMT and upper supervision by MENA Tox and upper supervision by ACMT. This is a time I think we should think about this part, because if you tell me I want you to come to US First of all, I'm Yemeni. There is no visa for Yemenis. Second of all, there is a high cost. Third of all, I need to go for that training out of my career, my family, my things. So why this training not come to my area? Thank you.
There's no reason why that shouldn't happen.
Yeah, well, I think it's a good question. As you know, some of you know, Ziad is also our chair of our international committee, and you know, we've talked about this over time. But you know, if there's enough groundswell of support, it needs to be kicked into a higher gear in terms of you know, putting together some sort of plan. You know, some sort of plan that has buy-in from folks. It's never going to happen without the effort, but I think we should capitalize on our successes that we've described and try to broaden out that to others and to share the expertise that we've developed in the process. And I'm very much supportive of that.
Okay, Dr. Shirazi, then Dr. Bashat, then Dr. Andy, and then we're done.
Okay.
And then Dr. Noor Shaheen gives her presentation. Please make them quick questions, more like sound bites. Elevator speech.
Well, I just wanted to reaffirm one of the things that Paul said. I think I'm one of the few, if not the only, fellowship director from the US. And one of the problems we had is actually emergency medicine. As Paul said, for emergency medicine department, you open it up and they're patients. For toxicology, you got to work on it. You have to have a reputation. You have to have a value added so that you're consulted. And many of those things come from having clinical pharmacology background, working with the departments of pharmacy and such. And I think to be honest with you, I think every country needs to look at their workforce, especially their healthcare workforce, and see how they're going to allocate that. We, now are moving, and I agree, we're moving away from emergency medicine being the only source. Because we're finding actually internal medicine, psychiatry, those guys are much more interested in the area of toxicology, and they want to make a living out of it, and they're working hard at it.
Thank you.
Yeah.
Dr. Bashar? Dr. Bashat, I'm sorry. I know, do you want to get set up? You're ready.
One simple question, thank you again. Just, we have so many residents there sitting here. I'm wondering that we always talk about the past of the medical toxicology, what happened in the past. What is your opinion about the future of the medical toxicology, about the toxicologist, for example, 10 years later? What's your opinion about this subject?
That's a whole hour lecture. Dr. Nelson, please.
Yeah, so can I respond?
Yeah, I'm just getting the microphone ready.
Well, I started my training in 1989, and I finished in 91, so it's really 30 years in 2020. And there's been a slow improvement over that time. A lot of the same challenges. We certainly have a larger workforce. I think we need to continue to look outside of our box. That's why I've been embracing the addiction medicine paradigm, something that we really didn't do much of in the past. Even the presentation that Gaylord gave earlier this morning about what his poison center does and all of the kind of varied responses to what a poison center can do. I think we need to embrace that sort of approach. It's not just going to be seeing acute overdoses. I think the acute overdoses is a core part of what we do, but it's just part of it. I think some of it's in education and consultation. As a society, we provide consultation on a variety of areas. We just heard that talk about chemical security, and we actually have a contract that we provide some consultation on that. So it's kind of going beyond the acute overdose paradigm. And just one comment about the pediatrician that Ashish mentioned. We've trained pediatricians over time that did not have primary training taking care of adults, but during their toxicology fellowship, they've become quite confident of at least taking care of adult toxicology patients. Now, they're not going to go back and say work in in a adult emergency department, but as part of their portfolio, seeing an adult toxicology patient, they're quite confident at. And what does board certification provide also? So some hospitals, to do consultations in the U.S., you have to be board certified in medical toxicology. So that barrier to become credentialed to provide consultations, whether you're a pediatrician or ER doc, if you have the board certification in medical toxicology, you can take care of those patients. Now, of the approximately 5,000 hospitals in the U.S., maybe about 100 of them, or 125 of them, have medical toxicologists. So most hospitals, there are no medical toxicologists, but we've made some inroads.
Thank you. Last question, soundbite.
So I was just thinking about alternative pathways into medical toxicology, and I personally, I'm married to a preventive medicine physician, and one of the challenges with this pathway into medical toxicology is typically the preventive medicine residencies come after some other residency program. So you're looking at a first residency, then a second, and then a fellowship, and at that point the spouse is frustrated and enough training. So I'm wondering if it would make sense for medical toxicology, addiction medicine, occupational, and preventive medicine to team up together to make a more streamlined residency process, so that the second, third year of occupational medicine can be linked more directly with the first year of residency training.
Yeah. Good question. These sorts of issues have been discussed over the years in multiple different guises, depending on what specialties you want to combine. It's very difficult. Everyone has their own turf, and they don't want to give up, and you try to shorten it, and does it get shortened from this, does it get shortened from that? There is a recently approved pathway for both addiction medicine and medical toxicology, where you can take off 6 months if you have the right training programs on a given campus. I know with preventive medicine, and again, I'm a big believer in folks that come from that field, sometimes they wonder, well, do we really need to learn all this acute care stuff? We're more interested in the chronic toxicities and whatnot. But it is kind of what it is, and the core content right now, medical toxicology, has both in it, and I don't think it's going to get chopped into finer pieces. I've trained some folks who've come from occupational medicine and internal medicine that have really warmed up significantly to the acute care stuff as well. So it kind of goes both ways. No easy solutions, though.
Dr. Wax, you had the most lively session. I already tweeted about it, so thank you so much.
Thank you very much.
Medical toxicology at Emory University. Prior to that, she had a emergency medicine residency and PhD in toxicology at Karadeniz Technical University in Trabzon. Trabzon was the host of Minatox 2011 with the help of Dr. Tunçok at the time. So we are pleased to hear from her a little bit about Turkey, some data and some of the situation with education and training.
Okay, thank you, Dr. Kazi. Welcome, everybody. First of all, I would like to thank the presidents of and members and board members of Minatox and IPADS to make this beautiful organization happen in our beautiful country. It's my honor to be a part of it. Now I will talking about the clinical toxicology practice and training with a Turkish perspective. I have no disclosure. So this will be a very fresh perspective. 7 months ago, as Dr. Kazi said, I certified from Emory University International Postdoctoral Fellowship Program in Medical Toxicology. And 2 years ago, I just got the first PhD in toxicology as an emergency medicine specialist. I'm actually working as a consultant in medical toxicology and emergency medicine in Karadeniz Technical University, and I'm taking calls and telephone consultation from my university hospital and other nearby hospitals and healthcare facilities. And we are about to set up a critical care and toxicology unit, which has a 14-bed capacity. We will set up it in 2 months, so we can also serve the critically ill patients and also all of the poison patients in our regions, approximately in 1 or 2 months later. So in Turkey, the thing is that we have limited number of clinicians with subject matter of expertise. So Turkey has one certified medical toxicologist, US trained, and one clinical toxicologist, Dr. Tunçok, who is certified from US. And we have 10 ED specialists who are in toxicology, in doctoral training recently, but lots of emergency specialists, pharmacists, pharmacologists, anesthesiologists who are really interested in toxicology. The thing is that medical and clinical toxicology is not a subspecialty right now, and we have still disagreement between the other disciplines and emergency medicine and other disciplines. So we need to collaborate more. We have few toxicology PhD programs. I graduated from 9 Eylül University Department of Pharmacology, a clinical toxicology fellowship PhD program. But also, a couple months ago, Gaziantep University Department of Emergency Medicine has set up a clinical toxicology program, but they have no student right now. They will approximately have maybe in next years. So the other programs, toxicology programs, are generally pharmaceutical toxicology, and they are under the division of pharmacy. So we have lots of pharmaceutical toxicology PhD programs, like 8 or 9, the number is like this. And the thing is that just 3 of them has a local poison center. 9 Eylül is one of them, and also Hacettepe University and Uludağ University has local poison information service. The thing is that the working hours are like in between daily hours and service on the local university, hospital, healthcare professionals. 10 years ago, actually, 9 Eylül University was serving 24 hours poison information service, but depending on the shortage of the faculty and the other problems, they only can serve just like daily hours, yeah. So future steps is absolutely we need set up a specific medical toxicology fellowship program with a collaboration between the other discipline and other programs, and absolutely with a National Poison Center. So we need to improve the interdisciplinary connection between other disciplines. This was my first presentation, and do you have any questions? Because I will talk about the National Poison Information
Let's keep going because
okay.
we have the microphone and we can do the
Sounds
other
good.
one.
Okay. So also I would like to talk about currently our National Poison Center of Turkey, which is in Ankara. We have just one National Poison Center who serves 7 to 24 hours, and it has established in 1986. They got approximately 2,000 calls per year, and 80% of these calls called by healthcare professionals. I wish I could make this presentation by the Director of Poison Information Service, but his schedule was not available, so I would like to provide the information that I could get from the team in Poison Center. So these are the basic numbers. The numbers are increasing, depends on the years, but now they tell us that the number is about 2,000 calls per year, but sometimes it can increase mistaking the calls can increase the number, but only for the poison control information, they got just 200,000 calls per year. They have a call management system. They can handles calls 3 at a time and records all calls through the system. The thing is that they have limited staff and calls answered in minutes, sometimes maybe about 30 minutes, so it's a big problem for the other physicians, especially ED physicians. They cannot reach easily if the shift is really busy. So they are working on 24-hour roster, the single coverage 12 hours per day, and weekends also they are served with the limited number of staff. The poison information officers with a clinical background provides the poison information service, but the thing is that most of them are paramedics and nurses. As to medical supervision in our National Poison Center, limited number of clinicians with the subject matter of expertise, but the thing is that There is no clinical or medical toxicology background, specific background. They are only physicians, those who have working depending on the experience in National Poison Center, and there's no specifically trained medical director in clinical toxicology right now. As to record variables, we have really good record variables. We got every information from the patient in Poison Center. This is our data save list. It's similar to the other poison centers worldwide. We got all the information from them. And as to data recording, the data is recorded as of 2006, and all conversations are recorded and saved in a different database. The other problem is that they are collecting the data, but they are not sharing with the other healthcare professionals or the public for more than 12 years. They only keep this information to just Ministry of Health and Public Health, but they don't publish any annual reports, and so that we don't know about how much we expose and what is the most common exposure in Turkey, so we have difficulties like that. As the information resources, they have lots of resources. They use Poisonex for electronic poison information service, and also they use textbooks, journals, and reference materials. But the thing is that the physicians are just using these materials, and they don't have any medical toxicology division. So, as to research and toxicovigilance, I have no information to provide you, but they have lots of collaboration with public health agencies, medication safety bodies, regulatory authorities. They have lots of connections. And they have key relationships between Ministry of Health, Ministry of Disaster and Emergency Management, public health, other healthcare professionals, media. Current challenges are, in a nutshell, there's a lack of medical supervision, non-accredited poison information providers with limited numbers, no follow-ups, they cannot do follow-ups, staff already stretched to the capacity, and annual reports are unavailable. And for the future strategy, maybe we can build a medical clinical toxicology as a recognized subspecialty in region, and also accreditation is really essential for the other poison information staff. Also, we need to entrenching the National Poison Center into the healthcare infrastructure in minds of officials and healthcare professionals. Thank you.
Thank you. I want to acknowledge Dr. Ainur Shaheen's contribution to this year's conference. She has carried a huge load, and I would like to just thank her.
Thank you.
We can take one question, then we're going to take a break, and we're going to resume at 4. I'm going to give you an extra 5 minutes. So 4:05, we start on lead. Quick presentation about lead. If you want to learn how to assess your lead environmental hazards, you should attend that session, and we'll finish at 5 o'clock. Quick question?
Hi, I'm Dr. Büşra Bildik from Istanbul. So thank you for your presentation, because it's actually a leadership for us. I'm a resident of Başar Cander. So right now, actually, we're really interested in clinical toxicology, but we don't have any pathway to follow right now. Mm-hmm. So I have a question about these PhD programs. Mm-hmm. Do PhD programs have actually a bedside manner? Because we've been told that it should have actually a bedside manner to understand mm-hmm. or follow the patients in their clinics, actually.
Honestly, the PhD program, I got my PhD, and I'm really proud of that. The thing is that PhD programs are most focused on for academic research, but there are exceptions like 9 Eylül, some of the toxicology PhD programs. For example, when I was a PhD student, we can have a bedside consultation from emergency department and we can collaborate to each other. The thing is that I totally changed my mind for myself before the fellowship, after the fellowship. The thing is that each program should be connected with poison centers, because the more you get consultations from the poison center, you get more well-trained. So, for example, during my fellowship training, I got, maybe if I didn't go to the Atlanta and got this medical toxicology fellowship program, I need to wait maybe 15 years to get those all patients in practice. So it's so concentrated training in poison centers. This is so essential. I think we need to collaborate to other disciplines, and we have already PhD programs, but we need to set up a really clinical and medical toxicology division with the poison centers. This is, I think, the most essential thing for training the other professionals. Otherwise, these PhD programs is not like a fellowship program, because I have also one. We got really exposed to patients, but it's not like that I exposed in Atlanta like during a 1 year. So we need to collaborate with also poison centers. Yeah.
Okay, thank you so much.
You're
Thank you,
welcome.
everyone.
Yeah, thank you.
Let's enjoy the break and then come back at 4:05. Thank you.
Thank you.
Toxicologist. So that's a unique area. He practices in Western Sydney, Australia. He's a colleague and member of ACMT, and he's been participating in our conferences, not in Gunja. Dr. Narin. He is going to talk to us a very important topic. In the MENA region, medical toxicologists, as you know, are rare. Forensic toxicologists are involved in poison centers in Egypt and Saudi Arabia, and many times are the only clinical toxicologist available, or the closest to a clinical toxicology available. This is the same situation in India. So what I asked Dr. Gunja to do today is explain to us the similar things and the differences between a forensic toxicologist and a clinical toxicologist. Are you up for it?
Yep. Thanks so much. Thanks, Ziad. Hi, I'm Naren Gunja. I'm an emergency physician by training originally, and then did a fellowship in clinical toxicology. Then I went to the US and did a master's in forensic toxicology, and then did some training time with the New South Wales Police Service and Coroner Service before working now equally in both medical and forensics. This photo, I put it in there because it's a kind of like a beautiful image of one of my favorite shows, which is Breaking Bad. And the world's only Breaking Bad themed cafe is in Istanbul. So if you ever have time to go to this place, it is a wonderful place. It is in Karakoy, which is on the Asian side of Istanbul, so it's not easy to get to. And there you can get dressed up in Walter White's jumpsuit, and you can, instead of making meth, you can make coffee. It's great. It's a wonderful place in eastern side of Istanbul. It's the only one in the world as well. So the owner is a big fan of the show. I just have a quick disclosure. I work for the police as well as the coroner, which is the Australian word, or the Commonwealth word that we use for the medical examiner. And anything I present here today has been slightly altered and anonymized to make sure that it doesn't breach any confidentiality, and that any perceived resemblance to cases that you may have heard of is unintentional. What does a forensic toxicologist do? It is quite a different subspecialty.
nearly all the forensic toxicologists around the world, not just in the US and Australia, Europe, are all primarily from a PhD scientific background. None of them, nearly none of them, are clinicians. So they are usually not MDs, they're usually PhDs. And they have a wide variety of expertise in what they do. Where they probably struggle the most is anything that requires clinical interpretation of people who are alive. They're very good with dead bodies because they don't have to worry about being alive. But when it comes to humans that are living and certain things that they have to interpret, it sort of reaches their limit. And we often see this, and I know ACMT has a combined forensics course, which I found very valuable over the years. And there is quite a lot of overlap in what we do. But a lot of what I do involves post-mortem interpretation, talking about drink and drug driving under the influence. Occasionally you might get drug-facilitated crime and sexual assault. There are also parts of the work that involves working around clandestine, often, drug labs. Drug seizures. Now, seizures in this world is totally different to convulsions. When they're talking about seizures, they're always talking about not fitting, but they're talking about capturing or police finding and arresting product that they've discovered through the course of their work. And there's also parts of occupational medicine involved with environmental and other exposures. And occasionally we do get requests for interpretation of things like mushrooms, plants, and envenoming, particularly in Australia. Envenoming is a very big thing that we have to do. I'm going to just quickly run through a case just to give you a flavor for what we do. These two elderly people were found dead in a hostel and both thought to have had strokes. But the GP who was asked to see the patient had some suspicions. The post-mortem exam was negative, really, nothing significant, no cause of death identified. The forensic toxicologist did some testing, and thankfully they did the autopsy soon, but even quicker, they took some blood very quickly, within hours of death, and kept it frozen for interpretation later on. And they found a whole bunch of things that the patient is taking therapeutically. And that's a common question we get. Is this morphine that was given to the patient, or is it as a result of metabolism from codeine? And lots of other metabolism kind of questions that we get, particularly with metabolites of MDMA, amphetamines, metabolites of other psychotropic substances. But the femoral blood and the vitreous humor of both patients were sent off and found to have elevated levels of insulin. And whenever you do insulin, you should also always measure C-peptide. And as you can see, the C-peptide is near undetectable. And this confirms that this was exogenous insulin administration. And this then goes to help the case for whether these two people were poisoned. And it was later found out that a nurse in the nursing home had injected the two with insulin, and she was arrested and is currently serving time in what we say Her Majesty's service. So a lot of it is about interpreting post-mortem redistribution, and this thing has been a very fraught thing for majority of clinicians, including clinical toxicologists and forensic people alike. And this is mostly because after death, all of those wonderful cell membranes that we like to worry about with transporters and equilibrium reach between extracellular fluid and intracellular fluid, all that is gone. And that entire compartment model is disturbed in death, or after death. And so normal kinetics, the things that we have trained in clinical toxicology, does not apply. So that makes interpretation difficult. You can't just look at a level and go, okay, based on this level, I think they took this much. That's very difficult, if not impossible, to do in forensics. the kind of drugs that we use all the time, or that we see, all those psychotropics, the antihistamines, antidepressants, antipsychotics, they are all weak bases that are lipophilic, and they are the ones most likely to have postmortem redistribution. And so there's a lot of controversy around what does a CP ratio, you've heard of CP ratio with central compartment to peripheral compartment ratios. There's a lot of controversy of what that means. Just because it's 1 doesn't mean that there has not been postmortem redistribution. There is also a phenomenon of peripheral postmortem redistribution. It's not just about central to peripheral or peripheral to central. You can do sampling in the femoral vein or artery, and you could have had drug that was sitting in the bladder that was sort of leaching out, depending on the position of the patient, leaching out and found itself into the vascular compartment. And then how do you interpret that? So there's a lot of issues about sampling, the quality, the transportation, the positioning of the patient that need to go into that interpretation. So we work very closely with the police. We also need to see photos of how the body was found, the positioning, and hence where the sampling came from and things like that. Drug labs are, there's more of this obviously in other parts of the world than Australia, but occasionally Australia is one of the methamphetamine capitals of the world. We don't have blue meth, but we've got lots of other meth. And, there's so many things that are being manufactured because you don't need big, wide plantations that can be seen from the sky. So we do get the occasional house that blows up, and then you've got to work out what's going on. And there are people living in these houses and manufacturing in a basement downstairs. And those houses have adults and children and dogs and all these animals running through this drug lab. These are the kind of patients you end up having sometimes. Not just from the actual chemicals, but also from the explosion itself. Drink spiking, we do get quite a bit of work about, has my drink been spiked, and as a lead into either drug-facilitated crime or sexual assault. Most of the studies that were done about 10 years ago showed that the main drug in drug spiking or drink spiking is ethanol itself. Now, that doesn't mean your drink hasn't been spiked. You could be spiked with ethanol, just a stronger concentration or more of a drink than you thought you had. So the kind of things we see is that ethanol is the commonest agent in victims. And the worst part of it is they have voluntarily drank that in most cases. And so that makes it difficult. We can also do things like ethyl glucuronide. I don't know if anybody's doing that in your areas. It's not like a fantastic new thing. It's been around for a while, but it's better for looking at certain things like abstinence and whether alcohol was ever ingested. But you do need to watch out for some of those false positives. To give you another sort of case that I can illustrate with, a 54-year-old woman is found unconscious at a party. She definitely admits to having drunk alcohol during the party, but then she says she passed out and doesn't remember anything. And then when she woke up, she was wearing quite a lot of expensive jewelry. All of this was gone. And a few weeks later, when she's been thinking more about it, she goes and tells the police that, I think I was drugged, and that's how they've been investigating this throughout the last few weeks. And then she thinks that perhaps she was drugged. Now, several weeks later, there's no blood or urine test that's going to show anything. However, she thankfully had quite long hair, and long enough that they could sample her hair. And we cut hair at 1 centimeter intervals. And at the interval that coincides with that party, they picked up Zopiclone. Now, she denies taking Zopiclone as a regular drug, and there was a high peak. So that's possible. And that's the kind of scenario you're faced with as a forensic toxicologist, is what does this mean, and how does it help the victim or the case that they're trying to build?
and it's only one small part of the story. So there is some evidence there of an incapacitating agent. It was consistent with the timing of the event, and it's supportive of her case. That's about it. So drug-facilitated crime is when a drug's pharmacologic effect is used to incapacitate somebody, and that then leads to a criminal act. And that criminal act, if it's a sexual assault, that's called DFSA, or drug-facilitated sexual assault. And why do they do this? Often there's a pattern. The perpetrators tried this before. They do it because the victim can't usually identify them or have lost memory along with it. There's a couple of common experiences that people will tell you. One is that they were completely knocked out. They don't remember anything. Or the other one is they had a flashbulb kind of moment, sort of like a James Bond movie, where they kind of remember intermittent periods of altered level of consciousness. We've seen a little bit of this with the Z drugs. I don't know if you have Z drugs in the Middle East. Zopiclone, Zaloplon, and Zolpidem. We don't have Zaloplon in Australia. It is probably the shortest acting and also has a very rapid offset as well. The thing is, the company was made to put indigo carmine in the tablet, so it's blue, and so it can be detected when it's popped into a drink. Zolpidem and Zopiclone are not. Zopiclone is actually quite long-acting for a Z drug, and it's almost, I would say, like temazepam. It's quite long for a Z drug. These things can be very difficult to detect in any biological sample of victims. You need to get to it very quickly. And in hair, the chance of detecting Zaloplon in hair is very, very low. Zopiclone, you have a chance. In terms of the kind of samples that we use for this sort of thing, blood and urine is the most common. Occasionally, you can try hair or oral fluid, but in general, they're not as easily available quickly, particularly if people present late. They're unconscious, so by the time they wake up, it's more than 8 hours, so oral fluid's hard to get. Hair testing. Hair testing is, it's great when it works out, problematic when it doesn't, and of course you need a very good lab that can measure it. In general, hair grows at about 1 centimeter per month on average in people. And there's very tiny amounts of drug present, and you've got to get them to collect it from the back of the neck, collect adequate number of strands, the quality of the hair's got to be good, and then you've got to cut it up into segments so that you can do a proper analysis on it. And there are some drugs you'll never be able to detect. For example, lorazepam's quite difficult. So in the end, all of this often leads to court action, or you have to spend some time in a coroner's court or a plaintiff court or some other federal court. And I guess my experience, my advice to people is know your limits. That's probably the best thing you can do, is knowing what's your area of expertise and not straying outside of that. Also, you need to have a reasonably good understanding of what LCMS and GCMS is, how they did the analysis, so a good relationship with the lab, and to know what are the limits of detection, quantification, as well as some of the variables with that analysis. PMR, you have to absolutely understand, postmortem redistribution. And often I find expert witnesses that come to court, they think the whole thing hinges upon their evidence. The psychiatrist or the orthopedic surgeon or the toxicologist thinks their evidence is so crucial to the entire thing. In the end, what ends up happening is it's a big jigsaw puzzle of lots of people's evidence, and the toxicologist is a small part of the story. And sometimes a more crucial part of the story than others, but not the entire thing. And
I would always say be humble in court, because you can get very caught out and get in trouble. Because what you say in court is printed, published, and is there forever on some website. So just, you got to be careful. Thank you.
We have time for a question or two, if anyone has any questions to Dr. Gunja about forensic toxicology aspects. Now, what do you think the difference is? So what do you think about the training of a forensic toxicologist that allows competency in medical toxicology?
Nothing. They have absolutely no expertise or training in any clinical work whatsoever. And so that's where they find themselves straying over a little bit. And the problem is when there are no clinical toxicologists who are doing forensic work, they are doing all this work and then straying into sort of making statements that are possibly outside of their expertise. So I find that we kind of complement each other. I got to make sure that I, as a clinical toxicologist, even though I have forensic training, that I don't talk about something completely outside my expertise, like how does this HPLC machine, what's the accuracy of that? I'm not gonna talk about that. I'm gonna let them do that. So they also are aware of their limits and what can be said in court and what can't be, particularly to do with alcohol and widmark stuff. That is fraught with issues. So they have very little clinical training whatsoever, at least in Australia, and I'm pretty sure Americans are the same. They're all PhD type people.
I think in Egypt, we don't have anybody in Egypt here from Egypt, but in Egypt there's a master's of clinical and forensic toxicology. I'd love to learn more about it to see what kind of competencies they learn.
In India as well.
In India as well. Is it also clinical? Is it more forensic?
They tend to be forensic pathologists who are clinical people, MBBS people, who then do some clinical tox work. So they have clinical expertise.
Thank you. All right, the next speaker is pretty boring. And he's going to talk about lead poisoning. So can you put my slides up, please? Mr. Brett Erickson and Miss Paromita Hore from the New York City Health Department. We have the Zoom going, so we'll see if that's going to work. But in the meantime, I want to tell you a little bit about my story with lead and working on this project in the Republic of Georgia. I'd like to acknowledge partners of this project from the National Centers for Disease Control in the Republic of Georgia, the Ashvili Children's Clinic, of course, Emory University, and then the UNICEF Georgia office or regional office in Georgia. Now, I've been working at Emory University since 2008. I completed my fellowship there in 2005. And when I returned to Emory, Emory was already doing a lot of work in Tbilisi, in the Republic of Georgia, through a USAID grant to develop immersive medicine. At the time, I had never been to Georgia, and the grant actually ended in 2009, and I still had not been involved in that project. But I knew about the relation between Emory and Georgia. Of course, I met my lovely wife, Tamar Gabelaya, who is a Georgian internal medicine doctor. And this is my first introduction to Georgia rather than the grant that was at Emory. When I went to Georgia, I really enjoyed visiting there. I'm sure many of you here, especially in Turkey, have been to Georgia. And I started asking questions about toxicology, and immersive medicine as well. Now, at the time, the CDC director, Dr. Tom Frieden, and I was working at the CDC as a contractor at the time, had told us that you should look for a problem that is big in your career. Look for a public health program that is big, that is something you can do about it, and that affects a large number of people. And to me, as a toxicologist, I think lead is one of these examples of a problem that is large, significant, with significant, well-studied impact on health, and you can fix it. So I asked that question in Tbilisi and found out that there was one case report of a family that was poisoned with lead. This family lived in Boston, Massachusetts, and was reported by one of our colleagues, Dr. Alan Wolf. They had brought spices from the Republic of Georgia to the US. And they had significantly elevated levels from eating this salt from Georgia. So I decided to do the first study that was a convenience sample at a hospital, the EHVili clinic, in children. And we published it and collected data from 254 children. And we found that 10% of our children had a lead level that was greater than 10 microgram per deciliter, which was the old level of concern in the US. Currently, the reference level in the US is 5 microgram per deciliter. So in my sample, which was a convenience sample, 10% had this level greater than 10. We wanted to pursue this further, but we hit a roadblock with the lab testing that we used. We accompanied this initial study with some public and professional education campaigns, with seminars in collaboration with the Ministry of Health. But then we were faced by a recall of the test that we used. The machine that we used to test the blood lead level in these children was recalled in the United States because potential contamination or wrong results. We knew that the error was probably small, but we couldn't really make a big claim because this issue happened. So we had to repeat the study again using the gold standard, which is ICP-MS, and we found similar results to our initial study. So we were reassured. But at that time, we had already raised awareness in the community of this problem. We had media campaigns, and I think the social media was very important. We had Facebook posts that were looking at this, talking about lead poisoning or lead hazards in Georgia. There were some volunteer community-based organizations that did studies of toys in Georgia and found lead contamination of toys. At that point, this grew enough in its significance in the community that the Ministry of Health, who we had been partnering with for many years on this project, reached out to UNICEF. And through the support of UNICEF, we were able to do a national study with a nationally representative sample of children. They were performing a multiple indicator cluster survey. This is a UNICEF study that's probably been done in Turkey as well. It's been done hundreds of times around the world. That looks at children and looks at a variety of indicators, not lead. We convinced them, with the support of the Ministry of Health and the data that we had provided to them, that we want to include a blood lead level in the draw when they go to visit the home of the child. And that was a collaboration, again, with the National Center for Disease Control, which is the importance of your Ministry of Health, knowing what you are doing at the research level and connecting with them. And with the help of the Italian Institute of Health, who donated the ICP-MS blood testing, we were able to complete this study in a short period of time. Of course, nothing should be done without education and outreach to the public and to the healthcare professionals. We had multiple interviews. We had a plan to respond to queries. We even had a 24-hour, 7 days a week callback system if we had questions by physicians to our toxicologists in Atlanta. The results came out and they were quite surprising. 41% of our sample, 41%, had a level greater than a level of reference level in the US of 5 microgram per deciliter. Our study was 10% more than 10. This study, which is more representative, it's a national sample, 16% of our children had a level greater than the old level of concern that CDC was using of 10 microgram per deciliter. In some parts of Georgia, there were much higher percentages of children with elevated levels. More than 5 microgram per deciliter. Some places had 85% of children had that level. You know Batumi? Batumi is close to Trabzon, right? Batumi area is in Adjara, and this is where you have these levels of 85% greater than 5. And if you look at the 10%, if you look at the 10 microgram per deciliter level, 50% of children in Adjara had this level. So what do you do with this? You get levels, now you have to interpret them. This is the role of a medical toxicologist. And here we have to talk about these levels. True, they are higher than what they are in the US, but in the US we were in that neighborhood years ago our national data in 2016 showed that we had about 6% of our children in some states with a blood lead level more than 5. And if you go back in time to 2012, we had states like Louisiana where 70% of the children had levels more than 5. And if you look again at the CDC statements about this, we realize that the condition right now in Georgia is similar to what it was maybe in the late 70s in the US. Why did we compare with the US? Because we wanted to communicate to the public a message of calm, a message of perseverance and resolve to mitigate this problem. We did not want to create panic. We wanted to show them that this was in the US in the 70s. I know 70s is 40 years ago, but still we're telling them that this is a situation that was there and it was also mitigated in the US to where they are right now by a series of public health actions and legislative and policies that prevent this hazard. And then we embarked on a project with the Ministry of Health to design a strategy to deal with this. And this is a multidisciplinary strategy. It includes multiple governmental sectors, multiple specialists, and multiple different efforts that are ongoing right now. The first thing we wanted to know is what is the source of this lead exposure? And of course, we know that lead, typically we think of it as a component of paint, especially old paint. However, it's not just old houses that have old paint. Remember that some houses are using new paint, and there are some new paint products that contain lead. If you're not in a regulated market, you may be able to find this type of paint. We actually went around a supermarket in Georgia, like a big supermarket, and we collected 20 different types of paint, and we tested them in my house with using a bedside test or like a point of care test, and we did not find lead. We knew also from the government that they did not allow leaded paint in Georgia. Leaded gasoline is another problem. I know leaded gasoline has been eradicated from many countries. I believe it's still there in North Korea and Myanmar. I think in Iraq. Is it still there in Iraq right now? In Iraq. And in Georgia, we had reassurances from the Ministry of Health that lead was not in gasoline. Of course, you have old pipes. That is a problem in various parts of the world. Even in the US, we had this problem in Flint, Michigan. And batteries, recycling batteries is an ongoing process. People try to make money in developing countries by recycling batteries and extracting the lead from it and contaminating the soil and themselves. There are other sources of exposure to this, whether it's in the environment or whether it's occupational. In Nigeria, a large epidemic of lead poisoning from people trying to extract gold from the natural ores in their home led to hundreds of children dying from lead poisoning. People that work with welding, people that smelt metals, people that are in firing ranges. When they fire bullets, they can expose to lead by inhalation or by even oral ingestion. There are also people that work with crystal glass makers. All of these professions are at risk. Battery recycling is a particular area of interest in some parts of the world, like India, for example, and Africa, where you can see these exposures occurring in clusters. The other non-traditional sources of exposure include traditional remedies. For example, kuhl and bint al-dahab. Bint al-dahab is used in Oman, for example. Kuhl is used in India and some Arab countries. It's made of lead sulfide. It can lead to exposure to the children and to the parents and poisoning that way. Currently, we're looking at retained bullet fragments. People that have retained bullets in their body can develop some elevated lead levels. Not very high, but if we say that no lead level is safe, they are quite concerning. And finally, spices. If you remember the case that I just mentioned to you in Georgia, spices was an important component, especially in Georgia. In Georgia, spices are like kebabs in Adana, right? Very important. If you say something bad about the spice, you better be ready for some problems with the media. And these spices are numerous, and they're manufactured by companies, but also manufactured in a traditional way, and they can become contaminated with lead, whether it's maliciously just to make more weight, to make the material heavier when you sell it by the kilogram, or by accident when you are grinding the grains. The grinders, if they are made of steel, and if there's an acid component there, you can leach the lead out into the actual spices. Of course, the oral absorption and lung absorption are the primary routes. Don't forget a placental transfer in pregnant women to their fetus. These are all important routes that can lead to lead toxicity. The skin is much less of a problem than the GI, lungs, and placenta. Remember with the GI absorption that if you have anemia, you will have more absorption. So some of the best ways to treat a child who has elevated lead levels is to supplement their iron level, iron supplement, and then giving them healthy food that contains iron, vitamin C, calcium. Those are the best ways to decrease the lead level in the child who's in an environment. So what are the clinical aspects of lead toxicity in children and adults that I want to just discuss with you a little bit? I want to share with you that the lead levels in adults are going to behave a little bit different clinically than in children. You will see the lead levels in adults a bit higher to cause a similar effect than in a child. You see in the children, for example, you can get the severe toxicity at levels of 70 to 100. And here you are looking at a patient who's encephalopathic with elevated intracranial pressure. They typically come into you the first time and you miss it. You don't realize they're lead poisoned. They come in with abdominal pain, maybe headache, lethargy, maybe a seizure. You would do a workup, you discharge them home, and they come back a week later with severe lead encephalopathy. And they can have brain edema and long-term neurologic damage. And you manage these cases like an ICU patient, of course. This is a critical patient, ICP management, and chelation of the lead. This next area of toxicity in children is a moderate area where you have the levels of 50 to 70. Here you have more subtle signs that can lead to the severe signs if not detected and stop the absorption of the lead through the pathway. The patient may be the child may be hyperirritable, may have lethargy occasionally, not interested in playing. They can call him a difficult child. Some GI complaints with abdominal pain and vomiting and low appetite. The biggest proportion of patients you will see are those that are below 50. This level of below 50 microgram per deciliter, the clinical effects are very subtle, and it's very hard to catch them unless you are doing proper exams of the mental development and the cognition of the child. You look at hearing, growth, all of these are clues that somebody has an elevated blood lead level, but they're tough to catch and easy to miss. Therefore, it's a good area here to consider doing screening to catch these children at these levels, to prevent them from getting more lead, and to also prevent them from getting the effect of lead exposure even at these levels, which we know are not good, because there is no safe lead level in your body. Even low lead levels can affect the growth and development of children. The biggest effect on this cognition is on the IQ, which is the intelligence quotient. And we know that elevated blood lead levels will affect your intelligence quotient, even at lead levels between 5 and 10. So those low levels of between 5 and 10, you get an effect on the IQ. The effect is a bit more significant than when the level is more than 10. This is why the CDC revised its data and said, okay, from now on, we are not going to say that there is a level of 10. No, we're going to say that no lead level is good, and our reference point right now is 5 microgram per deciliter. We are always trying to get as close to 0 as possible. At this point, I would like to see if Mr. Brett Erickson is on the phone. Brett, are you here? Okay, so Brett is here. Can you please turn the microphone to... No.
Paramedic, you can hear me, right?
Brett?
Yeah, hi, yeah.
Can you speak up a little bit? Hey, can you shut?
Yeah, can you hear me?
You want to share your screen, Brett?
Yes, sir.
Okay, go ahead, please.
Just
Erickson on the project in Georgia. Brett was working with the Pure Earth organization that works on mitigating lead hazards and identifying sources of exposure around the world. He recently changed his employment, so I will have him talk a little bit. But today his talk is about what we did together in Georgia, because he was actually involved after we finished our UNICEF study to identify the sources of exposure by doing an environmental assessment of homes in the country of Georgia.
Hi, Ziad, can you hear me? Can I begin?
Maybe speak up a little bit, or maybe you can increase the volume a little bit. Go ahead and try
Ziad,
now.
can I begin? Sorry, Ziad, can I begin?
Yes, go ahead.
And is it audible? Can people hear me in the room?
I think you're loud and clear.
Wonderful. So I apologize as we're having a bit of difficulty hearing on the phone on our end, but I believe Ziad just introduced me. So yeah, my name is Brett Erickson. Previously, I worked for an organization in New York called Pure Earth. Although I no longer work for Pure Earth, I'm currently employed by the United Nations Environment Program. However, the work that I'll present on today was done with Pure Earth under contract with the Georgian NCDC, and in no way represents, I in no way represent the UN today. Great, so I think Ziad summarized this for you briefly just a moment ago, but in 2018, the NCDC and UNICEF completed a sort of an unprecedented blood lead level survey across the country of Georgia. To my knowledge, this is one of the few, I think 2 or 3, Mexico has done one, and really only a handful of other countries have done nationally representative blood lead surveys, particularly low and middle income countries outside of the US. So this is really an incredible effort. They found 1,500 kids all over the country living in some pretty remote areas and took their blood leads, took their blood and sent it to Italy for analysis with ICP-MS. I think Ziad referred to this, but you know, the blood leads were really quite high. On average, the blood leads were above 6 micrograms per deciliter. As context, in the US, they're below 1 microgram per deciliter. The CDC uses a reference dose of 5 micrograms per deciliter, which represents the upper 95th percentile of all blood leads in the US. So 6 micrograms per deciliter is pretty high. And the median was also high, approaching 5. And I'll just point out here, you can see that the blood leads were log linearly distributed. That's typical with metals exposure. So Pure Earth was engaged by the NCDC to look at what was causing, what were the sources of exposure? Why were these children, why do these children have elevated blood leads? We were tasked with looking at 16 quote unquote high exposure households, and this is where children had blood leads above 30 micrograms per deciliter. And just to point out, if you look at the upper end of the distribution here, there's some pretty high blood leads. Kids with 50, 52 micrograms per deciliter. For folks in the room, that's a really, that's exceptionally elevated. You wouldn't see that outside of an occupational setting typically. And then we also looked at lower levels of exposure. So this is where children have below 5 micrograms per deciliter. Just to go in, I'm sure this is common knowledge for folks in the room, but just to cover it very briefly, there is no safe level of lead exposure. Lead is a neurotoxicant, so it's confused by the body as calcium. It's taken into, it crosses the blood-brain barrier where it interferes with the development of gray matter. So there's a direct relationship between exposure, pediatric exposure to lead, and IQ decrement. So even at the US CDC reference level of 5 micrograms per deciliter, we would expect an IQ loss in a child of 1 to 3 points. There's also associations with increased blood pressure. So above 5 micrograms per deciliter, a doubling in blood lead levels associated with a 1 millimeter of mercury increase in systolic blood pressure. Now, importantly, the study in Georgia used blood lead levels rather than bone lead levels, which is another way that one can assess lead exposure. Now, bone lead would look over the lifetime of an individual, where blood lead would only look at a sort of a window of time. The half-life of lead in blood is about 30 days. So I'll just quickly go into, and this is probably redundant for folks in the room, but I think it's important. We'll just talk about the units that we're using. So 1 part per billion is equivalent to 10 parts per billion is equivalent to 1 microgram per deciliter. And a part per billion is equivalent to a packet of sugar dissolved entirely in a glass of water. So if you can imagine that, that's a really small amount of sugar dissolved in a glass of water. Now, some folks in the room know that I'm lying right now. This is not an accurate representation of 1 part per billion. Because in fact, 1 part per billion is a packet of sugar dissolved in an Olympic-sized swimming pool. So if we can imagine, in this case, the water in the pool represents the blood running through our veins, or in the patient's veins, then the packet of sugar is the lead that's also found in the blood. So really small concentrations. As I said, 1 microgram per deciliter is equal to 10 parts per billion. So it's about 10 packets of sugar in an Olympic-sized swimming pool. So really, really small concentrations can have a big impact on neurological development of blood pressure. I won't go too into this, but I'll just leave this slide here. These are some of the methods that we used for assessing various media. So here on this slide, what I'd like to bring your attention to is the table on the right-hand side. For folks who may not be that familiar with Georgian geography, Ajara, Guria, Imereti, these places are in western Georgia. In eastern Georgia, the blood leads were actually more consistent with other parts of the world. So, but there was a steep increase in blood leads moving west. So what these numbers represent, 86%, 78%, et cetera, is the number of children in the National Blood Lead Survey above the 5 micrograms per deciliter threshold. So as you can see, it's clear that kids on the western part of Georgia had higher blood leads than kids in the eastern part of Georgia, by a wide margin. Accordingly, we assessed homes. The homes that we assessed were more likely to be in the western region than in the eastern region. So, because we were looking at homes primarily with kids above 30 micrograms per deciliter. This is more on our methods. So we looked at water. We look at, having worked at lead sites sort of all over the world, folks are always concerned about their water. This is interesting, right? Because lead is not particularly water soluble in most forms. However, people want to know that their water is safe. So we assess the water in homes with 2 different instruments, one in a private laboratory and one in the Ministry of Agriculture. We took dust wipes, we packaged dust wipes. So one way that we can assess exposure in a home, particularly from lead-based paint, is that lead-based paint will get pulverized, it'll get broken down, and it'll find its way into the dust in a home. Or if the soil is contaminated outside, that'll find its way into the dust in a home. So we take dust wipes, we put them in a plastic bag, and we've actually brought those back to the US and had them sampled here. We also took spice samples in the field, and I'll talk about how. We took 10% of those and sent those to a laboratory. So most of our work was actually done with an X-ray fluorescence instrument. And just as background for folks that may not be familiar with this thing, they cost about $40,000. So they're not cheap, but they're not too expensive as far as laboratory equipment go. And they can assess upwards of 30 different elements in anywhere from 30 to 60 seconds down to parts per million. They're incredibly powerful instruments. In a day with one of these instruments, one charge of a battery will last you 6 hours. You can take 300, 400 different measurements down to parts per million. So this is a picture of me. I'm assessing paint, enamel paint on a door in Georgia. These are, by the way, the ICP-M, the PXRF is the standard unit that we use across the U.S. for doing lead-based paint assessments as well as soil assessments. With regard to soil, they have an excellent correlation with ICP-AES. It has an R squared of above 0.999, so almost 1. It's an exceptionally powerful instrument. We were unaware of, or rather I should say that there's only a handful of studies that evaluated the use of a PXRF instrument with regard to spices before we decided to undertake our study in Georgia. There were some studies indicating that above 10 parts per million, you could get a pretty good correlation, but we did go into this a little blind. So we looked at 25 different homes. We took 61 dust wipes in those 25 homes. We collected 114 spice samples. We took 15 different water samples, and we took over 700 PXRF measurements across a week in the 26 different homes. So with paint, another one, so when we talk about lead exposure, a lot of people's minds go immediately to paint. Now this is in contrast with the literature. So if we look at literature in the United States, there's a serious lead-based paint problem, particularly in the middle part of the 20th century. Lead-based paint was used extensively in the beginning of the 20th century, less so in the middle part of the 20th century, and was phased out in the mid-70s in the US, legally. But really, lead-based paint was primarily used in the beginning part of the 20th century. As that enamel paint began to break down, it started to cause an exposure in sort of the second half of the 20th century in the US. However, if we look outside the US, there is a dearth of evidence indicating that lead-based paint presents a significant exposure risk. However, because of the big problem in the US, and because of the Global Alliance to Eliminate Lead Paint and other global efforts, we always look at lead-based paint. So in this case, we took 228 different measurements. More than half of those were below the limit of detection of the instrument. It just didn't pick it up. The mean concentration was 0.159 milligrams per centimeter squared, which is below the US EPA threshold. I should say we only found a single sample above the US EPA threshold. It was on a piece of furniture that was imported from Turkey about 70 years ago. We looked at cookware, so we took 53 measurements using the XRF of cookware, mostly metal, some ceramic. Again, generally very low concentrations. If you look at the ceramic piece there, we found a mean concentration of about 78 milligrams per kilogram or parts per million. That might appear elevated, but at that level, it's more likely lead that's naturally occurring in the clay that's used to make the pot, as opposed to a glaze that's added to the outside of the pot, which would have a much higher concentration. And when you add a glaze, this is common, right? Particularly in the MENA region, so North Africa, I'm sure folks in the room are familiar with this. Lead oxide is commonly used as an artisanal ceramic glaze. When that's done, the potters themselves are acutely exposed, as other families and their neighbors. But there's a chronic exposure, a low-level chronic exposure that can result in blood leads of 5 to 10 milligrams per kilogram, micrograms per deciliter. But in this case, in Georgia, we don't think there's any extensive use of ceramic lead glazes. We also used lead checks, and these test for leachable lead, and we were unable to identify any leachable lead in cookware. We looked at toys, 65 different measurements. They were all, with the exception of 3 of them, they were all below the U.S. Consumer Protection Safety Commission standard of 100 parts per million. And only one of them was really high, and that's this truck here, which was, again, a Turkish toy that was imported to Georgia. It was about 1,000 parts per million. We're not convinced this was the source of exposure. However, we did confiscate and destroy the truck. That's me again, lots of pictures of me. Taking soil measurements, again with the XRF. We took 91 soil measurements with a mean of about 47 milligrams per kilogram. As context here, New York City, where I live, has a mean concentration somewhere between 100 and 200 milligrams per kilogram, as do most global cities. So these are very low. And by the way, that concentration results in the US primarily from lead-based paint and leaded petrol emissions deposited around the city and around the country. The fact that we found 47 milligrams per kilogram on average in Georgia, that's sort of much lower than international levels in urbanized areas. Again, dust, lots of samples, only 2 floor samples above the reporting limits of the laboratory. Both of those samples were above the US EPA action level of 40 micrograms per square foot. But other samples in the homes, in those same homes, are pretty low. So the area-weighted average of that dust exposure, again, is pretty low. All of the water samples that we took were below the detection limit of the equipment. So that brings us to spices. So I went into this exercise, I should say, quite skeptical that spices could present a significant level of exposure. However, also going in, I read some work, a recent study from the Department of Health and Mental Hygiene here in New York City by Paramita Hore, who's on the call at the moment, and hopefully we'll say a few words after I'm through with my presentation. But that study is very compelling, and it found significantly elevated levels of lead in spices. So we looked at spices in homes, and what we found was that the homes in the western part of Georgia had much higher levels of lead in spices than the eastern part of Georgia. The spices where we could identify the name of the spice had an average concentration of 1,000 milligrams per kilogram. If you look all the way at the bottom of the text there, the Department of Health and Mental Hygiene in New York City utilizes a screening level of 2 parts per million. I don't think it should say standard, a screening level of 2 parts per million, which is equivalent with milligrams per kilogram. So this is vastly in exceedance of anything that could be considered safe. The highest level that we found was in excess of 20,000 parts per million, which is, I mean, to put it very clearly, is poison. This is exceptionally high concentrations of lead in spice, and it's adulterated. It's deliberately added to add weight and color. This was interesting, so we wanted to compare the results of our XRF measurements with the ICP-MS, laboratory wet-based techniques, and we found a really high correlation, an R-squared of 0.98. We then calibrated all of our PXRF measurements to the ICP-MS. So here's a graphical representation of the concentrations that we found. I note that it's on a log scale. So if we look at Cavatelli-Cavavili, which is the colloquial name is yellow flower. The English name is yellow flower. You can see that nearly all the concentrations that we took were above 1,000 parts per million milligrams per kilogram. Some of them were upwards of 10,000. But all of the spices here, I mean, the vast majority of spices that we identified were elevated. We then took the data from our field study and we put it into something called the Integrated Uptake Biokinetic Model. This is a free model available at the US EPA website. With regard to lead exposure, the US has just done a tremendous amount of work, owing in part to the lead-based paint crisis here in the middle of the 20th century, et cetera. But we just have, we have so much data with regard to lead exposure and lead remediation. So this software, which is very powerful, can be downloaded for free at the US EPA website. And what it does is one inputs different sources of lead exposure, concentrations for different media, and the model will output an expected blood lead level. So this is my daughter about a year and a half ago. So in this picture, she weighs, say, 10 to 15 kilograms. About a year later, she weighed about 20 kilograms. She's a big girl. So her body weight increased by 30% in the span of a year. And to do that, she had to take in a lot of food. She had to take in a lot of water. And then her bones got bigger, her muscles got bigger, her brain got bigger, hopefully. And, you know, she just changed, right? I mean, if anybody in the room can imagine having their body weight increase by 30% in the span of a year. You know, it takes a lot of stuff, right? And so on a proportional level, she's taking in so much more of whatever is in the environment as her brain grows than any of us are as adults. So that's why we focus on kids as a vulnerable receptor. The model looks at air, looks at dust, it looks at soil, water. It makes a number of assumptions based on the peer-reviewed literature of the biokinetics and toxicokinetics of lead in the system, and then it outputs a distribution of blood lead levels. So on the right, what we did was we took the levels, the field that we identified in the field, and we plugged them into this IAUBK model. And we assumed a certain amount of spice ingestion per week based on the Georgian diet and some common Georgian recipes, which are delicious, by the way. If you have a chance to go to Georgia and eat Georgian food, it really is, it's some of the best food in the world, I have to say. But yes, we looked at spice concentrations that are pretty low, actually. So 0, 25, 50, 75, and 100 milligrams per kilogram, which are well below sort of the mean concentrations we identified. And we plugged it into the distribution. And these are probably too small for you to see. But this one here, actually the second one from the top on the left-hand side, has output a geometric mean of about 5 micrograms per deciliter. And that's based on a spice concentration of 50 milligrams per kilogram. So the purpose of this exercise was just to validate our assumption that spice concentrations could indeed result in an elevated blood lead. And what we found was that it actually takes much less than the stuff we were identifying in the field to end up with an elevated blood lead. It really just doesn't take a lot of lead in food to poison kids. Okay, that's the blood lead that we have from, that's the distribution from the National Blood Lead Study. Again, log normally distributed, and it matches best with the second from the top on the left-hand side there. And again, just to remind everybody in the room that it does not take a lot of lead. Really just small amounts of lead to end up with a pretty severe health hazard. In conclusion, lead-based paint does not appear to be prevalent in Georgian homes. Soil contamination also appears low. Water did not seem to present a significant source of exposure. Adulterated spices are common across the country, although more prevalent in the western part of the countries. Importantly, you know, when you look at the results of our study, it could be difficult to compare those with actually the high blood leads of kids that were identified because the blood leads were taken a year or more prior.
Oh, okay, cool.
Lastly, I'll just highlight some reading. There's 2 publications I'd like to highlight. The first is from Paramita, who's on the phone. I'll add, and I would like to invite to say a few words. And Jenna Forsyth, who did some work in Bangladesh. Actually, well, just quickly, the spoonful of lead study, they took more than 10,000 different samples of spices in New York City from a lot of different countries, assessed those for lead in a lab, and found some elevated concentrations. Lots from the MENA region and some exceptionally high concentrations from Georgia. And Jenna Forsyth's study looked at lead chromate use in turmeric in Bangladesh. So that's the team that did the study. Yeah, thank you very much.
Thank you, Brett. Paramita, would you like to say something, or would you like me to ask you a question? I have a question, unless you have something to comment on. And you can just speak, unmute yourself and speak. guess not. So any questions for me? Okay, I think you all had a long day. I thank you for your perseverance and resilience. Enjoy your evening. Tomorrow is the opening ceremony and the main program with 2 tracks here and there. So enjoy your evening and sleep well so you can be awake and alert all day tomorrow. Thank you.
Good morning, everyone. I think we are running late by 5 minutes. So we have to start the first session and the main congress. Today we have 2 tracks, basically track A on this side and track B will be on the next door. So whoever is in the wrong place. The first session for today is the emerging issues in emergency toxicology, and that will be moderated by Dr. Bassar Kader and myself. The first speaker in the list is Dr. Peter Akobono. Dr. Peter is basically trained in emergency medicine at the University of Kansas, at Kansas City, before completing a subspecialty fellowship in medical toxicology at Oregon Health and Science University and Oregon Poison Center in Portland. He joined the Department of Emergency Medicine at the University of Kentucky in 2017, where he serves there, as well as he is the medical toxicologist in the same Kentucky Poison Control Center. And he runs basically inpatient consultation service at the University of Kentucky. Welcome, Dr. Akobono, and his topic will be about opioid epidemic in the US. Where are we now, and where are we going? Thank you.
Thank you very much for the kind introduction. It's a pleasure to be here. So this is me. We're going to discuss the opioid epidemic. I'm Peter Opnanu. I'm a medical toxicologist and emergency physician, and as of the 1st of this year, now the director of the Kentucky Poison Control Center. So let's ask the question of where are we and where are we going? We'll review a few objectives here. We're going to go over some of the history of opium and opioids, as well as learn the causes of today's opioid epidemic in the United States, as well as understand the role that prescribers and patients have in this epidemic. So let's ask a simple question of what's your experience? Anyone have a family member, friend, know someone who's had issues related to opioid use? I know that I have. I've had a few that I probably missed where there were signs and symptoms that they had dependence. By the lack of hands, I guess you guys are doing a lot better than we are in the US. So let's take a quick review. Our total drug overdose deaths in 2016 in the United States were roughly 64,000, which made it more likely to die from an opioid overdose than from a motor vehicle accident. This is a stark contrast to about a 700% increase in overall overdose-related deaths that happened coming from 1990. What we see is just a steady, sharp incline over the last 30 years related to our overdose drug deaths. And of those, greater than 75% are related to opioids, both prescription and illegal opioids. Overdose is the #1 cause of death for Americans aged 15 to 50. Again, in 2016, we had 64,000 deaths as a result of drug overdose. To put it in comparison, this is almost 6,000 more than died in all of the Vietnam War. This is 24,000 more than died in all of the motor vehicle accidents that were reported in 2016. At our peak, we had a total of 47,000 deaths related to HIV. Drug overdose is more deadly than HIV, is more deadly than our motor vehicle accidents that we see on the road, more deadly than gun violence, which is very common for us. This is the poppy plant. This is one of our folks that's cultivating the poppy plant. The sap is where we get most of our opioids from. We'll take a brief history going through opium. So you take that dried sap and make it to get that latex, and that gives us a roughly 12% morphine content out of there. Roughly 4000 BC is where we first see documentation of people deliberately cultivating and growing opium for use. We have a long history of opioid as use as a medication. So we've seen it for the treatment of pain, which we continue to see for the treatment of pain, the calming of irritable infants, as well as a cough suppression and a diarrheal treatment. These really have not changed much over the years, although hopefully we're not using it as often to simply calm irritable infants. Recreational use isn't really documented until about the 1300s, starting with the Ottoman Empire. And then moving into the 1600s, we see an explosion in the use of opium in China. We finally see first documentation of mixing of opium with tobacco for the purpose of smoking. In smoking opium, we get a higher potency, we get a faster release into the brain, so it's a preferred method. In 1729, the problem becomes so severe in China, they go ahead and outlaw it. And then flash forward, go another 120 years or so to British colonialism, and now we start the Opium Wars. The two wars with China, related all around the British colony of India, and the desire to be able to push Indian opium into China. In the end, the British win both of those wars, and there's unrestricted access to Indian opium in China. So, the result, we see quite a bit of widespread opium use amongst the Chinese. We see the birth of the opium den, which you can see in the pictures here. Doesn't really work that well. You can lay down and smoke your opium and relax. Come 1905, based on the epidemiology, roughly 25% of males in China are regular opium users. Well, let's focus in on the United States a little bit. The Civil War becomes a real nidus for our opium and our morphine-related problems that happen. If you think back to our Civil War, the weaponry that we have for the Civil War is not nearly as efficient as the weaponry that we have now. Not as effective at killing, but very effective at maiming and causing permanent and lasting injury. And so what happens is our soldiers, after being struck by these weapons of war, are now left with permanent pain and quite a bit of excruciating pain. At the time, we're fairly limited in what we have to use to treat pain. So morphine becomes the drug of choice. With morphine being used quite frequently, our soldiers become addicted, and we get now what is known as the soldier's disease, which is morphine addiction. Come to the late 1800s, as the United States is completing its manifest destiny and expanding from coast to coast, we get a rush of Chinese immigrants to the U.S., both to our most populated areas at the time being San Francisco on the West Coast and New York on the East Coast. With that comes the cultural love and use of opium. Remember that roughly 25% of our Chinese males are using opium, so we finally see the emergence of opium dens in the United States. Finally, around the 1870s, just after the Civil War, we see a ban on opium dens. However, they continue to exist in clandestine areas all the way up until the end of World War II. If we take a brief product history related to our opioids in the United States, coming to 1804 is when we first see morphine being patented and used. Moving on until 1832, so a relatively large 28-year gap until codeine comes along. In 1878, we get heroin or diacetylmorphine created and patented, and start to see it used for medical purposes in the hopes that it is less addictive than morphine is. Surge forward roughly another 40 years, and then we finally see hydrocodone and hydromorphone, followed rapidly by oxycodone and methadone in use. Meperidine is developed just before the end of World War II, and then fentanyl in the 1960s. Heroin is our big scourge. We'll take a little bit of a focus here. So the generic name is diacetylmorphine. In the United States, we typically do not use we do not use heroin for any medicinal purpose. That's been going on since 1924. However, in other parts of the world, including Europe, heroin or diacetylmorphine may be used for both labor pains as well as for end-of-life care. So it's initially marketed by the Bayer Corporation as a non-addicting treatment for morphine addiction. The sentence is rather important because what we realize is that even when dealing with an opioid addiction, we still need an opioid to treat opioid addiction. In 1906, the AMA finally approves the use of diacetylmorphine for medicinal use as a replacement for morphine. And then not 8 years later, we have over 200,000 heroin addicts in the city of New York. roughly at that time a population of 5 million people. Thanks to the Harrison Narcotics Act in 1914, we outlaw the non-medical use of heroin, and then a short 10 years later, we outlaw the use even for medicinal reasons. Here's a few old advertisements for heroin. As you can see, it's being marketed as an antitussive here, so cough, the problem has been solved. Simply use glycoheroin. It's compounded securely and compounded at your pharmacy, and it's made by science. There's a little line in there that's made by science, so it must be good. The next is an ad that simply says fly heroin. With this ad that used to appear in Sears and Roebuck, you can make a purchase of heroin and have it delivered to you in the mail with your hypodermic syringe and needle. There's enough for 2 doses daily and a syringe that you can use twice in that day. And then following with just a simple ad for heroin hydrochloride. Sorry about that. So let's take an examination from the 1900s to the 1980s. Thank you. Prior to the 1980s, opioids are almost exclusively used for the treatment of acute, severe pain, which is where they got their start. Typically are not used for the treatment of chronic pain, and the vast majority of our opioid addicts are heroin addicts. And they primarily live in urban and inner cities. In the United States, they typically represent those of the lower socioeconomic class, and they represent the minority class. At this point in time, there is no opioid epidemic. This may simply be because we're not paying attention, simply because it's not harming those that we see or care about frequently. Another timeline when we start to see things change. So come 1984, MS Contin is approved for the use of terminal cancer pain in patients. Quickly following that, OxyContin is also approved for the use of pain in terminal cancer patients. And then 6 years later, OxyContin gets the approval for pain that is not related to cancer. And it is at this point that Purdue Pharmaceuticals begins to point out to us that pain is not being treated appropriately and is not being treated well. Come 2000, the Joint Commission for Hospitals in the United States brings up the pain scale and begins to ask the question, on a scale of 0 to 10, where is your pain at? Pain is now the 5th vital sign and something that must be treated. All pain that is not 0 needs to be treated. 2005, we see the proliferation of our patient satisfaction surveys. Namely, question on that is, was your pain treated adequately? Was it treated quickly? How is your pain doing now? And then finally, we get in 2007, Purdue Pharmaceuticals pleads guilty to false marketing for their product, saying that they had initially said that oxycodone was not addictive. There was a less than 1% chance of addiction, which we know to be untrue. Come 2010, we begin to see an increase in the publication of journal articles calling for us not to prescribe opiates as frequently as we have and to begin to restrict their use. But still following that, in 2016, the Centers for Medicare Services decide to make pain one of the core measures. Why does this matter? Well, as the core measures go, this means money for hospitals. If you're not treating your patient's pain adequately and you're finding out their patient satisfaction surveys, you are going to lose money. Further incentivizing you to provide more and more pain medications and create more and more addicts along the way. And then just recently, in 2017, we've had multiple states and cities file lawsuits against Purdue Pharmaceuticals and other pharmaceutical companies related to their advertising and pushing of opioid pain medications. It's a simple graphic to put opioids by the numbers here. Just to know that in 2016, over 170,000 adults in the United States began using heroin for the first time. Overall, related to opioid death and loss of work and other times, this has lost us $504 billion in work productivity for the year. So what's wrong with the United States? As a whole, we only represent about 5% of the world's population. However, 80% of the opioids are prescribed in the United States. And what we see is that maybe this opioid epidemic is a uniquely American problem. How are our patients getting started on opioids? If you take a look at the pie chart here, what we see is that greater than 50% of our patients are going to get started because they received it for free from a friend or a relative. added another 15% because they bought it from a friend or relative. It turns out that the drug dealer on the street is not the person that is most likely to get you started on opioids. When you find out where they're receiving their drugs, where their friends receive their drugs, the lion's share of them receive them all from one physician, one provider. This is what happens when you write a prescription for 60 oxycodone for a sprained ankle. Your patient takes 2, maybe 3 of those tablets and keeps the rest in their home. Their friend comes along and takes them. Their friend comes along and complains of pain as well, and they're given to them for free. What we're doing with large burden prescriptions is really just creating more and more addicts. In the United States, as an emergency physician, we get quite the blame for prescribing too many narcotics, for prescribing too many opioids. Again, that perfect scenario of there's an ankle sprain, and instead of prescribing ice and ibuprofen, compression, and rest, here's 15 oxycodone to take over the next several days. But it turns out when you actually delve into the numbers, those that are prescribing the most opioids are in fact the primary care provider, the primary care physician. This seems to be more related to maintenance than anything else. We're dealing with chronic pain inappropriately and providing opioid prescriptions continuously. We see orthopedists up there, which makes some sense, right? These are typically painful procedures, painful surgeries, and acute pain needs to be treated. Physiatrists, those are our physical medicine and rehabilitation physicians, are dealing with chronic pain as well. Our dentists will prescribe quite a bit of narcotics following your wisdom tooth extraction. I think I just had my wisdom teeth extracted this past year, and my dentist wrote me for 20 Vicodin to follow. I don't think I took any of them. So what are we seeing? We're seeing dramatic increases in both heroin and fentanyl-related deaths. What we have is chronic opioid therapy and toxicity. What we see is people developing a hyperalgesia. So they're becoming more and more sensitive to their pain as they continue to take these high dose and potent opioids rather than seeing their pain improve. And so what happens is they have a requirement and a need for escalating doses, which leads out to more and more opioid doses out in the community, more and more access for individuals. The results we see of an increasing dosing and increasing frequency. We have seen prescribing begin to taper down and cut patients off, but what this does is this drives them now to shop for other physicians. If this provider will not give me the opioids that I want, I will find a new one. And worst case scenario, they go out into the streets and begin to purchase heroin and other products. Why? Because heroin is cheap and readily available within the United States. And now we're seeing an increase in the fentanyl-related deaths as a result of that. Here's a chart that I'm certain that you guys got to see yesterday, related to all opioid overdoses. So what we can see is starting back in 2000 and moving up until close to the present day of 2015, our likelihood of opioid overdoses increasing dramatically. We saw a continual rise in our prescribing patterns and our prescribing of prescription opioids up until 2010, and then we start to flatten out. We don't see the decrease that we would like to see, that we stop prescribing, but we're not prescribing any more than we had. And if you take a look at that blue line that represents heroin, that goes along with our opioid prescribing. Once we stopped prescribing opioids, we started seeing an increase in the amount of heroin that was being used and heroin-related opioid deaths. And then the years following that, we began to see more of our other synthetic opioids and some of our manufactured fentanyls and clandestine opioids. Again, we see the 3-wave here. So early on in the early 2000s, most of the problem is related to us as prescribers, giving out too many doses. And in that interim time between 2000 and 2010, it's safe to say that we created a fair number of addicts, and our addicts are having difficulty managing their symptoms. Finally, as we realize that we are doing more harm than we are doing good to our patients, we begin to cut back on our prescribing, and this forces our addicts to go off to use heroin and more frequently. And then as heroin quality can sometimes decrease, we see the emergence of our more synthetic opioids being used and abused. What we have are stronger and more dangerous opioids than before. Our old heroin was roughly 10% pure. Our new Mexican heroin is on the order of 40% purity and can sometimes be found to be higher. If you're a dealer and you want to boost your product, you can go about adding fentanyl to also increase your high in the symptomatology that your patients will get. What we wind up is with things like with greater than 20 and 30% stronger than our usual heroin. Our average heroin user does not know what they're buying on any given day. So the same amount on Tuesday may cause them to overdose on Thursday. What we see is that all opioids abuse are on the rise. And why are people moving to heroin? As we discussed before, it's low cost. It's ubiquitous. We're seeing increasing impurity, and we're seeing the lack of access to prescription opioids. Opioid use and abuse comes in 3 simple phases. The early phase is 0 to 7 days. The middle phase is 1 week to 3 months afterwards. And then the late phase is everything that's after 3 months. Typically, we have focused mostly on our late phase at this point. This is where addiction and things are headline grabbers. Building a new rehab facility, getting people on new medications, that grabs a lot of attention. However, it's almost a little bit too little, too late at that point in time. We need to make a more effective focus on the early phase, on 0 to 7, with simply not prescribing or reducing the amount that we prescribe, and then recognizing individuals in the middle phase as they're beginning to develop addiction and dependence. So what do we need to know? 80% of our new heroin users began with prescription opioids. 69% of the first-time users get a prescription from their friends or their family. And every opioid prescription, even for a few days, has a risk of developing addiction. What we have to do is educate our providers and our public to minimize all the opioids. Here's an interesting graphic where simply receiving 1 day of opioids can increase your risk of chronic opioid use downstream. So if you receive up to 40 days of opioid use, at 1 year, you are 35% more likely to continue to be on opioids, and at 3 years, you're greater than 15% more likely. Pain usually gets better. Pain usually goes away. We usually tolerate pain and adapt to pain. There's very few reasons to continue on for 3 years taking opioids. For us to return to our previous levels of prescribing, we'll need more than an 80% reduction in our total opioids prescribed per patient. And without these dramatic reductions, we're going to continue to create more and more opioid and heroin addicts. What can we do? We can restrict ourselves to opioids for simple, severe, and acute pain. In the state of Kentucky, as a provider, I'm not really allowed to prescribe for more than 3 days of any opioid without a documented end-of-life condition for them. We need to begin to use other things such as ice and heat and elevation and rest and physical therapy to help to treat our pain. And if meds are being requested, we can use Tylenol and Advil and Aleve and Motrin. They're incredibly effective. And remember to inform our patients and have our patients ask if the prescription they're receiving does contain an opioid, as well as continue to restrict those opioids for severe pain to simply 2 or 3 days. We've made some progress, but there's still more progress to be made. In 2010, from 2010 to 2015, we have seen a 15% reduction in our opioid prescribing, but this is still well above our 1999 rates. We can focus on education with appropriate prescribing. We can discuss with our patients when opioids are necessary, and we can discuss with friends and families the signs and symptoms of addiction and opioid use. And moving further for treatment, we can try and increase the number of X-waiver physicians we have, or take the approach from ACMT, which is simply to remove the X-waiver and allow any physician to go ahead and prescribe Suboxone and buprenorphine as is necessary. Thank you very much.
Okay, please.
Hello. Good morning, everybody. I am Dr. Praveen Agarwal from India. We have a lot of opium, not overdose, but addiction in our northern state, that is Punjab. The estimate is that about 22% of students who are studying in schools and colleges, they are addicted to opioids. And the reason was easy availability of codeine as cough syrup, then tramadol as a painkiller, and opium as such. So it's not a question, but it's just a statement. Thank you.
Thank you. And Dr. Behçet? Wait for me, please. Wait, please.
Dr. Peter, thank you very much for your nice presentation. I am totally agree with you for the last slides. How can we prevent to use opioids in its groups? We are working in emergency departments. There is really no need to use more than one dose. Because for the severe pain, we are not the pain clinic. We are working in the emergency department, especially for the patient who have severe pain. Please do not use more than one dose. One dose is enough for us. So thank you very much. This is the most important way how can we prevent for addiction.
Thank you, Dr. Bajit. Okay, last question. Okay.
Thank you for the beautiful presentation. If you already said it, but I missed it, I'm sorry. But I would like to know which group is the most dangerous group for the opioid use in prescription drugs, naturally.
So for prescription drugs, it typically falls between the ages of 15 and 50, and those that are dealing with chronic pain. Those are the ones that are most likely to represent both to the emergency department as well as to their primary care provider. Oftentimes they're already on a chronic pain regimen, chronic opioid use, and they present to the emergency department with complaints of pain. And so rather than receiving simply one dose or no doses of opioid pain medication, they continue to receive multiple doses while in the emergency department.
Thank you.
Thank you. Dr. Aynur Şahin from Turkey. After completing her emergency medicine residency, Aynur continued her studies at 9 Eylül University Department of Pharmacology. Receiving her PhD, Dr. Şahin is postdoctoral fellowship trained in medical toxicology from Emory University and Georgia Poison Center in US. 2019, she published several articles about toxicology and emergency medicine in peer-reviewed journal, and she working in hepatotoxicology department, and I think she is the part of Eurasian Journal of Toxicology too. Please, Dr. Aynur.
Okay, thanks so much. Good morning, everybody. Today, my lecture is about cannabinoid emergencies, which is a really big problem all over the world. I have no conflict of interest, and my objectives are to make you understand the background, the mechanism of toxicity, and the clinical features of cannabis toxicity. Also, how we can evaluate and manage the patients in our emergency departments. So, cannabinoids, the plant also named as cannabis sativa, has been used for 4,000 years in traditional medicine. As to today, in modern medicine, they are only approved for the control of chemotherapy-induced nausea and vomiting, which is really resistant to other antiemetics and other supportive therapy. Also for the appetite stimulation in cachexia syndrome due to HIV injection. These are the most commonly used illicit drugs all over the world, especially in Europe and US. And the cannabis marketing is becoming more diverse and very complex. According to European Monitoring Center for Drugs and Drugs Addiction annual report in 2019, the estimated using numbers are about 25 million in adults and young adults. Illicitly produced herbal cannabis and cannabis ricin continue to be the most commonly used forms, and unfortunately these are more potent than the past. The legalization in medical, recreational use and edible products can cause big challenges in law enforcement, regulation and monitoring. I would like to also point out the edible cannabis products, which are really trending up these days. These products are like Pandora's box. So what I mean, the THC amount in per servings are really confusing and non-standardized. So the recommended psychotropic dose for THC for psychiatric effects. The recommended dose is like 10 to 30 milligram. But the thing is that these products, especially a single cookie, a single bar, or a package of gummy bear can contain around 100 milligram THC, which can cause a severe toxicity, especially young kids, because these products are so attractive and they are easily consumed, so kids are in danger. I had an experience with these edible products when I was a fellow last year. Last year on Valentine's Day, we had a call from public school nurse, and she declared us that after eating some home treats and some homemade sweets in the school, students started to becoming hallucinating, confusing, crying with crying red watery eyes. And they started vomiting, and all of them admitted to hospital. After the investigation, they found that one of the threats was edible cannabis product, and all of them discharged after 2 days with a healthy condition. So this is a really big risk for the kids. Cannabinoids has various forms, especially natural ones. They are called marijuana, which is dried crushed flower, heads, and leaves. Also, the other forms are hashish and hash oil. Cannabis contains more than 500 chemicals, and the most famous ones and most potent ones are THC, cannabidiol, and cannabidiol. THC is the most famous one. These are lipid-soluble and highly protein-bound. So this table shows the pharmacokinetics by the route of use. It compares the inhalational and intestinal exposure. If the route is inhalation, the absorption is so quick. The serum concentration peaks within 15 to 30 minutes, and also the onset of the symptoms starts within 15 and in 1 hour. As to oral ingestion, the absorption is really slow because they have low bioavailability. They had first pass metabolism, and they are they have chemical degradation in gastric acid. So the onset of symptoms are later than the inhalational ones, and these symptoms can lasting up to 12 hours. The metabolism of THC undergoes in hepatic enzymes called C2C9 and 3A4. The active metabolite is 11-hydroxy-THC, and the inactive metabolite is THC carboxylase. And they are excreted via urine and feces. Also, they are excreted in human milk. What is the mechanism of action? There are two main types of cannabinoid receptors. Cannabinoid 2 receptor is primarily found on peripheral tissues, so the most important receptor is cannabinoid 1. They are found in high densities in the brain, especially basal ganglia, cortex, cerebellum, and hippocampus, and they cause inhibitory modulation of serotonin, norepinephrine, and dopamine. The actions at these locations cause the cognitive and motor impairment. Synthetic cannabinoids, actually the name is synthetic cannabinoid receptor agonists. They are created in late 60s for the therapeutic purposes, but now they are only used for illicit purposes. They have lots of street names. These street names are K2, Spice, Crazy Monkey. They have a really similar structure with THC, similar structure to THC. The thing is that they have large of chemicals and additives which can affect the detection and the potency. What is the differences between synthetics and natural cannabinoids? Synthetics are full agonists, so they have greater potency, they have longer duration of clinical effects, and the additives that they contain can cause severely life-threatening complications. Clinical manifestations varies depending on the dose, route of administration, the experience of user, the vulnerability of user to psychoactive effects, and also which the drug is used and combined with the other substance. For example, after smoking a one marijuana cigarette can cause euphoria, palpitations, heightened sensory awareness, altered time perceptions, exacerbate psychosis also with a previous medical history of bipolar disorder or schizophrenia. Passive smoking only affects young kids and infants. They don't affect the adults. So passive smoking does no effect on adults. As to clinical manifestations to the cannabinoid toxicity, CNS symptoms varies between moderate, mild mental status change to coma. Also, we can see seizures, we can see sleepiness, somnolence, ataxia, slurred speech, psychosis. As to cardiovascular symptoms, the most common symptom is tachycardia, palpitation. Also, we can observe hypertension, chest pain. The respiratory symptoms are tachypnea, dyspnea also occurs in these patients. Rhabdomyolysis we can also observe and they can cause acute kidney injury. Also, we can see some GI symptoms like nausea and vomiting and also dry mouth. They are used with the concomitant substance. The most concomitant substances are alcohol, cocaine, and amphetamine, and they can alter the physiological and psychological effects of cannabis. As to pediatrics, kids are more likely to have drowsiness, lethargy, adults. There are several case reports about cardiovascular and neurological toxicity due to synthetic cannabinoids, but the evidence are really low-based evidence. We have case reports after synthetic cannabinoids use. We can see these case reports with acute MI. Also, I had a case report after a patient presented with sustained VT and VF after using of synthetic cannabinoids combined with toluene. This patient resuscitation lasts in 10 hours, and after 2 weeks, we discharged him with a healthy condition. Also, this sudden cardiac death reported due to synthetic cannabinoid exposure. Ischemic strokes, subarachnoid hemorrhage also reported after the use of synthetic cannabinoids, but the evidence is really low. In 2018, Illinois Poison Center reported to public health system that there are lots of patients presented with high INR levels with unexplained bleeding to the emergency departments with a history of synthetic cannabinoid use in 3 days. And they made the investigation. And they found that these cannabinoid products are contaminated with bradifacum. So a total of 155 cases had been identified. 147 individuals required hospitalization. 4 patients died because of the major bleeding, and the most common sign was hematuria. They added bradifacum, and bradifacum, as you know, it's the superwarfarin, which has a long time elimination half-life and 1 times higher potent than the other warfarin groups. As diagnostic testing in our clinics, only enzyme multiplied immunoassay techniques and radioimmunoassay techniques are available, and these are qualitative tests. They detect only inactive metabolite of THC, which is called THC carboxylase. The disadvantages are they don't measure the degree of exposure and they cannot detect the new synthetic cannabinoid metabolites. And also we can have false negative and false positive results. The detection range varies between 15 to 100 nanogram per milliliter. For legal implications, if the level greater than 20, that needs confirmation with advanced techniques. And the mean time for positivity varies between 3 days to 18 days for light users, and it varies 7 to 34 days for heavy users. The advancing testing methods are GCMS and HPLS techniques. These are the reference methods. We can analyze urine and serum samples. The metabolites can detect in urine up to 7 days for just single, for the history of using just single cigarette. But the problem is that they have a really limited clinical utility, and also they have challenges to detect the new synthetic cannabinoids, especially the new released ones. Yes. Also, passive inhalation of marijuana is unlikely to result in positive urine test results unless the exposure has been extreme or the exposure has occurred in a young child. As to management, the managements are only includes the supportive therapy. There is no specific antidote treatment for the cannabinoid toxicity. Decon is not recommended. For example, for agitation and anxiety, the first-line therapy is benzos. We should keep away from antipsychotics. If the patient has tachycardia and hypertension, the first-line therapy is also benzos. If the patient has ventricular dysrhythmias, we need to follow ACLS guideline. If rhabdomyolysis occurs with acute kidney injury, we need to give fluids resuscitation and we need to consider hemodialysis. Other heart problems related with cannabis use, one of them is cannabis hyperemesis syndrome. This is seen in the chronic and heavy marijuana use. The pathophysiology is unclear. The clinical syndrome includes abdominal discomfort, pain, nausea, and hyperemesis, which is really resistant to standard therapies. But the interesting thing is that symptoms improve with bathing or showering with hot water, but this mechanism is also unclear. The treatment is only cessation of the marijuana use. The other health problem is we can also observe cannabis withdrawal syndrome, which are not as serious as like opioid withdrawal or benzodiazepine withdrawal. The mechanism is the desensitization and downregulation of cannabinoid 1 receptors. We can observe irritability, sleep difficulty, decreased appetite, decreased mood. Also, they can have one of the following physical symptoms such as abdominal pain, shaking, tremors, sweating, fever, but these symptoms are not as severe as like the other withdrawal syndromes. Also, in the literature, we have lots of studies. They detect there are lots of cannabis contaminants, and they cause lots of health problems. For example, the most common cannabis contaminants are microbes, heavy metals, pesticides. Also, we have lots of case series like lead poisoning, arsenic poisoning due to cannabis contaminants with lead and arsenic. Also, we can observe like severe infections, especially immune-compromised patients due to cannabis contaminants. Take-home points, cannabis use are trending up. Pediatric cannabis exposure are more frequent owing to rising the use of edible products. Synthetics can cause life-threatening complications. Diagnosis of synthetics exposure is really challenging, and the management is only supportive. Thank you.
So, we have time for 2 or 3 questions. If anyone. Yes, please. Can we have the mic on that side, please?
Thank you for your nice presentation first. I want to ask you, there is a new article in the England Medical Journal related with the use of synthetic cannabinoids in a liquid form in electronic cigarettes resulted in ARDC, acute lung injury. What do you think about this topic? This liquid form usage in electronic cigarettes can cause a new outbreak in the world?
The thing is that, first of all, I would like to say that I didn't read this article about the acute lung injury, but I think the additives can cause lots of complications. So the thing is that we need to know about which additive can cause this type of acute lung injury. And I hope I told you that most of the mechanisms for these complications are uncleared. And also thank you for your comment and remind us to that also can cause a lung injury. So we need to be careful about the especially synthetic cannabinoids for all over the world. But it is published where? Okay, so we also take care of this type of complications, but you know, these days the contaminants, the additives, can cause of this type of complications. But I have really no detailed information about that. If Bedriya, do you have any comments about the acute lung injury for the cannabinoids? Maybe we can discuss after our meeting. Thank you. Thanks so much.
Okay, because of the time, I think we will invite our third speaker, Dr. Bruno Migerban. Yes, we have a little bit change in the program because so we will have Dr. Bruno Migerban. He's a professor of the critical care medicine at Paris Detroit University. He's the head of the Department of Medical and Toxicology Critical Care at La Ripostière Hospital. Yeah. He is currently the past president of the European Association of Poison Centers and Clinical Toxicologists, and he is the chair of the scientific program for Minatox 2020. He conducted several research and clinical trials on the clinical toxicology related to opioid, respiratory toxicity, prognostic factors of life-threatening poisoning, and the management of refractory cardiotoxicants, poisoning using ECMO. Today, he is going to speak about GHP derivatives, the sleeping beauty in your ED. You have 20 minutes for that, Dr. Moore.
Thank you, Bedriya, for this very kind introduction. Good morning, everybody, and I hope you will enjoy this Congress program. So now we'll talk about GHB derivatives related poisonings, and as you will see, these acute toxicity is increasing in many countries in Europe and especially in France. So we'll start with a short case report. This is a 27-year-old female. She was found drunk in the street around 10 p.m. She told the bystanders that she had ingested drugs. Rapidly, the pre-hospital medical services arrived on the scene. She presented a coma, a non-reactive coma with bradypnea and bradycardia. And she experienced rapidly a cardiac arrest. Immediate SCLS, including cardiac massage, tracheal intubation, mechanical ventilation, and epinephrine administration, allowed a return of the spontaneous cardiac activity in sinus rhythm. And she was transferred to our ICU at midnight. On admission, you see her vital signs, and her neurological examination showed a coma with classical coma score of 3, non-reactive mydriasis, but no brainstem reflexes. There were no additional abnormalities, but when we performed her biological test, we were surprised by a very severe metabolic acidosis, 6.46 for the arterial pH, 3 millimole per liter for the bicarbonate concentration. Her lactate were almost normal, 1.32, no ketones, and as you see, when you calculate the anion gap, it was about 37 millimole per liter. So she exhibited a very important metabolic acidosis with increased anion gap. She was managed symptomatically with fluids, norepinephrine, alkalinization, and she was treated with intermittent hemodialysis during 4 hours. She also received fomepizole in the hypothesis of an intoxication by toxic alcohol. She received a bolus dose and followed by a continuous infusion during the hemodialysis. Her routine toxicological screening tests showed the presence of fluoxetine and mirtazapine, suggesting that she was probably depressive. But what was curious is that all the alcohols, including ethylene glycol, methanol, ethanol, and also salicylates, were totally negative. So she presented a severe metabolic acidosis that was rapidly corrected with the treatment, but no toxic alcohol. Rapidly she improved, she was extubated and discharged and went to the psychiatric follow-up. Of course, we have no diagnosis at that time. I don't know if you have any idea, but hopefully her roommate came to the ICU with a bottle of 1 liter of gamma-butyrolactone, GBL, that was found empty near her bed. So we, based on this finding, we performed additional analysis and we measured the concentration of GHB in her blood on admission at 6,400 milligrams per liter, and about 4 hours later at 7,180 milligrams per liter, which represented the highest plasma GHB concentrations ever reported in the medical literature. So what is GHB? Probably you know that this is a colorless, odorless liquid. It is water-soluble, slightly salty and bitter taste. It is used as an anesthetic drug and also as a treatment of narcolepsy. But of course, it has been used as recreational drug, although its dosing is difficult. And it is classified in many countries, and especially in France, as narcotic and illegal drug. GBL, gamma-butyrolactone, is also water-soluble, colorless and oily liquid, miscible with alcohol, but with a ketonic odor. It is used commonly as a chemical in the industry for paintings, varnishes, and cleaning of car rims. It is also used as recreational drug because it is metabolized in vivo in GHB. So here are some marketed GBL products, and you see you can easily buy it from the market and even from internet, when you can buy like 1 liter of GBL while it is transformed in an illegal drug. So you have a product that is legally sold on the market, easily available, and it is transformed immediately in vivo in an illegal drug. So this is very curious. The recreational use of GHB, GBL is mainly in the gay clubbing. It has also been incriminated as a criminal drug used for sexual assault. And based on all this risk, it was, as explained, classified as on list 1 and narcotics in many countries, but it's still used and misappropriately used in the recreational scene. And we observed an increase of its use recently. And many first experimentations in naive patients. You see here, based on the reports from the Paris Poison Control Center, the increase in the number of use and fatalities in Paris area. Here in our ICU, also a significant increase in the use of GHB, and more recently in the appearance of GBL used among these admitted patients. So that all the French newspapers 1 year ago talked about this important issue with the increase of use of GHB at the recreational scenes. In Europe, this is also the case, and you see here, based on the Euroden data, Euroden work group data, you see that GHB, GBL is also very extensively used among the patients who are referred to the emergency departments in Europe, and it is at the 4th rank among the illicit drugs after heroin, cocaine, and cannabis. So what is GHB? GHB is a physiological neurotransmitter. It acts on the receptors of GHB, but also on the GABA-B receptors. And of course, it can be metabolized to GABA, and thus act also indirectly on the GABA-A receptors. So it's like a sedative drug. So if you measure your concentration, you have endogenous GHB concentration, which is not 0. GHB is rapidly absorbed with relatively low bioavailability with the oral route. Its volume of distribution is relatively limited, no protein binding, and a metabolism to water and CO2. And that's why it is used for RAP, because you cannot find GHB when the patient wakes up. It is renally eliminated for 2% with an unchanged form, and its kinetics is nonlinear with a 0 order at high dose. What is important is, from a pharmacodynamic point of view, its action is relatively short, during 1 to 3 hours maximum. GBL is it's the molecule that is metabolized in vivo by serum lactonase to GHB. Metabolization is very rapid, within 30 minutes, and it follows approximately the same pharmacokinetics without elimination as unchanged form in urine. Here also the effects are very short. So this slide shows you this metabolism, and you see that GBL is transformed rapidly by lactonase to GHB. You have also another derivative, which is called 1,4-butanediol, which can also be metabolized in GHB. And GHB is a neurotransmitter that can go to GABA. And itself it's metabolized into water and CO2. The toxicity is dose and concentration related, and you see if you increase the dose, you will increase the risk of CNS depression, respiratory depression, and of course you may present even cardiovascular instability with bradycardia, hypotension, and risk of seizures, and finally depression of even brainstem reflexes. In many situations, GHB and GBL is used with other drugs in mixed poisonings, but it seems that there is no clear symptoms that may distinguish this mixed use from the use of GHB by itself. The patients will present a deep coma, and the question, of course, for the management is to know whether you have or not to intubate the patient, because the duration of the coma is very short. So this is debated in the literature, and you see here just a case, a situation where 21 participants to a rave party arrived at the hospital with a Glasgow coma score of less than 8. They were supposed to be intubated, all of them, but none of them wasn't really intubated, and all improved spontaneously. So, of course, intubation is debated, but probably it may secure also the respiration, and especially if the risk of aspiration and seizure is important. There is no efficient antidote. Several antidotes were used: naloxone, flumazenil, physostigmine, benzo, but none of them has any effectiveness to reverse or improve in anything the patient outcome. There is no clear relationship between GHB concentration and the depths of coma, thus suggesting a very important inter-individual variability in the onset of consciousness impairment. And of course, there is a tolerance. So if you are a chronic user of GHB, you will have less neurological symptoms than a naive patient. What is interesting is that there is like an on-off effect with GHB. And you see this relationship between, in one patient, between the Glasgow coma score and the GHB concentration. And you see that a very limited decrease in the concentration around the EC50 of this drug will result in a very important modification of the Glasgow coma score. And finally, before going to the solution of our case, there is, of course, a dependence liability, and chronic use may result in withdrawal syndrome, with, you see, an onset rapidly after the cessation of the use, a duration of 14 days. Withdrawal may be very severe with tachycardia, anxiety, agitation, hallucinations, delirium, seizures. It is similar to benzo and alcohol withdrawal, and it is managed usually with benzodiazepine and sometimes even require barbiturates. So let's go to our case. What was the problem? When reviewing the literature, we found 2 cases with such severe metabolic acidosis with increased anion gap. This is the first case, which looks like ours, self-ingestion of 300 milliliter of GHB, presentation with coma, respiratory depression, bradycardia, and you see a severe acidosis, pH 6.75, with an important concentrations, even though lower than ours, of GHB. The patient presented also a cardiac arrest and was treated with hemofiltration and discharged without sequela. This is the second case published in the literature. Here also use of GHB with severe metabolic acidosis, a high concentration of GHB. The patient was also treated with hemodialysis, which resulted in a rapid normalization of her metabolic situation and discharge without sequelae. So what are the mechanistic hypotheses? If you take GHB orally, then you have a saturation of absorption and metabolism. So, as shown by this experimental study, even if you increase the dose, you are unable to increase the GHB concentration due to this saturable absorption. While if you ingest GBL, then you see that you have a dose-dependent elevation in GHB concentration, and you are able to increase GHB concentration because it is much better absorbed and immediately metabolized from GBL to GHB after absorption by the lactonase. So if you drink GBL, you are able to increase GHB concentrations to concentrations which you cannot reach, never, if you ingest directly GHB. And of course, as our patient, if you drink GBL in a binge manner, then you can increase so highly the GHB concentration that you will modify the equilibrium between the anionic and the cationic form, and you will exhibit a metabolic acidosis with anion gap related to the anion form of GHB, which is gamma hydroxybutyrate. So the only solution to reach very elevated concentration of GHB is to drink GBL, which seems to be much more dangerous than GHB. And in this case, you will exhibit a metabolic acidosis with increased anion gap. In practice, there is the diagnosis between GHB and GBL poisoning is not so easy because almost all GBL is metabolized in GHB, and you will not be able to diagnose the presence of GBL. So you will only measure GHB. So you have to measure GBL in the drunk solution only. So it is difficult, and you have to base your diagnosis on the patient report. So in conclusion, GHB and GBL poisonings are increasing. Severity may be increased in case of co-ingestions, mainly other drugs and ethanol. And the biochemical properties allows GBL to be transformed in GHB and to induce metabolic acidosis, which is observed in case of binge-type GBL ingestion by an unusual consumer. So what to do in practice? Clinicians have to be aware of this rare risk of metabolic acidosis due to GBL binge drinking. Diagnosis is based on the screening of GHB and the measurement of its concentration. And of course, in case of very severe acidosis, early ECTR with mainly intermittent hemodialysis is required to avoid organ failure and fatality. Thank you very much.
For one question before we move to the last. Yes.
Dr. Bruno. What happened to your first case that has a very deep acidosis? It was 6.46. What happened to this patient?
So she improved by hemodialysis, and she was discharged without sequelae at home rapidly. Acidosis rapidly was corrected. I showed the slide. Rapidly was corrected by hemodialysis. And the anion gap was related to the anionic form of GHB. And as I have explained, to reach such a situation of anionic GHB, you have to drink GBL, because you have to reach very elevated concentration of GHB, which is impossible if you drink directly GHB, because first, you have not so large amounts of GHB, because it's an illicit drug, so you cannot drink so large amounts. And secondly, absorption is saturated. So even as shown in the rat, even if you ingest large amount of GHB, you cannot increase the concentration of GHB. While if you drink GBL, then it is rapidly absorbed, immediately transformed by lactonase, and you can reach very elevated concentration of GHB and present this situation. That's why in the past we did not see such situations of metabolic acidosis, because it's impossible to reach this with GHB. You need to drink GBL. And that's why this situation is rarely reported, just 2 cases in the literature. And our case has the highest concentration ever reached of GHB.
Okay, sure. Another question? Yes.
If I'm not wrong, you've started to treat with fomepizole in your first case, right? Did you have any answer for this treatment? I believe that you followed the ABG, so did the patient improve in this period?
We administered fomepizole because based on the onset
gap,
of metabolic acidosis with increased anion gap, we suspected initially that the patient has drunk
methanol or other
toxic alcohol, even though the history of the patient was not supporting such drinking, because the interval of time between the exposure and the onset of metabolic acidosis was very short. But our physician in charge suspected toxic alcohol and administered fomepizole to block the metabolism. And then the patient was immediately dialyzed. I think fomepizole has no efficiency on the situation, but hemodialysis immediately improved the situation because it corrected the acid-base disequilibrium, and also it allowed the elimination of the toxicant.
I'm asking
the toxicant can be eliminated by dialysis.
Yeah, I'm asking that because in our hospitals, I don't believe that we can measure this GBL or GHB. So in the emergency department, we need to have another treatment option. So hemodialysis is gonna go after, and it's gonna take time. So I'm actually looking for another solution to keep these patients alive.
No, there is no antidote. But as you understood, such a situation is very rare. I'm not sure that you will meet such a situation because it's very rare. In the majority of GHB poison patients, it's only coma, and it's only intubation or not. As I showed you before, intubation is debated because the coma is very short. So either you decide to intubate or not, but there is only a coma with a duration of 1 to 3 hours maximum. This situation of metabolic acidosis is exceptional, and you cannot reach it with GHB. You have to drink GBL.
Okay, thank you.
I don't know if GBL is surely available everywhere because you can buy it on internet.
Yeah.
But the people don't know this. While recently in France, it was advertised. I don't know why. It was advertised in the recreational scene that you can drink GBL and it is like a GHB. GHB is illicit, GBL is available. So all the people started to drink GBL and buy it from the market.
Okay, for the sake of time, you can approach Dr. Migerban during the break and discuss this in details.
Yes, thank you. Thank you, Dr. Bruno. I want to invite, with my pleasure, my colleague, Dr. Mehmet Okumuş. He's an associate professor of emergency medicine at Medical Science University, Ankara Training and Research Hospital. He worked as an emergency medicine consultant in various provinces, Istanbul, Konya, Malatya, and he is an instructor in basic life support, advanced life support, and traumatization course, and he is from board of IPAT. Okay, please, Mehmet Okumuş.
Thank you, dear Bashar Jander. Yes, I traveled a lot in Turkey, not much in abroad. So I'm going to talk about toxic ECG. ECG is a screening tool for the heart and for the diagnosis of the cardiac toxicity, and we can use it for the prognosis of heart, and the monitoring progress is a guide to manage and disposition. ECG is very cheap, is readily available, and it's not invasive, and it identifies potential fatal cardiac conduction abnormalities. You can see this cardiac conduction system. It's an impulse provides by the sinus node, and it's current through the conduction system to atria and ventriculi, and then occurs to systole. Here we see the action potential in sinus node. The automaticity depends on the slow sodium channels. As the increase sodium in the cell, it increases the voltage, and if it reach minus 40, an impulse creates, and this period creates automaticity. And in the muscle, the phase 0 creates QRS, and the phase 2 and 3 creates QT period. As we see in the right, at the end of the phase 3, contraction occurs. So we can see different kind of action potentials and different from generating different part of heart. So I'm going to talk right now mechanism of cardiotoxicity and their manifestations on ECG. When blockade of sodium channels occurs, the slope of phase 0 decreases. And at this time, the QRS widens. And in AVR lead, the R wave is getting bigger, and right axis deviation occurs, and ventricular tachycardia and fibrillation may occur, and brugada phenocopy may present. When blockade of potassium channels, the phase 3 and 2 and 3, it causes the elongation of T wave, and at the end it occurs QT prolongation, and this may cause torsades. And beta-adrenergic receptor blockade causes sinus bradycardia, first, second, and third degree blocks, junctional bradycardia, and ventricular bradycardia. Propranolol and sotalol differs from other beta blockers. Propranolol acts like TCA, therapeutic antidepressants, and blocks also sodium channels, and this cause wide QRS. And sotalol blocks potassium channels, and this cause QT prolongation, and may cause torsades. And calcium channel blockade causes sinus bradycardia, second and third degree heart block, sinus arrest with nodal escape, and may cause stale. We have to keep in mind the prolongation of PR interval may be the first sign of calcium and beta blockers without any sign of other blocks. There are many kinds of drugs and agents that blocks sodium channels, and there are also many drugs that blocks potassium channels. So when we approach and toxic ECG, we have to follow a systematic row. The rate of ECG and rhythm of ECG, PR interval, coarse duration, and we have to check the right axis deviation and also check QT interval and CD, ST segment elevation or depression. First of all, when we check rhythm and rate, when tachycardia occurs, we may suggest sympathomimetics and anticholinergic toxication and group 1A and C antidysrhythmics. When bradycardia occurs, the cause of toxication may calcium and beta blockers, digoxin, opioids, organophosphates, and lithium. When enhanced automaticity occurs, the poisoning, the cause of poisoning may digoxin and symptomatic toxicity. When we evaluate the PR interval, when it's long, it suggests calcium and beta blockers or digoxin toxicity and other drugs. When we evaluate the QRS interval, it must be more than 100 milliseconds, usually caused by drugs that block sodium channels, TGAs, class 1 antidysrhythmic, and carbamazepine. And we can see right bundle branch block, prominent R wave in AVR lead. When we evaluate QT interval, usually caused by potassium channel blockers toxicity, we have to measure QT interval at the beginning of Q wave and at the end of T wave. But if we see U wave, we have to measure it with T wave. And we have to be aware of torsades. And when we have bradycardia, constant bradycardia is more likely to be with torsades. When we measure QT interval, we get used to use corrected QT, but in intoxications, in cardiac toxications, we have to use absolute QT because of it's more relevant with torsades. We can use to evaluate the QT with QT nomograms. It's available everywhere. If you measure, if the QT interval above the line, torsades is more potential. There are some drugs that prolongs QT that we use often, antihistamines, antibiotics, antidysrhythmic agents. Management of specific cardiac drugs. I want to go with cases. Case 1. 62-year-old female with past medical history of hypertension, coronary artery disease, and atrial fibrillation. She is tired and weak. She presents to ED, and she appears alert. She reports an episode of syncope, and she was bradycardic and hypotensive. She is afebrile and she has any tachypnea or hypoxia. This is the ECG strip. First of all, if we evaluate rate, it's bradycardic, it's rhythmic, and if we evaluate D2, we can see the first degree block. She has been taking metoprolol at 200 milligrams. She forgot to take it, and after she take it together, 3 pills each time, and at the end she became toxic. What can we do in beta blocker overdose? We have to give fluids when hypotension occurs. When it's unresponsive to IV fluids, we can use vasopressors. And we can use specific antidotes, high-dose insulin. And when bradycardia occurs, we can use atropine. If unresponsive, beta-agonist isoprene infusion. Glucagon, when we can use, but it's inferior to high-dose insulin. Case 2, a 70-year-old man with a history of hypertension, depression, and alcohol use disorder present after ingesting more than 50 tablets of calcium channel blocker. After 8 hours, he was lethargic. His heart rate was 30, blood pressure was low, and his ECG was like this. As we can see, it's written back, but bradycardic. And if we look at the D2, yeah, we can see the P waves and QRS waves are dissociated. Yes. They are complete heart block, and sinus rhythm is about 90, and ventricular rhythm is about 30. Calcium channel blocker toxicity presence with bradycardia and AV block and myocardial depression. If hypertension present, fluid resuscitation is necessary. If it's not response to IV fluid, we can use cardiac inotropes and vasopressors. We can use also ECMO. To bradycardia, we can use atropine, but sometimes it doesn't respond to it, and we can use pacing, transcutaneous or transvenous. Specific antidotes are calcium gluconate and high-dose insulin. The next case is about 61-year-old male patient. 5 hours prior to presentation, he ingested approximately 60 tablets of amitriptyline. He is confused and combative on arrival. Vital signs, he is tachycardic and blood pressure is low. His ECG is like this. He's tachycardic. as you see, QT wave is long, and on AVR is prominent R wave, and in V1 is Brugada-like shape, and in V2 is first degree block. The PR wave is long. Yes, we can use an tricyclic anti-dose, anti-drug poisoning, sodium bicarbonate, and we can hyperventilate patient. And we can use in hypotension crystalloids and vasopressors. The next patient present to the AD with syncope. He was on antibiotic use, ciprofloxacin, for his cystitis, and he present AD with syncope, but he recovered rapidly. He's bradycardic and hypotensive. The ECG is like this. As we measure the QT wave, it's long. And if we use the QT nomogram, is the QT is above the line. So it can be present, or it can be cause of torsades. And in fellowship, in the fellow of the patient, there are polymorphic VT and torsades occurs. I want to mention the digoxin toxicity. The digoxin toxic dyspnea combines with ventricular tachycardia and slow ventricular response. It's frequently occurs prematurely ventricular systole, sinus bradycardia, slow atrial fibrillation, and any type of AV block and ventricular tachycardia. There are some examples. Sinus rhythm with PVCs, ventricular bigamy. And here is atrial tachycardia with high degree AV block and PVCs. This is a classic of ECG of the digoxin toxicity, atrial tachycardia, and high-grade second-degree AV block with frequent premature ventricular complexes. And this one is bidirectional VT, broad complex tachycardia, and axis alteration in each beat.
Last 1 minute.
Okay. So, thank you for listening.
Time, but only one question, maybe one question. No, okay. We have break, after break, opening ceremony. Waiting all to opening ceremony. Okay, thank you.
Welcome to everyone to our opening speech. I hope you are enjoying this section. And now I would like to introduce Dr. Ziad Kazi, the president of Minatox, for giving his opening speech.
Thank you. I was hoping I get some music and stroboscope so I can get up here with the... What happened to that? I was... Anyway. I want to actually, first of all, address our audience, the Ministry of Health, with Dr. Samih Kurtut, who's not here with us today, unfortunately, because of a competing obligation. But he was supposed to be here, so I want to just address him. Also want to address the Turkish Red Crescent, which is represented today in the ceremony, as well as AFAD. Unfortunately, Turkey has had several recent natural emergencies that have really occupied them, and you know, all our thoughts and hearts go to people that lost family members and friends, and also for those that died or were injured. I also would like to address Dr. Bashar Jandar, President of IPAT, Dr. Bashat Al, Treasurer of Secretary of IPAT, and my sidekick in this conference, Dr. Lisa Moreno, President of the American Academy of Emergency Medicine, Dr. Mohammed Al-Hajri, Director of Emergency Preparedness at the Qatar Ministry of Health, Dr. Paul Wax, Executive Director and past President of the American College of Medical Toxicology, Dr. Charles McKay, immediate past President of the American College of Medical Toxicology, Dr. Ashish Balla, President of the Asia Pacific Association of Medical Toxicology, Dr. Praveen Agarwal, Chief of Emergency Medicine at AIIMS, New Delhi, India, Dr. Amin Kazi, President of the Mediterranean Academy of Emergency Medicine and past President of the American Academy of Emergency Medicine, Dr. Yassine Tunçuk, President of the Turkish Society of Pharmacology, Dr. Kai Kehe, representative of Dr. Horst Thiermann, President of the European Association of Poison Control Centers and Clinical Toxicologists, and one of our two keynote speakers this morning. And our other keynote speaker, Dr. Hussein Hassanyan Mugaddam from Iran, from Tehran, Director of the Poison Center in Tehran. And then guests, delegates, and participants from Turkey and beyond. And I apologize if I missed anyone, but I hope that you will enjoy this amazing conference that we put together as a collaborative effort between MENA Talks and IPAT. We wanted to come to MENA Talks, to Istanbul, for many reasons. But the first reason is we've had an exceptional experience in 2011 in Trabzon. And through the passion of Turkish colleagues like Dr. Bahshat, Dr. Aynur Shaheen, Dr. Jandar, we were invited to come back for this year to beautiful Istanbul. Now, MENA Talks is a nonprofit organization, and our mission is to advance the care of poisoned patients and to prevent poisonings. And we want to do that through education, research, and clinical care. We also want to advance public health strategies that prevent poisonings and then improve the situation in our MENA region in terms of hazards to our citizens and community members. We would like eventually, as a vision for us, that we can have a toxicologist, a qualified clinical toxicologist, available to take care of every person living in the MENA region. And we mean by that available in the same city, available in the same hospital, available in the same country. And we are working on that, and we need everyone's support and effort to achieve this vision. We've come a long way. As some of you may know this is our 10-year anniversary for MENA Talks. And we are celebrating this in Turkey. It's a very special event for us. And we've accomplished several steps in this process. We have more challenges to come. Although we've done a lot, we still have much more to do. For example, we need to have training programs in the MENA region to train physicians and pharmacists in clinical toxicology. We also want to have recognition of this training by the Arab Board of Emergency Medicine, for example, and have our first Arab Board of Medical Toxicology. We need research and data. We need to collect data about our chemical exposures, about our poisonings, and we need to share this data and learn from it and act on it. We need to have clinical research that is really relevant to our community and society. Clinical research in the US may or may not be relevant to our region, and we need to keep that in mind. We want to provide technical consultation to ministries of health in the region. And we've done that already for some countries in the region, but we want to do more to help them meet the international health regulation implementation requirement, to help them improve the health of their citizens by protecting them from unwanted chemical exposures. We want to have medical student outreach activities.
Thank you very much, Dr. Ziad. Welcome, everybody, to our beautiful country, beautiful intercontinental city. Only one city in the world, intercontinental city, beautiful Istanbul. I hope you enjoy your time in Istanbul, our dream city. Istanbul is like law for the people, and another law for us is emergency department, emergency medicine. Not only doctor in Turkey, and more of population, people love emergency medicine. Because in one day, some department, like my department, take visit more than 3,000 in one day, patient. In Turkey, in 1 year, we have emergency department visit more than 130 million. So this is very big power for us. Without emergency, you can't do anything. And toxicology, very important part of emergency. All toxicologic patients come to emergency department, of course. And for education, for resident education, for fellowship education, very important toxicology. For that, I want to thank to Minitox for this good collaboration, but this is only the first step for the future. I hope we will increase this collaboration, not only with Minitox and with Kazitu and another all speaker and distinguished speakers. Tamam mı bizim işimiz bu arada? Tamam mıyız? Last day, yesterday, Dr. Bejese said to me, you didn't speak 1 hour. For that program is broken. I said, okay, today I will speak 1 hour. If I have time. Okay, when you say finish, Dr. Ziad, when you say, okay, finish, I will finish. But if we will continue the time, okay? Check the time. Emergency medicine, of course, we have some problem. I want to share what is our life in emergency medicine. You know this video maybe? Ya olmaz ya. Acayip. Bu arada bu niye çalışmıyor? Böyle. Okay. We will check everything. Okay. Okay. Violence is okay. Okay. I will go back again. Okay. I try again. Bu çalışıyor mu şimdi? Peki basıyorum. Vaktimiz. Okay, tamam mı? Geçiyorum. Vaktimiz yok. We haven't time. Okay. Çalışıyorsa çalışıyor. Çalışmıyor. Okay. Violence is very important part of emergency. This is about violence video. I have some video about emergency medicine, but of course we have problem. Ses. Okay. That is any important. Okay. Always technology have problem with you. Okay. Okay. It's nothing for. So everything. Who want to work in emergency department? Only crazy people want to work. This is not problem for Turkey and Middle East and North Africa because we have a lot of crazy people in our country. So everybody come to emergency department. This average age for the life. This is for emergency. Bunun kırmızısı nasıl çalışıyor onu da bulamadık. Emergency. We have another. Media is very important part of emergency department, always. And always they say some wrong thing. This, okay, this is, I can't do anything for myself. Ya bir daha asla bana konuşma hazırlamayın. İkiniz bir, Allah'ım yarabbim ya neyse bu kadar uğraştım. Peki, this is, overcrowding is very important for all the world. And this question, why is my bed in corridor? This long ways in the ER, average time, the last time in United States, 100 minutes. We need, of course, some good triage system. But we don't forget the doctor protects all the patient. This is off day for dermatology and radiology and ophthalmology. And this is off day for emergency medicine. Of course, we should be cool and calm in emergency medicine. always. We should see it. We should understand everything is very good. This is from advanced cardiac life support. Wait a minute. Doctor know better, of course, from patient. They continue. Okay. And we should teach the patient too. Okay, as EPAT, who are the EPAT? EPAT have a lot of big organization in the 1 year and different. This is from opening ceremony, but ses gelmeyecek, öyle mi? Ses gelmiyor. Okay. Ses gelmiyor. Peki. This very different opening ceremony. You should listen from website. I'm sorry for that. I don't know what happened with video, okay? And of course, this big organization, every year we increase the number of member and more than 47 country this year we will be together. This is thanks for all this good organization. Okay, this for thanks. Sorry. And for this year we have a lot of speakers, but one of them he will come for the award ceremony. Do you know him? Yes, he is coming. Brugada will join our congress this year. We always, maybe more than 100 people for months prepare this congress. Okay, I will quickly. This is for our congress. We have more than 300 activation in 1 year. Is EPAT. I will finish quickly. In all the Turkey, not only Turkey, for example, this in 1 day in 3 different continents and 4 countries together in 1 day. In April, in 1 day, 6 activation in 3 countries, 6 activation in 1 day. IPAT very big organization. This is all activity in 1 day. We have a lot of organization in abroad, in an international area, Sri Lanka, Ukraine, Georgia, Uzbekistan, Macedonia, all IPAT organization. Again, Georgia, Baku, Azerbaijan, Kazakhstan, and a lot of country, and Mecca, Medina for place of that. We want to increase all emergency care in the world. This is from Budapest, and this year we will go Serbia, Belgrade. And Kappa-Tox, another activity of IPAT, toxicology section. Annually we organize Kappa-Tox. And for example, ECMO and TREBO are very important for toxicology patient too. And not only for health area, for example, in football federation and basketball, we give this education. And Sono School, another international area for IPAT. We building 6 schools together in 6 countries. And these are courses in every area we have another course. This is all the name. We publish 5 journals in one. One of them Asian, Avrasian emergency medicine and toxicology and critical care and case report, and we're waiting for trauma journal too. We have newspaper and TV. Always you can follow all Congress and another activation from TV. And we have story of emergency. Every year we have competition about that, and last year we make emergency sing competition, and this year we finish with emergency short movie. He's singer of emergency. A lot of books together. We give a lot of award. So I want to invite all people, all members, all emergency physicians in the world, this big activation, and IPAT, not only one society, IPAT very big company. We want to make this step to feature together with Minotox, with all society together. Thank you for welcome. Thank you very much.
Thank you, Dr. Başar Cander, for his speech. Now I would like to invite Dr. Bruno Megarbain, Chief of Minotox Scientific Organizing Committee.
Okay, good morning, everybody. I will not be very long. I would like just to thank you, all of you, to have accepted to come to our meeting, and I hope that you will enjoy our scientific program. I would like to thank all the societies, EPAT mainly, who contributed to the program, all the speakers from Turkey and from MENA region and from Europe and the US, for having accepted to participate and to come to Istanbul. And I would like to wish you a very enjoyable stay in Istanbul and very good time in listening to the lectures. And thank you very much. So there are 2 tracks, as you have seen. Please be present, and I would like also to ask the chair to be on time to allow the program to finish on time in the evening. Thank you.
Thank you for Dr. Bruno for his speech. And now I would like to invite Dr. Robert Hoffman, the Chief of Minotox Abstract Committee.
Hello. So like Bruno, I don't have much to say, but I do want to say again on behalf of our organization, thanks to our hosts here in Turkey. This is fantastic, and we're happy to be here. For the abstracts, again this year we've had an increase in the number of abstracts that were submitted, which is really encouraging. we've also had a noticeable increase in the quality of abstracts, including abstracts that are really more scientific than case report and otherwise. It was pleasing to see that these are predominantly actually from Turkey, so many very good, outstanding abstracts from Turkey. As every year, we're limited in the number we're able to have presented. So it's always a difficult decision how many to include and how many to not include. But we're pleased with the content that you're going to see, both in our e-abstracts or our e-posters and then in the oral presentations. One thing that we're looking forward to this year is the best abstracts that we have are going to actually expected to be published probably within the next 6 months. But I think, again, our hosts, as well as everybody who submitted abstracts, and everyone attending, I encourage you to attend the oral research session or take a look at the e-posters when they're displayed. Thank you.
Thank you to Dr. Robert Hoffman. And now I would like to invite Dr. Ashish and Dr. Praveen for their opening speeches.
Thank you, Mina Talks. I'm not going to give any opening speech. Let me make that clear. Dr. Praveen Agrawal, Chief of Emergency Medicine at AIIMS in New Delhi, and I'm Ashish Palla from PGI Chandigarh, Professor of Medicine and toxicologist. Also here representing Asia Pacific Association of Medical Toxicology as the President of Asia Pacific Association. We are here on behalf of Academic College of Emergency Medicine of India and WASEM. We are here to honor our two dear friends, Dr. Ziad and Dr. Basar, and we just want you to please come on to the dais so that we can honor you. This is our traditional way in India to honor our loved ones. So thank you very much.
I forgot that WASEM, very big organization for us, and we are the part of WASEM, and I have very good news about WASEM Congress, but I don't give now. I don't give now, but we are the leader of WASEM together with Sagar and your organization. Thank you very much, and say hello to all WASEM. Thank you.
Thank you. And I also forgot to thank Integral Global Consulting. Mr. Nabil Ahmad, can you please stand up in the back? Integral Global Consulting has partnered with us and provided support to develop the outbreak investigation workshop, which is happening on Friday. It's been a pleasure to working with Nabil and his team, Jackie and Hannah. Thank you.
So now we'll continue with our scientific program, and we have two plenary lectures. So I'm very happy to introduce Dr. Kai Kehe. He's from Munich. He's a specialist of chemical poisoning, and he will talk about sulfur mustard poisoning toxicity and management. Kai worked with Horst Thiermann in the Bundeswehr in Munich, and he performed several experimental studies on chemical weapon toxicity, and he has probably very interesting original data regarding sulfur mustard complications in case of exposure, and he will communicate this. And I think that this is really an important issue for us in the MENA region. Thank you very much, Kai, coming to Istanbul.
Yeah, thank you. First of all, I have to confess that this is the first scientific session which was introduced by the Pirates of the Caribbean main theme. I hope that you are not disappointed that I'm not Jack Sparrow, Captain Jack Sparrow. I'm Colonel Kier from Germany, and I'm a medical doctor and a specialization in toxicology, and I started my research with sulfur mustard back to 1996. And now I'm head of the medical CBN defense in Germany, and and I want to thank the organizers that they give me the opportunity to give you to share you some experience from Germany about sulfur. Pointer. I don't know whether you can see the pointer. Very low light. No. Okay, perhaps I can describe it. Huh? First of all, I want to introduce you a little bit with sulfur mustard. Sulfur mustard is an old chemical warfare agent introduced in the battlefield, unfortunately, by the Germans in the First World War. It is an oily liquid, which is very important. It has a boiling point, 215 degrees Celsius, and it has a vapor pressure, which means that in humid conditions, it produces some important vapor, and it is heavier than air, and what is the main characteristic why it is used as a battlefield agent, it easily can cross the clothes. This is what I show you later in the cases I will present. Synonyms are ypperit or Senf gas, which is the German name, or mustard gas, which is the English name, which is a typical odor, which is caused by the technical impurity. The highly distilled sulfur mustard has no real odor, but technical produced mustard has a typical mustard-like or reddish-like odor. And it's also called H, or abbreviated HD, which is the abbreviation from Hansstoff, also Hans were the name of the Germans in the First World War, and the distilled version is HD. This is the NATO abbreviation. The molecular toxicology, or what we think one of the most important events in the cell is alkylation of the DNA. You can see sulfur mustard, which can produce a sulfonium ion, which easily can react with guanine in the DNA to form a monoadduct, which you can see at the lower part of the slide. As it has two reactive sites, it can form also crosslinks. It can crosslink the DNA. And the crosslinks of the DNA is the main reason why cell division is impaired. And, and this can cause DNA breaks and also holds responsible for some mutations, what we believe. And from this molecular toxicology, you can easily understand that rapidly dividing cells are mostly affected. And where are rapidly dividing cells? These rapidly dividing cells are, for example, in the skin at the stratum basale. The keratinocytes are the most vulnerable part of the body, and later also the blood stem cells. But sulfur mustard does not only react with the DNA. It can react with each part of the cell. It can react with even with water, forming thioglycol, which you can measure in the urine, for example, as a simple biomarker. It can react with the RNA, with proteins, and also with enzymes. For example, hexokinase is one of the most susceptible proteins. Therefore, sulfur mustard can impair the glycolysis in the cell. which was found in the 40s. Taken together, when rapidly dividing cells are affected mostly and glycolysis is inhibited, this is one of the two reasons why this agent is a prototype of modern chemotherapeutic agents, like, for example, cyclophosphamide, which has also the reactive ethyl chloride group. And we believe that DNA mutations can cause cancer, but I can show you later more effects, and also the long-term effects are important, and we are still, it is a matter of ongoing research what is the most relevant mechanisms. But now I want to focus on keratinocytes. Keratinocytes roughly can have several roads to death. They can, after a sulfur mustard injury, can go into necrosis. They can die via apoptosis. You can find reproductive cell death and also programmed cell death in form of terminal differentiation. And this is important because this is an effect on wound healing. First of all, the forming of the wound is an effect of apoptosis and necrosis, and the wound healing, which needs proliferation of cells, is impaired. And also, you can find a higher rate of differentiation in the surrounding tissue. And this is the reason why sulfur mustard burns, who looks like, for example, they look very similar to sunburns or chemical burns, but this molecular mechanism is the reason why sulfur mustard burns heal more slowly than, for example, compared to sunburns. A sulfur mustard burn needs around about 1 month to get closed. And these are the macroscopic cutaneous signs. You can find blisters, ulcerations, and erythema. The intoxication starts after several hours with erythema. You can see erythema when it is a vapor exposure on the front chest and also in the axilla and then the genitoanal region, which are moist skin regions. The vapor crosses the sclerosis, and when the skin is moist and there are a lot of hair, it can go deep into the skin and cause this damage, and it starts with erythema, and after a while you can find blisters, which you see on the upper left side, which are thin walled blisters, and then when it is a severe burn, also ulceration. And interestingly, the microscopic feature of this sulfur mustard burn is a clear split between epidermis and dermis. Therefore, the separation of the epidermis from the dermis is the most striking histological feature, and it is still a matter of debate why this small molecule can cause such a specific histopathological sign. And when you look more in detail, you can find a split in 3 regions, which are in the region of the hemidesmosomes and the lamina densa. You can see that where you see the red line, and where the red line is, there is the split of the epidermal junction. And this correlates very well with laminin 5 degradation and MMP9 activation. MMP9 activation is, I'll come back to this later, which is possibly a therapeutic target. The long-term effects are also very interesting. They are mostly published by our Iranian colleagues, and they describe neoplasms, mostly sherry-like hemangioma in the, on the skin, on the exposure sites, and also some forms of hyper and hypopigmentation of the skin, which you can see on the right side. And also various forms of scarring can occur and can cause disabilities in the patients. But keep in mind, Sherry-like hemangioma is an important sign, which means that vessel disturbances are a very important sign. These are the eye lesions, which start with photophobia and inflammation, and this and a blepharospasm, and which is so painful to the patient that they cannot actively open the eye. And when you look at the pictures from the First World War, you can see so-called blinded soldiers guided from the battlefield, and this is the reason what they have encountered, that the eye is a very susceptible organ, and they are blinded. Luckily, 80% of the patients do not suffer from long-term effects, but 20% of them suffer from some corneal erosions, which can persist over decades. And this is mostly responsible to the limbal stem cell defect, which occur in these patients too. And the Iranian medical community published some data that after transplantation and also with limbal stem cells, you can achieve a better outcome for the patients. And sulfur mustard-induced lung injury is also a severe injury. It starts with coughing, with some infections and inflammation, and also a so-called pseudomembrane formation, which can be a life-threatening effect. Pseudomembrane formation means that the trachea, the epithelia of the trachea can also form a blister, and the epithelium gets off the wall and can obstruct airways. After a while, these defects are replaced by, not by an epithelium with mucociliary function. It is a normal epithelium. You have no mucociliary clearance, and you have a scarring, which you can see on the downstairs on the left side, which is red encircled, and you can see a scarring and narrowing of the airways, which can impair the patients very well. I've had the opportunity to see these patients in Tehran, and some of them were not able to walk 10 meters without shortness of breath, which is really, they were really in bad condition. I think this is the most disabling late effect in these patients, and we have to take care of them. And also, you can see blood vessel disturbances and malformations in these patients, and when you make a bronchoscopy, they start bleeding. In late effects, they start bleeding, and they have also coughing with blood, but this is not a sign of malignancy, interestingly. And these are patients from nowadays, this is a patient from Syria. Unfortunately, in the southern part here of Turkey and Syria, chemical warfares are used, and I have to thank here the Turkish medical doctors that they take care of these patients, and they do a tremendous job, and they publish also and share also the data with us, which is very important to learn about this poisoning. But I do not want to focus on these patients. I want to show you some patients from Germany. As you've seen in Syria, there were a lot of sulfur mustard present, and as Syria signed the OPCW treaty, all the chemical warfare agent stockpiles, especially sulfur mustard, were destroyed by a ship, the Cape Ray, from US. And the hydrolysis product was shipped to Germany to get rid of these waste and of the burns. And this is the facility in Germany where it was done, and you have these barrels with the waste, and if you destroy 99.9% of a chemical warfare agent, 0.1% is still active. You have to keep it in mind. And this has happened here. When they put it to the oven, was a higher temperature, and there was a malfunctioning of burning. 3 persons were in the room. The oven temperature was 150 degrees, the room temperature over 30 degrees. And then the active sulfur mustard, which was still present, started to evaporate, and we estimated an exposure time of 15 minutes. This is the equipment we normally use. The workers had a mask on, had gloves on, and also some boots, but no adequate PPE, no adequate personal protective equipment. And this is why this agent was developed for. In the First World War, all the soldiers were equipped with a gas mask, but this agent was designed to cross the clothes, which I mentioned before. Therefore, because of this non-proper protection, the patients get a burn, which looked like a sunburn. The symptoms developed 2 to 4 hours later and started with the erythema of the chest and the neck. And this is some pictures of them, and also the buttocks. You can see some blister formation, and also at the arms and at the axilla, which was, and also where the gas mask was not present in the hair. Therefore, this is very, very typical, and I have to go back, unfortunately. And they were treated with flamazine, which is a sulfonamide silver cream, corticoid, and diclofenac oral. This was quite good, but from the point of the patients, not good enough. They still suffered some pain, especially from the genitoanal, or from the scrotal effect, because this is also a very moist region of the human body and has a lot of hair, and therefore this is very susceptible to sulfur mustard. And when there's a burn, it hurts very much, and the soldiers cannot march anymore. This is one of the reasons why it was very disabling for soldiers. And we had a discussion in Germany whether this was really a sulfur mustard burn. Some guys argued this could be also perhaps a chemical intoxication of the waste. And the lab of Professor Thiermann is an accredited lab from the OPCW, therefore this lab can confirm sulfur mustard poisoning via degradation products in urine, which is from the beta-lyase degradation product, which is more, this is more specific than thiodiglycol, which I mentioned before, and also sulfur mustard albumin adducts. And as you can clearly see in the depicted picture, is that there were some distinct pattern and also specific adducts in these patients. Therefore, we can be sure that these burns we observed in these workers were really, really sulfur mustard burns. And taken together, you have a typical clinical picture. You have a sunburn like erythema. You have thin-walled blisters, and we were able to confirm the diagnosis with a specific lab diagnostic. And now I want to come to another important issue, that is epigenetic. Epigenetic is, for those who are not so familiar with this, is very important to maintain tissue identity. For example, if skin cells divide, they remain skin cells. And if kidney cells divide, they remain kidney cells. But all of the cells, all these cells have the same identical DNA code. And why can a cell be sure that it is a skin cell and not a kidney cell? This is because of epigenetic. And Epigenetic are several marks on histones and DNA, and these markers are both responsible for the tissue identity. And can also, we have writers and erasers and readers of these marks, and if this epigenetic code is disturbed, for example, by toxic substances, it can, for example, activate oncogenes. And this is, beside mutation, another reason for neoplasms. And therefore, we digged a little bit deeper into this research, whether sulfur mustard can also induce epigenetic disturbances. And we have several proteins and which can hold responsible for these, as I showed, for these markers, which are stick to the DNA and the histones. And I do not read all these epigenetic modulators. Perhaps to keep in mind that the DNA methyltransferase is important, as well as the histone acetyl transferase. And when you look at the color code, we found an upregulation of several of these modulators in cells which are treated with sulfur mustard, with 1.01 micromolar sulfur mustard or 0.5 micromolar sulfur mustard. To give you a feeling what this dose means, 100 micromolar is the so-called blistering concentration. This is factor 100 below the blistering concentration. And exposure with 1 micromolar is a light reddening of the skin. And this light exposure really upregulates DNA methyltransferase. Therefore, we can expect some disturbances in the epigenetic code. And I show you this in the patient. We have had a patient in Germany, 2012, which was a lab technician who unfortunately synthesized sulfur mustard in a lab. And this synthesis did not went well, and there was a leakage in his synthesis apparatus, and a small drop of sulfur mustard hit his lab coat. A small drop hit his lab coat. And this little drop was able to cross the clothes, to come to his belly, and when it touches the belly, it starts to evaporate. And when the evaporation starts, the mustard gas will diffuse to all regions it can reach. And this is what happened. This is where the drop hits the skin, and you see the arrows where it can move on. And therefore, even if it is a little drop on the skin here, you have a reddening everywhere where there's some space below the clothes. This is a really interesting picture. And to show you the outcome of the patient, you see the a little bit disappointing that I have no pointer here. At one day, you have a reddening and a blistering formation, and it's on day 8, you see a severe defect on the skin. And this huge defect and huge burn, which showed no tendency to heal because of the, as I told you, you have a reproductive death. The skin cells are at the root edge are not dividing, and therefore you had to get rid of these skin cells. And this is done by surgery. And it was excised, this region, and then the patient received a skin transplant from the thick, which you can see on day 20. And then 4 weeks, 8 weeks, 15 weeks, and 1 year later, you can still see the defect. Some other pictures, it's 15 weeks after split skin graft, and also he had a sign on the left forearm forearm which was not treated. You can see the difference. And this is 1 year after it. And then we were interested whether there were some epigenetic changes, as I told you before. And this was a patient who was worthwhile to investigate, because we were able to get some skin samples from exposed sites, from vapor, which is the upper red arrow, and the wound edge, which is the lower red arrow. And you can see a upregulation or a higher content of 5-methylcytosine, which is a DNA tag on the DNA, which is a tag, a cytosine tag, a methyl tag on the cytosine of the DNA. And this is really a striking upregulation. And when you look at the center of the transplant, which was from the unexposed side of the body and transplanted to this region, it is no significant upregulation. Therefore, 1 year after exposure, we can clearly see an upregulation or a higher methylation rate of the DNA, which can cause perhaps some late effects and which can be perhaps a cause for DNA, neoplasms, which can perhaps occur, or these cherry-like hemangioma, which I described before. Now, come to the end. This is I've summarized the gross pathology, microscopic pathology, and the molecular pathology. And when you look at these events, I will skip forward. We have several potential therapeutic options. You can use scavengers like N-acetylcysteine. You can modulate cell death by caspase inhibitors or PARP inhibitors, which was not successful. You can try to use MMP inhibitors, like, for example, doxycycline, to prevent blister formation. Also inflammation, anti-inflammatory drug like steroids, non-steroids, and analgesia is important in surgery. And up to today, only these options are still in use at the moment. This is N-acetylcysteine, which is believed to be has to be some scavenging effect. Steroids, non-steroidal anti-inflammatory drugs like diclofenac, or it's also important to have some analgesia and also surgery. And the way ahead is, if you look at epigenetic modifications to have some therapeutic options to prevent, for example, long-term effects. It is interesting that at the moment we have development of epigenetic modulators. This is mostly in the context of chemotherapy, and we tried to use a DNA methyltransferase inhibitor, because this was what we have found in our patient, that the DNA methyltransferase was upregulated, and there's a drug which is called decitabine, and in cell culture it is very effective to prevent these methylcytosine, but in fact it is for clinical use it is not possible, because this is also a nucleotide and has some similar side effects as sulfur mustard by itself, and therefore I think it's not useful, but as a proof of principle it is worth to think about these kind of drugs for further development and therapy. And now I'm at the end of my talk, and if you have some questions, I'm happy to answer it.
Okay. Are there any questions from the floor? Ziad, the first question.
Thank you. Thank you, Dr. Kehe, for a great presentation. I'm involved in a NIH-funded center for arsenicals, for lewisite.
Yeah.
I'm not a bench scientist. I'm more involved in the education side. But I want to ask you, our researchers are finding a role for the unfolded protein response signaling. So the unfolding of proteins causing the damage, the cell damage. And then we are looking at antidotes, we call them chemical chaperones, that can stop the unfolding process. Have you seen anything like that inside in the sulfur mustard mechanisms, or are they different mechanisms? Between lewisite and sulfur mustard?
Yeah, first of all, lewisite and sulfur mustard are very distinct. They have some similarities in the clinical pictures, but they have a very different molecular toxicology. And lewisite attacks the pyruvate dehydrogenase. And as you mentioned, chaperones, I think this was also investigated in sulfur mustard injury, but I'm not aware of any further experimental data on this issue. It is still worth to look at it, because sulfur mustard has such a broad mode of action, and you cannot exclude what is really going on. But sometimes it's very difficult to identify what is the most relevant mechanism. This is true. But I'm not aware that somebody has really done research on this. Yeah. Please.
Thank you. My question, are there any clinical bronchogenic carcinoma because of my people exposed to sulfur mustard during their war with ISIS? And of course, we gave them anacetilcysteine and capsule.
I'm sorry, I can hear you.
Can you speak more loudly?
A little bit more up or more directly?
Yeah. Are there any clinical data that support that the use of anacetilcysteine will decrease the bronchogenic carcinoma in the future? Or just it is from theoretical point of view?
He's asking if anacetilcysteine can be used to prevent the long-term effects.
Oh, yeah, effective. I can tell you what I believe. As I told you, sulfur mustard is a very lipophilic drug. There are some data which are published which can show that sulfur mustard is stored in the lipid depot, and there it can be redistributed. And sometimes when you look at the toxicokinetic, you can see a degradation and then an up and down. And as acetylcysteine is a scavenger with an SH group, it can catch free sulfur mustard, but it has to be administered very fast. And when this scavenging effect is, when you administer it very fast and you have this scavenging effect, then it can also prevent long-term effects, and then it is useful. However, most of the patients do not reach the clinic in time. And this is perhaps more for a military setting when you use it. That the enemy is using perhaps sulfur mustard, then the medical doctors in the field have acetylcysteine readily available, and then it would be of advantage. But in, for example, Syria or a terrorist attack, when there's a population hit which is not protected and you need a lot of time to get it into the hospital, I don't think that acetylcysteine is really of beneficial effect.
Thank you.
Thank you for your presentation. It was interesting to me. I have a question about the decitabine. You mentioned about the targeted therapy. Yeah. Do you have any drug repurposing research studies for decitabine in your institution for the sulfur mustard poisoning?
We are at the moment launching a new program and try to fund it, and then perhaps we can dig a little bit deeper. But at the moment we have only data to decitabine.
Okay, thank you very much.
I have not understand. Your center was in charge to destroy the sulfur mustard from Syria. That's it?
It was a degradation product. The sulfur mustard was hydrolyzed on the ship.
On the ship.
The Cape Ray.
Okay.
And as it, they stated that 99% was destroyed, the waste was shipped to Germany. But there was still some active agent in it because there was 0.1% left. Which
So
was
it was brought to your center?
Yes.
For which purposes?
To burn it.
To burn it.
Yeah.
And how?
To destroy it. They
and how was it possible that 2 employees were contaminated? Because you are.
This was a. They were silly. I think.
Because I thought that the Bundeswehr is very specialized in this field.
We were also very surprised about this fact, I must confess. Normally, they stick to the rules and they have to wear a proper equipment. But unfortunately, it was too hot. Yeah, this is the reason. It was too hot for them. And then they did it the easy way. And this was a lecture they've learned.
So that means that even in the most famous center that is specialized on chemical warfare and with trained personnel, it's possible to make mistakes and to be contaminated.
Everywhere where a human being is, you can have an error. That's also machines can make errors.
And by burning the product, you eliminate 100% of everything.
Normally, it was signed that it was totally destroyed, and this is a question: how clean is clean, or how much it is destroyed? And as we have learned from this lesson, is that when we destroy most, really 99% of the agent, there's still something left on the walls, for example, of the containment. That because it's very sticky sulfur mustard, that can survive hydrolysis. And this is when you get it off, it can evaporate. And if you have several tons, and we speak about 100 tons, then you have a little amount.
Okay.
Which is.
Last question, please.
Thank you. I was thinking about treatment with cyclophosphamide, which is a much less toxic alkylating agent, but still, I think, more or less the same mechanism.
Yes.
And of course, we hydrate those patients. I didn't see that as a treatment, or for acute emergency treatment. Would that be one of your suggestions? And the other question is, do you think there's enough evidence now to recommend skin grafting in essentially all affected areas after 1 year? I know you've done it. It looks like a good idea. Would you recommend it universally? So 2 questions, sorry.
Yeah, two questions. As we have seen, these patients, especially the last one, had a quite heavily burn, but there was no need for hydration. It has a balanced fluid. I think it's worth to think about it. But I haven't read it in any recommendation so far. That this is necessary. And the second question about these skin grafting. If you have a single patient with such a severe burn, you can do it, but I would not recommend it universally. For example, the first patients I've shown, this were like sunburns, and they quickly recover, and there's no need to make any transplant. But when this is a deep burn, which touches also the dermal tissue, then I think there's a need to make a transplant, because the wound healing is very much impaired in these patients. Also, because we are a Western country and most of the people are really often concerned. In this patient, the last patient, he had really a concern about neoplasm. He Googled sulfur mustard and has seen some reports about malignancies, and therefore he underwent a second surgery, and it was, even this transplant was excised more deeply down to the muscle, because he was so scared about it. Yeah. By the way, I asked him, where did you get this, the synthesis route from? And he answered from Wikipedia. I can say that I tried to delete it in the German version of Wikipedia several times, but it pops up from other guys and you cannot get rid of the information. Yeah? That's the internet. Yeah.
Okay, thank you very much.
Thank you.
Guidelines, please.
Thank you very much.
I'm sorry, I would like to introduce him. He is chair of a scientific committee of APAT, and he's from the Department of Clinical Toxicology, Lokman Hakim Hospital, Shadid Behçeti University, University of Medical Sciences in Iran. Okay.
Thank you very much for inviting me, and thank you very much for organizing committee to have this great conference and sharing our knowledge and our experience together. Okay. No, this is off.
It is off.
Could you please turn it on? Okay. No problem.
Sorry, Hussein.
No,
you have to turn your back. If you prefer to sit here, you have the screen.
No, that's okay. That's okay. Thank you. Actually, why we are trying to describe the methanol outbreak here, because the MENA region, including Iran, Turkey, Afghanistan, and other neighboring countries, are involved in methanol toxicity outbreaks from recent years, and we had a lot of fatality after those outbreaks, and we had no guideline how to manage them. So I'm not focusing on the personal treatments of every patient. I'm focusing on public health issues of methanol outbreaks and how we as a physician should deal with methanol outbreaks. So it doesn't work. So I should declare that I have no conflict of interest. The importance of this issue is that if we work